1. The interface between psychiatry and obstetrics and gynecology. An introduction. Nada L. Stotland, M.D., M.Ph. Donna E. Stewart, M.D., D.Psych, FRCPC. Since the first edition of this book was published, scientists have devised techniques for genetic testing of pre-implantation embryos and for the gene mutations responsible for some familial breast and ovarian cancers. Sextuplets have been brought to term. Knowledge of lesbian health and health care has grown. HIV/AIDS has continued to spread disproportionately fast among women, especially African American women. The provision of health care and the relationships between patients and health care professionals have been drastically altered by managed care entities. Increased and better screening has minimally decreased breast cancer deaths. Fewer women have access to abortion services. We thank the chapter authors for bringing the results of several years of new findings to this compendium of issues at the interface of psychiatry and obstetrics and gynecology. This interface may be conceptualized narrowly, as a subspecialty of the psychiatric study of somatic symptoms and diseases, Alexander 1950. From another perspective, however, psychosomatic obstetrics and gynecology includes a realm both broad and deep that begins with men's and women's feelings and behaviors related to female reproductive physiology, Benedict and Rubinstein 1942. It ranges from the events surrounding conception or its 1-2 psychological aspects of women's health care, second edition frustration, to reactions to terminal gynecologic malignancies. It encompasses the joyous embodiment of romantic love and the enactment of the most brutal victimization. Although only a small percentage of psychiatric and other mental health professionals explicitly devote their clinical or academic practices to this area, virtually all encounter these issues in their work with patients and their families, with medical students, and with residents. Although many organ systems and their pathologies are associated with psychologic meanings, dynamics, conflicts, and symptoms, the relationship between psychiatry and the reproductive system is especially rich. Hysteria originally designated a psychiatric illness caused by the wanderings of the uterus from its proper site in the pelvis. The term was coined over 2,000 years ago and was still in use in the late 20th century, Pomeroy 1975. Long after dissection had demonstrated the realities of the anatomy of uterine connections, Sigmund Freud linked hysteria to forbidden sexual wishes and sexual frustration, Freud 1931/1961. In 1891, JAMA published an article titled "Can the Gynecologist Aid the Alienist in Institutions for the Insane?" 1891/1991. Portions of this article were reprinted for historical purposes in 1991. The author or editor, who is unnamed, cites the work as alleging a link between the functions, dysfunctions, and removal of the ovaries and uterus and psychiatric illness and treatment. A quote from the article asserted that oophorectomy may be relied upon generally to cure insanity limited to the menstrual period, p. 3230. This statement presaged attempts a century later to treat premenstrual symptoms. Other recent controversies are also foreshadowed. Bemoaning the indisposition of alienists to accord the gynecologist a place in cooperation with them, the article explains, there was said to have been too keen a desire to try oophorectomy as a panacea for all kinds of insanity in women. There was also an effort made to introduce female physicians upon this tide of so-called necessity, and thus were blended disadvantageously questions of public policy, or expediency, with what should have been scientific inquiry. Can the gynecologist aid the alienist in institutions for the insane? 1891/1991, p. 3230. Clinical work and experimental studies performed in the years after Freud's major contributions have disproved some of his assumptions about female psychosexual development, sexuality, and psychopathology. At the same time, new facets of patients' sexual histories prove to be as important in the etiology of psychiatric illness as those asserted in the past, albeit in a different way. Many patients with personality disorders, post-traumatic stress disorders, and other diagnoses have histories of sexual and physical abuse. The interface between psychiatry and obstetrics and gynecology. 3. Sexually transmitted diseases and new reproductive technologies challenge the psychologic coping mechanisms of patients and the skills of their psychiatrists today. AIDS has introduced the possibility of a serious illness or a lingering death into many sexual encounters, and into gynecologic care. The discrepancy between knowing the methods by which disease transmission can be reduced and implementing those methods in interpersonal behavior remains unresolved. Women and children are the fastest growing populations infected with the virus. In order to design and implement strategies to reduce the transmission of HIV, public health workers must be informed of the psychology, sociology, and anthropology of female reproductive behavior. See Chapter 16. Breast and pelvic malignancies raise other psychosocial issues. The exchange of knowledge between psychiatrists and obstetricians/gynecologists, OB/GYNs, may improve the diagnosis and effective treatment of breast and gynecologic malignancies by identifying the factors that deter women from self-examination and regular medical screening. An awareness of these factors will help the psychiatrist enhance patient compliance by helping patients understand and cope with their fear of pelvic examinations, and it will help gynecologists adapt examination techniques to minimize emotional distress. In other areas, improvements in outcomes and discoveries at the cutting edge of theory and practice may have paradoxical effects. Among the middle and upper classes, maternal and perinatal mortality rates have decreased and anesthetic techniques have improved. Parents-to-be are informed of and participants in obstetric decisions. Thus every couple demands to have a perfect childbirth and a perfect child, and failure to meet those demands has, at least in part, contributed to 80% of obstetricians in the United States having been sued at least once for malpractice. Charles and Kennedy, 1985. These demands for perfection often begin not only before birth but also before conception. Astounding, previously unimaginable developments in reproductive technology seem to offer the possibility of biologic parenthood to every infertile woman or couple. Christie and Pawson, 1987. Yet these developments pose a host of problems, the resolution of which will require knowledge of biology, psychology, sociology, anthropology, ethics, and law. But the clinical dilemmas face psychiatrists in the field right now. Dick Stein, 1990. At what point in the diagnostic and treatment process for infertility do continued expense, life disruption, and bodily intrusion constitute an obsession? How can the psychiatrist help the patient and the treatment team make prospective policy and ongoing decisions? What ethical and psychiatric issues are raised by the voluntary and paid donations of gametes, embryos, and gestational for psychological aspects of women's health care? Second edition, Services of One Woman to Another, Lantis, 1990. What roles, if any, should psychiatrists play in screening, support, and treatment? Unprecedented family constellations could offer us the opportunity to discern how family dynamics and psychologic development are shaped by genetics and by the environment. The dialogue between obstetrics and gynecology and psychiatry, and among OB/GYNs, patients, and psychiatrists, is interwoven with social change. Stotland, 1988. Tensions are reflected in language, doctor and patient, with their rich mutual obligations founded in age-old relationships, become provider and consumer. Primum non nocere, first, do no harm, becomes caveat emptor, let the buyer beware. OB/GYNs are often women's primary care physicians and the experts on their most intimate bodily parts. As such, they become the object of the strong negative and positive attitudes of their patients. They are transferentially endowed by their patients with magical technical and emotional powers. In turn, most obstetricians' offices are bedecked with photographs of infants they have delivered, testimony to a mutual emotional investment in their patients that goes beyond the skills of the accoucheur. Women have also reacted with vituperation to the actual and perceived arrogance, insensitivity, psychologic ignorance, and authoritarianism of OB/GYNs. Laypersons and medical gadflies have published books with titles such as Male Practice, How Doctors Manipulate Women, Mendelssohn, 1982, Seizing Our Bodies, The Politics of Women's Health, Dreyfus 1978, and Immaculate Deception, A New Look at Women and Childbirth in America, Armed 1975, alleging and sometimes documenting negative physical and emotional effects of gynecologic interventions, some of which are unsupported by scientific evidence. The book Our Bodies, Ourselves, Boston Women's Health Collective 1984, conveys the message that the self-esteem and physical health of women can be improved by knowledge about their own anatomy, physiology, pathology, and treatment, that this knowledge need not remain the arcane preserve of physicians. Social scientists and other professionals have documented physicians' demeaning attitudes toward women patients in articles such as A Funny Thing Happened on the Way to the Orifice, Women in Gynecology textbooks, Scully and Bart 1973, and The Training of a Gynecologist, How the Old Boys Talk About Women's Bodies, Hellerstein 1984. In some women's consciousness-raising groups, women examine their own and each other's bodies in a more prosaic and immediate attempt to demystify, inform, and accept themselves. Self-help groups teaching and performing menstrual extraction and suction abortions as well as routine examinations moved into the interface between psychiatry and obstetrics and gynecology. 5 Previous professional preserve. Other self-help or consumer groups continue to focus on providing information, support, and preparation for reproductive experiences such as infertility, pregnancy, childbirth, and breastfeeding. Bing 1973, La Leche League International 1987, Seiden 1978. Today's alternative approaches include baby massage and prenatal yoga. In this environment, OB/GYNs practicing in good faith have been hard put to fathom the skepticism, rage, and litigiousness of their patients. Few, if any, specialties require such mastery of a combination of ever-increasing scientific knowledge and technical skills in addition to long hours, legal liability, and exposure to clinical situations of overwhelming emotional intensity. Friedman 1986. Training programs in obstetrics and gynecology include little instruction in psychodynamics, psychopathology, and interpersonal skills, either in formal didactics or by example. Often, the patient population in teaching hospitals consists of disadvantaged women whose social circumstances distance them from the upper-middle-class doctors in training, prevent them from seeking timely care, disincline them to complain about their care, and interfere with the pleasures of a successful outcome, as when a resident delivers a baby to an overwhelmed young teenager who will take it home to a dangerous housing project. Trainees are brought face to face with the medical outcomes of social problems, such as domestic violence, rape, incest, and sexual abuse, that they do not have the time, knowledge, support, or resources to address. Adler 1972. These factors conspire to increase their focus on the cognitive knowledge and technical agility that their mentors reward. The changing circumstances of medical practice further erode opportunities for doctors and patients to get to know and trust one another. Managed care, with choices of plan made at the employer rather than consumer level, inhibits or obliterates patients' choices of physicians. Patients make frequent geographic moves. Doctors have little motivation to understand their own responses to patients and medical situations, to examine patients' responses to them, or to develop skills that put patients at ease. Physicians practice in groups and subspecialties, both of which decrease continuity of care. In fact, it might be said that the sicker and/or more distressed a woman is, the less likely it is that she will obtain care from a physician who is familiar with her personality, defenses, usual responses to illness, family, religious, and social supports, and other coping mechanisms. The psychiatrist's role in providing this sort of information and enhancing these skills is ever more important under these circumstances. Dunbar 1954, Karasu et al. 1979, Lepowski 1986, Stotland and Garrick 1990. 6 Psychological Aspects of Women's Health Care, 2nd edition. Contraception and induced abortion are areas in which personal feelings about sexuality, reproduction, and gender roles as well as religious and cultural rules and values color and politicize medical practice. Contrary to popular belief, Abortion has been practiced throughout recorded history and was permitted until a few centuries ago by the Roman Catholic Church, Newman 1991. New physicians, sworn by the Hippocratic and other oaths to protect life, are arrayed opposite each other as they define life and the priorities of one form of life over another. Legalization and the improvement of medical techniques have reduced the gynecologic complications of induced abortion to a small fraction of those of childbirth. The same is true for major psychiatric sequelae. The decision to terminate a pregnancy is a weighty one, however, necessarily made under the pressure of time and best made with support and without coercion in either direction. Governmental restrictions on abortion limit the options for poor and psychiatrically ill patients and the professional autonomy of psychiatrists and gynecologists to discuss those options with their patients. Webster v. Reproductive Health Services 1989. This volume is a clinical and theoretic sourcebook for the practitioner facing the many universal and specific issues of obstetrics and gynecology that arise in psychiatric practice. These issues may include presenting symptoms, as when a patient is referred for care after suffering a rape or being diagnosed with infertility or malignancy. In other cases, the role of the obstetric/gynecologic event or condition in the psychiatric illness is not volunteered or even recognized. Sexual abuse, a frequent feature in the history of patients with several major psychiatric disorders, may require particularly informed and expert diagnostic skills or several years of building trust in a psychotherapeutic relationship to reveal itself. The fact that a psychotic, manic, or depressed inpatient is postpartum may be apparent only when one learns her children's ages from the family or reproductive history. Feelings about a hysterectomy or the loss or termination of a pregnancy may play a role in the dynamics of a current conflict. Women also have questions and concerns about the psychiatric aspects of menstruation and menopause. We hope that this work will remind readers of the many rich connections between psychiatry and obstetrics and gynecology and will inform their research, teaching, and clinical work. The choice of topics to be addressed in this book was determined by three guiding principles. 1. What issues specific to women are encountered by psychiatrists and other mental health workers? 2. What psychologic issues should be considered in providing women's health care? 3. What are the special problems seen in a consultation or liaison service to an obstetric/gyneco? The interface between psychiatry and obstetrics and gynecology 7 Logic Program. Notman and Nadelsons, 1978. Pioneering work in the area of women's health is an excellent starting point, but the past 2 decades have seen rapid technologic and theoretic developments. Thus, a fresh look at some of the old issues and an attempt to explore some of the new dilemmas are required. Nowhere is this more apparent than in the rapidly developing field of new reproductive technologies. We have tried to emphasize those topics in which new developments have occurred. We have been guided in our choice of subjects by our clinical work, in which we daily see women referred by physicians for problems specific to their gender. Our research in psychosomatic obstetrics and gynecology and our teaching of medical students and residents has helped to focus our attention on those issues that are most common and problematic. This book is divided into 3 sections: pregnancy, gynecology, and general issues. The pregnancy section consists of 7 chapters covering topics ranging from the psychology of normal gestation to physical and psychiatric complications during and following pregnancy. Robinson and Wisner's chapter on fetal anomalies, Chapter 3, addresses the new prenatal diagnostic techniques as well as the management of dynamic issues that emerge when abnormalities are detected. In Chapter 5, Stewart and Robinson discuss the use of psychotropic drugs and electroconvulsive therapy in the pregnant and lactating patient. Dell's chapter on adolescent pregnancy, Chapter 6, explores the etiologic factors and treatment strategies for this population. Leon's chapter on perinatal loss, Chapter 8, describes the emotional reactions of parents bereaved by miscarriage, stillbirth, or neonatal death and suggests approaches for treating clinicians. The gynecology section consists of 8 chapters dealing with both common gynecologic problems and some of the more controversial issues such as induced abortion and the new reproductive technologies. In Chapter 9, Jens Vold and Dan explicate the role of the menstrual cycle in exacerbating as well as precipitating psychologic symptoms in biologic and social contexts. Sherwin gives a comprehensive account of the psychiatric aspects of menopause in Chapter 12 and reviews the sometimes confusing literature on exogenous hormone administration. In Chapter 13, Steege and Stout discuss the assessment of chronic pelvic pain and its management by the gynecologist and/or mental health professional. In Chapter 15, Burns presents a thoughtful overview of the psychosocial concomitants of gynecologic malignancies as well as the emotional demands on the oncology team itself. Finally, in Chapter 16, Moore and Smith consider the special meanings and implications of HIV/AIDS for women. 8 Psychological Aspects of Women's Healthcare, 2nd edition. The General Issues section addresses several timely topics. We have tried to present a broad and balanced picture. A psychodynamic perspective on reproductive choices and development is offered by Notman and Nadelson in Chapter 17. Segraves and Segraves, in Chapter 18, offer the latest wisdom on sexuality, sexual dysfunction, and sex therapy. Substance Abuse, Chapter 20, and Eating Disorders, Chapter 21, are other issues too frequently overlooked in obstetrics and gynecology practice and are discussed here by Bloom and Russell and by Stewart and Robinson, respectively. Anderson and Farrar's chapter on breast disorders and breast cancer, Chapter 22, is especially important in this era when uninformed fears of breast cancer influence women's compliance with medical recommendations and considerable controversy about diagnosis and treatment persists. Violence against women, in the form of spousal abuse, rape, and incest, has a major impact on their physical and emotional health. Recent findings have altered both diagnostic and treatment approaches, as discussed by Warshaw in Chapter 23. Saved, in a chapter new to this edition, Chapter 24, discusses the special and insufficiently acknowledged healthcare issues for lesbian patients. The rapidly changing healthcare scene adds new ethical and legal issues, discussed by Nadelson in Chapter 25, to the already complex world of women's health. In Chapter 26, Myers addresses a topic often missing in works of this kind, the reactions of men to women's reproductive events. In Chapter 27, Stotland addresses the provision of psychiatric consultation and liaison to obstetric and gynecologic services. Finally, Fulalove addresses the meaning of minority status in Chapter 28. This book can be used for teaching medical and other healthcare students, as a reference for residents in psychiatry and obstetrics/gynecology, and to inform the clinician who is working to improve the care provided to women patients. References: Adler G., Helplessness in the Helpers. BRJ Med Psychol 45:315, 326, 1972. Alexander F., Psychosomatic Medicine, New York, W. W. Norton, 1950. Arms S., Immaculate Deception, A New Look at Women and Childbirth in America. Boston Mott, Houghton Mifflin, 1975. Benedict T., Rubenstein B., The Sexual Cycle in Women, Psychosomatic Medicine Monographs, Vol. 3. Washington, D.C., National Research Council, 1942. Bing E., 6 Practical Lessons for an Easier Childbirth. New York, Bantam, 1973. The Interface Between Psychiatry and Obstetrics and Gynecology. 9 Boston Women's Health Collective, The New Our Bodies, Ourselves. New York, Simon and Schuster, 1984. Can the gynecologist aid the alienist in institutions for the insane? JAMA 16:870, 873, 1891, reprinted in JAMA 265, 243230, 1991. Charles S. C., Kennedy E., Defendant. New York, Free Press, 1985. Christie G. L., Pawson Me, The Psychological and Social Management of the Infertile Couple, in the Infertile Couple. Edited by Pepperell Rs., Hudson B., Wood C. New York, Churchill Livingstone, 1987, pp. 35-50. Dick Stein L.J., Effects of the New Reproductive Technologies on Individuals and Relationships, in Psychiatric Aspects of Reproductive Technology. Edited by Stotland N.L. Washington, D.C., American Psychiatric Press, 1990, pp 123-139. Dreyfus, ed. Seizing Our Bodies, The Politics of Women's Health. New York, Vintage Books, 1978. Dunbar, H.F., Emotional and Bodily Changes, A Survey of Literature on Psychosomatic Interrelationships. New York, Columbia University Press, 1954. Freud S., Female Sexuality, 1931, in the Standard Edition of the Complete Psychological Works of Sigmund Freud, Vol. 21. Translated and edited by Strachey J. London, Hogarth Press, 1961, pp 223-243. Friedman, E.A., The Obstetrician's Dilemma, How Much Fetal Monitoring and Caesarean Section is Enough? An English J. Met 315:641, 643, 1986. Hellerstein, D., The Training of a Gynecologist, How the Old Boys Talk About Women's Bodies. MS 13, 5 136, 137, 1984. Karaso, T.B., Pluchnik R., Conti H., et al., What Do Physicians Want from a Psychiatric Consultation Service? Compare Psychiatry, 18:73, 81, 1979. La Leche League International, The Womanly Art of Breastfeeding. Franklin Park, Illinois, La Leche League International, 1987. Lantis, J.D., Second Generation Ethical Issues in the New Reproductive Technologies, Divided Loyalties, Indications, and the Research Agenda, in Psychiatric Aspects of Reproductive Technology. Edited by Stotland N.L. Washington, D.C., American Psychiatric Press, 1990, pp 87-96. Lepowski, Z.J., Consultation Liaison Psychiatry, The First Half Century. Gen Hosp Psychiatry, 8:305, 315, 1986. Mendelson, R., Male Practice, How Doctors Manipulate Women. Chicago, I.L., Contemporary Books, 1982. Newman, Loaf, Historical and Cross-Cultural Perspectives on Abortion, in Psychiatric Aspects of Abortion. Edited by Stotland N.L. Washington, D.C., American Psychiatric Press, 1991, pp 39-49. Notman, M., Nadelson, C., eds. The Woman Patient, Sexual and Reproductive Aspects of Women's Health Care. New York, Plenum Press, 1978. Pomeroy, S.B., Goddesses, Whores, Wives, and Slaves, Women in Classical Antiquity. New York, Schocken Books, 1975. 10 Psychological Aspects of Women's Health Care, Second Edition. Scully, D., Bart P., A Funny Thing Happened on the Way to the Orifice, Women in Gynecology Textbooks, in Changing Women in a Changing Society. Edited by Huber J. Chicago, I.L., University of Chicago Press, 1973, pp 283-288. Seiden, A., The Sense of Mastery in the Childbirth Experience, in the Woman Patient, Sexual and Reproductive Aspects of Women's Health Care, Vol. 3. Edited by Notman, M., Nadelson, C. New York, Plenum, 1978, pp 87-105. Stotland, N.L., Social Change and Women's Reproductive Health Care. New York, Praeger, 1988. Stotland, N.L., Garrick, T.R., Manual of Psychiatric Consultation. Washington, D.C., American Psychiatric Press, 1990. Webster v. Reproductive Health Services, 109s.ct 3040, 1989. Pregnancy. This page intentionally left blank two normal and medically complicated pregnancies. Diane A. Phillip, M.D., FRCPC. Melanie L. Carr, M.D., FRCPC. The miracle of pregnancy and the transformation of women into mothers has fascinated people from antiquity to the present. However, it is only during the past century that mental health professionals have begun to contribute to our understanding of the psychologic aspects of pregnancy and the psychosocial phases that women pass through on their journey into motherhood. Although this century has seen tremendous strides in the field of obstetrics, including the management of formerly non-viable high-risk pregnancies, there is a lag in our understanding of women's psychologic adaptations to medically complicated pregnancies. In this chapter, we begin by exploring the psychologic aspects of normal pregnancies, particularly in first-time mothers. Next, by providing a brief overview of medically complicated pregnancies, we create a framework for examining current understanding of the psychologic adaptation of pregnant women to their high-risk status. Finally, we consider the role of the psychiatrist consultant to obstetrics and gynecology. The psychoanalytic view. The psychoanalytic movement was among the first to consider the psychologic meaning of pregnancy to young girls and women. Although Freud's theory regarding pregnancy is now viewed as antiquated, it bears brief Men 1314 Psychological Aspects of Women's Healthcare, 2nd edition, because it was the dominant view for much of the 20th century. Freud understood the female wish for pregnancy by adapting his notion of the Oedipal conflict to girls. He believed that young girls, in coming to terms with the absence of a penis, initially blamed their mothers for their castrated bodies and turned to their fathers to replace the lost penis. Freud viewed the final resolution of this phase as a replacement of the wish for a penis by the wish for a baby, Freud 1933–1964. As more women began to offer their perspective in the psychoanalytic arena, the emphasis began to shift away from this notably phallocentric explanation. Influential in finally breaking with the older view, Benedict, 1970, saw pregnancy as a basic biologic drive in women, not merely a substitutive function. Thus motherhood is not secondary, not a substitute for the missing penis, nor is it forced by men upon women in the service of the species, but the manifestation of the all-pervading instinct for survival in the child that is the primary organizer of the woman's sexual drive, and by this also her personality. p. 139. These ideas have been developed in more recent reports by authors who have seen the wish for motherhood as based not only on biologic drive but also on an identification with what is essentially female. Several therapists have noted a richness in themes of identification with the woman's own mother, Kestenberg 1977, Lester and Notman 1986, Pines 1972, 1982. Over the course of the past century, a shift has occurred in the psychodynamic conceptualization from viewing pregnancy as a wish for a penis like the father toward an acceptance of the importance of an identification with the mother. Psychologic stages of normal pregnancy. In the late 1950s, Greta Bibring set out to do a longitudinal study of normal pregnant women using a multidisciplinary team of mental health and healthcare professionals, Bibring 1959. Bibring et al. 1961. As a result of her observations, Bibring postulated that pregnancy, like puberty or menopause, is a period of crisis involving profound psychologic as well as somatic changes, Bibring 1959, p. 116. Further elaborating on the analogy to puberty and menopause, she noted that these are all biologically mediated transitions from which there is no return. Once one becomes a mother, there is no returning to the previous childless stage, Bibring 1959. We would add that the abnormal and medically complicated pregnancies 15 vent of effective contraception and the legalization of abortion have placed pregnancy in a unique position. It is the only developmental stage that may or may not be embarked upon depending on a woman's choice and her cultural milieu. Bibring was perhaps the first to describe normal stages of psychologic development in pregnancy, Bibring et al. 1961. Numerous other investigators have provided greater detail about the phases of pregnancy. We attempt to synthesize the various perspectives in this chapter. Although most authors view the psychologic stages of pregnancy as beginning with conception, we find it more useful to use a broader context and consider the development of mothers as beginning in childhood and continuing well into the postpartum. Girls can be observed preparing for motherhood by trying on the role in play. As Morris, 1997, pointed out, a familiar scene is that of young girls fighting over who will play the mother in a simple game of house. Stern, 1995, writing from the perspective of an infant psychiatrist, suggested that long before conception occurs, the young girl or woman imagines herself as a mother as well as imagining her infant and child. When the woman finds a partner, these representations and schemas, as Stern calls them, undergo further elaboration because she now has new information about the child's future father. Once pregnant and into the postpartum, the woman is faced with increasing information about the fetus, herself, and her husband, and so the internal representations of these individuals evolve. Stern 1995. Once conception has occurred, there are three distinct psychologic phases that most women pass through during their pregnancies. These stages roughly correspond to the 3 trimesters of pregnancy and appear to be triggered by various psychologic, biologic, and cultural influences. The first stage of pregnancy is usually thought to begin when the woman realizes she is pregnant and to last until she experiences quickening, fetal movements, at approximately 1-2 months. During this stage, as new and often uncomfortable physical symptoms develop in the expectant mother, ambivalence about the pregnancy is common. Ultimately, in a wanted pregnancy, the fundamental task of this first stage is the acceptance of the pregnancy. Sandalowski and Black 1994. Women struggling with this task may show behavioral signs, such as denial of the pregnancy or unusual reactions to bodily changes. Cohen 1979. Several other psychologic changes begin at this time. In the clinical literature, psychologic slippage or forgetfulness has been described. Raphael Leff 1991. Only recently has this notion been examined empirically, in a cross-sectional study of memory in pregnancy, Sharp et al. 1993. This study 16 psychological aspects of women's health care, second edition confirms women's subjective experiences. Over 80% of the pregnant women studied perceived their memory as impaired compared with only 16% of non-pregnant control subjects. On objective measures of memory, the pregnant subjects were significantly impaired in comparison with control subjects in their recall of lists of words. Because no differences were found in the performances of women among the 3 trimesters, the authors concluded that no single hormone could be singled out as causative. Certainly one might have expected that the rising levels of estrogen in pregnancy would, in fact, be protective because estrogen has been found to heighten verbal memory in women. B. Sherwin 1998. Nevertheless, beginning in the first trimester and continuing into the early postpartum period, a woman's memory may be somewhat compromised. This change can become clinically significant in situations in which patients are given large amounts of information to retain. The predominant fear expressed by women in the first trimester of a wanted pregnancy is a fear of miscarriage. Leifer 1977. Other themes of this stage include increased emotionality, preoccupation with bodily needs, particularly food, and an obsession with her secret. Raphael Leff 1991. Many women continue to keep the pregnancy secret until they have passed into the second trimester. As the viability of the pregnancy seems more ensured, the mother embarks on the telling process. She typically progresses in a hierarchic order from those closest to her outward. Raphael Leff 1991, Rubin 1970. The second psychologic phase of pregnancy was historically thought to be initiated by quickening and the undeniable realization that life exists within. With the advent of fetal ultrasound, the progression into this next phase of development may be accelerated for some women. Raphael Leff 1991. Regardless, with the reduction or disappearance of many unpleasant physical symptoms, the second trimester of a woman's pregnancy is a time of relative peace and fulfillment. The most important tasks for a woman in this stage are initiating an emotional affiliation with, or attachment to, the fetus and recognizing the fetus as a separate individual contained within her. Bibring et al. 1961, Cohen 1979, Leifer 1977, Lester and Notman 1986, Pines 1982, Raphael Leff 1991. In his work, Stern, 1995, pointed out that from about the 4th to the 7th month there is rapid growth in the richness, quantity, and specificity of the networks of schemas about the baby to be. P. 23. This is apparently heralded by either quickening or by fetal ultrasound. Also at this time, signs of motherliness or a wish to nurture the infant become apparent. Lester and Notman 1986. Leifer, 1977, identified several behaviors indicative of abnormal and medically complicated pregnancy. 17 attachments such as talking to the fetus, calling the fetus by a pet name, and maneuvering the fetus so that the partner may observe movement. Hormonal correlates of maternal attachment were examined in a large, multi-center study of pregnancy. Fleming and colleagues, 1997, used both cross-sectional and longitudinal data and found that attachment to the fetus significantly increased between the first and second trimesters. However, no correlation was found between the hormonal changes of pregnancy and the measures of maternal attachment assessed during pregnancy. Interestingly, an increase in the estradiol to progesterone ratio, E/P, through the course of pregnancy was consistently related to stronger feelings of attachment in the postpartum. Therefore, hormonal factors may contribute to attachment, particularly in the early postpartum. With the sensation of fetal movements, the mother begins to recognize the fetus as a separate entity. Issues of separation and individuation from her own mother may be triggered by this process. In addition, it is during this phase that the woman may have anxieties about identifying with, or becoming like, her own mother. Morris 1997. The typical resolution of this period is a reworking of previous attitudes that help the young woman separate from her mother in earlier developmental phases. Ideally, the pregnant woman develops a newfound appreciation for her mother and the mothering role in general. Bibring et al. 1961, Cohen 1979, Morris 1997, Pines 1972, 1982. According to Cohen, 1979, unresolved conflict with one's own mother is more stressful than marital conflict and is a predictor of maladaptation to pregnancy. However, in the study by Fleming et al., 1997, no change was found in mothers' relations with their own mothers, although it is unclear how this relationship was measured and if questions of separation and identification were examined. As expectant mothers come to accept their fetuses as separate from themselves, they may also develop new feelings of ambivalence toward the pregnancy. For many women, the stage after quickening brings relief that there is indeed life within as well as a sense of fulfillment. Leifer 1977, Rubin 1970. However, it is not uncommon for women to harbor feelings of resentment toward the fetus. Benedict 1970, Pines 1972, Trad 1991. Around this time, a woman begins to show and thus loses control over who knows of the pregnancy. Rubin 1970. The mother may feel treated as a pregnancy and not as a person. Consequently, she may have an increasing sense of aloneness, which may be exacerbated if she has predominantly childless, non-pregnant friends. Raphael Leff 1991, or if she continues to feel ambivalent or negative about the pregnancy. 18 Psychological Aspects of Women's Healthcare, 2nd edition. The third and final psychologic stage of pregnancy begins when physical discomforts again predominate and the mother has a sense of her infant as viable. Lester and Notman 1986, Raphael Leff 1991. During this stage maternal, fetal attachment is expected to be at its highest, and nesting behavior is occurring, that is, preparations for the baby's arrival, such as purchasing furniture or selecting a name. Leifer 1977. The absence of this nesting behavior at this stage may indicate a maladaptation to pregnancy. Cohen 1979, Leifer 1977. Thus the predominant themes during this time center on preparation for the baby's arrival, somatic concerns, and worries about the delivery. According to Stern, 1995, the elaboration of schemas about the expected baby declines beginning around the 7th month. The image apparently becomes less clear than previously. Fleming and colleagues, 1997, described a similar phenomenon and reported a slight decline in positive feelings about the fetus in the weeks immediately preceding the birth. These may be protective functions on the part of the mother, to ward off any potential feelings of disappointment should the real baby differ significantly from the fantasized one. Stern 1995. During this final stage, expectant mothers again focus on bodily sensations, and appearance may become an increasing concern. In a survey of obstetric patients at 36 weeks gestation, Hoffmeyer et al., 1990, found that although 20% of the patients reported feeling more attractive, more than 50% felt less attractive and 60% had a decreased interest in sexual relations with their partners. This sense of being unattractive appears to increase throughout the course of pregnancy but actually peaks in the postpartum. Burke 1993, Leifer 1977. At this time in the pregnancy, anxiety about the delivery increases. Leifer 1977. Fears tend to group around several themes. Worry about the health of the baby often ranks highest. Kestenberg 1977, Neuhaus et al. 1994. Pain and loss of control during delivery are other major concerns. Mackey 1995. Antenatal classes have attempted to address some of these fears. Unfortunately, to date only a limited amount of research is available regarding the efficacy of prenatal classes in improving psychologic outcomes for women, and the results of this research are conflicting. Nichols 1995, Zwelling 1996. With each developmental milestone of the fetus, the sense of the unrelenting push towards separation is reinforced. Trad 1991. At no point is this more true than with delivery of the infant. Delivery is a profound culmination of much of the physical and psychologic preparation of the mother and her partner. In one brief moment, two become three, and the course of their lives' normal and medically complicated pregnancies 19 is set on a new, unalterable path. Postpartum issues are discussed elsewhere in this volume, Chapter 7, but it is important to reiterate that development of the mother continues after the birth as an interactive process between the woman and her baby. Bibring et al. 1961, Stern 1995. Medical complications of pregnancy. The notion of high risk can be broken down into both medical and psychosocial categories. L. N. Sherwin and Melly 1986. In this discussion we primarily consider the former, the latter is covered elsewhere in this text. The designation of high risk is given to approximately 30% of pregnancies in the United States, and these pregnancies account for 50% of perinatal mortality. Complications may develop at any stage of pregnancy as a result of pre-existing or emergent maternal disorders, obstetric difficulties, or fetal compromise. A cursory overview of these medical complications follows, to set the stage for discussion of the psychologic aspects of high-risk pregnancy. A more detailed description is beyond the scope of this chapter, but appropriate references are included. It behooves the psychiatrist working at the interface of psychiatry and obstetrics to have a working knowledge of the medical complications that can develop in pregnancy in order to have a full appreciation of the patient's course and to provide an effective liaison service. Maternal factors associated with increased risk during pregnancy include hypertension, diabetes, cardiovascular disease, renal disease, malignancies, and HIV. Some of these present for the first time, or only, during pregnancy. For example, hypertension is a complicating factor in approximately 5%, 10% of all pregnancies, SciBy 1992. Preeclampsia, a disorder specific to pregnancy, is characterized by hypertension, edema, and proteinuria. It accounts for the majority of hypertensive graviditis and develops with increasing frequency after the 20th week of gestation. Eclampsia is preeclampsia with convulsions. The only specific treatment is delivery, but temporization with bed rest, medications, and careful monitoring may be justified if the patient is remote from term, maybe and SciBy 1994. The remaining minority of cases involve chronic hypertension. Management of this latter group is controversial. Many experts now recommend not treating mild elevations in blood pressure. The benefits of treating severe hypertension in pregnancy appear to outweigh the risks of the medications used, however, because maternal and fetal morbidity and mortality are significantly reduced with treatment. SciBy 1992. Since the introduction of insulin, fetal and neonatal mortality in pregnant 20 psychological aspects of women's healthcare, second edition size complicated by diabetes has reduced from approximately 65% to 2%, 5%, Landon and Gabby 1992. Strict glucose control, both preconception and prenatally, appears to further reduce the risk of congenital malformations in the fetuses of diabetic women, Palmer 1994. As with hypertension, the vast majority of cases of diabetes, 90%, develop during pregnancy as gestational diabetes, Landon and Gabby 1992. For some of these women, however, that diagnosis intrapartum may foreshadow a diagnosis of non-insulin-dependent diabetes later in life, Palmer 1994. Cardiovascular disease complicates 0.4%, 4% of pregnancies and is the most frequent non-obstetric cause of maternal mortality, Biswas and Perloff 1994. The effect of cardiac disease on the pregnancy differs depending on the severity of the underlying disorder. With close monitoring and management, women with other medical illnesses such as mild to moderate renal disease, blood disorders, seizure disorders, multiple sclerosis, and even certain cancers in remission are increasingly able to have a successful pregnancy outcome. It is only when these disorders are severe that the prognosis for mother and fetus may be compromised. In the past 2 decades, HIV has increasingly complicated the pregnancies of young women. In an extensive review, Fowler et al., 1997, reported that of the estimated 30 million individuals infected with HIV worldwide, 11 million are women and 3 million are children, 90% of whom were infected perinatally. It is notable that in women of childbearing age, risk factors that prompt HIV testing are frequently under-recognized by clinicians, Schoenbaum and Weber 1993. Pregnancy does not appear to affect the progression of HIV, Hoyt 1997. However, treatment for HIV-related conditions may be delayed because of risk to the fetus, De Ferrari et al. 1993a, 1993b. In terms of HIV's impact on the pregnancy, North American studies comparing HIV-infected women with healthy control subjects have demonstrated no significant differences in obstetric complications or birth outcomes, Minkoff et al. 1990, Selwyn et al. 1989. Many factors are believed to increase the risk of transmission of HIV from mother to fetus. However, new retroviral treatments administered during pregnancy and later to the neonate can reduce the risk of perinatal transmission from 25% to 8%, Centers for Disease Control and Prevention 1996. Knowledge about risk reduction in HIV-infected pregnancies has given new hope to HIV-infected women considering their reproductive options. Obstetric factors that increase risk in pregnancy include habitual abortion, multiple gestation, placenta previa, and abruptio placentae. Miscarriage is a common problem in pregnancy, but most women will go on to normal and medically complicated pregnancies. 21 deliver a healthy baby in a subsequent pregnancy. A small subset of women, however, will repeatedly lose their pregnancies, a condition known as habitual abortion. Possible contributing factors include chromosomal abnormalities, dysfunction of the maternal endocrine system, infection, structural anomalies of the reproductive tract, example cervical incompetence, and underlying maternal disease, Pernall and Garmel 1994. Treatment of habitual abortion, therefore, is aimed at the underlying cause. With the increasing numbers of women delaying childbearing and the new reproductive technologies, the number of multiple gestation pregnancies has increased substantially in the past 2 decades, Bowers 1998. It is well known that the presence of additional fetuses increases the risk of complications for the mother and the fetuses. Ideally, early diagnosis with ultrasound allows for increased surveillance and improved outcomes. Unfortunately, not all cases are diagnosed antepartum, Palmer 1994. Of all pregnancies, 2%, 3% are complicated by serious hemorrhage, often in the 3rd trimester, Pernall 1994a, 1994b. Placenta previa, which occurs in 1 of every 200 pregnancies, is a major cause of such bleeds. Placenta previa is the implantation of the placenta in the lower segment of the uterus so that the placenta extends to the margin of the internal os of the cervix, partially or completely obstructing it. It presents as painless vaginal bleeding, and diagnosis is established by ultrasound. Management depends on the amount of bleeding, gestational age, fetal well-being, and presentation. The other major cause of third trimester bleeding is abruptio placentae, in which the placenta begins to separate from the interior uterine wall too early in gestation. In 20% of cases this bleeding is contained within the uterus, behind the fetus, resulting in a concealed abruption. Close monitoring of both mother and fetus is essential if abruption is suspected, because both are at serious risk of significant morbidity and death. Fetal complications that cause a pregnancy to be designated as high risk include intrauterine growth retardation, IUGR, and intrapartum fetal distress. IUGR complicates 3%, 7% of all pregnancies. Many factors are associated with IUGR, including infection, multiple gestation, poor nutrition, eating disorders, chromosomal abnormalities, congenital malformation, maternal hypertension, maternal smoking, and drug and alcohol abuse. Once IUGR is diagnosed, serial determinations of growth are undertaken, and treatment is aimed at contributing factors. After the age of viability, delivery is considered if fetal compromise is evident, Gaby 1986. In some cases, complications develop during the intrapartum period in a pregnancy that had progressed smoothly until term. Significant steps have 22 psychological aspects of women's health care, second edition been made in identifying fetal compromise during labor. Lower morbidity and mortality rates have resulted, primarily through the determination of fetal risk for hypoxia. The benefit of intrapartum surveillance is that it allows for confirmation of fetal well-being and may prevent unnecessary obstetric intervention. Unfortunately, false positive results still occur, and operative deliveries are sometimes undertaken unnecessarily. The advantages of increased technology must be weighed against the disadvantages, including the psychologic aspects of having a monitored labor. Psychologic aspects of high-risk pregnancies. Although a vast body of literature exists on the medical aspects of high-risk pregnancies, there is only a small body of knowledge about resulting psychologic reactions. In this section we attempt to explore the meaning of this diagnosis to expectant mothers, the ways in which it may affect the developmental milestones outlined, and some specific issues pertaining to these patients. In general, it appears that once women are diagnosed with high-risk pregnancies, they struggle with each psychologic stage of pregnancy. The normal ambivalence of early pregnancy may be protracted and therefore may delay acceptance of the pregnancy. After quickening, these women may have greater difficulties attaching to their fetuses. Furthermore, in the final stage of pregnancy, nesting behaviors may be delayed or even absent and dependency may be heightened. Some of these difficulties may persist into the postpartum. In considering the psychologic adaptation to high-risk pregnancy, it is important to recognize that even women with normal pregnancies may perceive themselves to be at risk. Marto et al., 1991, found that a pregnant woman's perceived risk of having a baby with an abnormality did not correlate with her actual risk. In a recent study, Searle, 1996, noted that although women tend to underestimate the actual risk of an abnormal outcome, placing it at around 1/1000, most of these women were anxious that their own pregnancy was at risk. Anxiety about the well-being of the fetus ranked highest among their concerns. By far the most important anxiety reducer, for 90.5%, was the availability of routine antenatal screening tests, which provided these women with the reassurance that all was well. Searle 1996. One must wonder, however, what role the routine availability of these tests plays in creating a sense of risk and abnormality in the first place. The high-risk group itself is not homogeneous, and thus it is difficult to normal and medically complicated pregnancies 23 draw conclusions about all women with high-risk pregnancies. For example, The patient's reaction to the diagnosis is affected by the stage at which the pregnancy is identified as high risk, the etiology of the risk, the nature of the treatment, and the personality structure and defenses of the pregnant woman. Kemp and Page 1987, Woolreich 1986. In exploring the meaning, to women, of a medically complicated pregnancy, it is important to recognize that much of the self-esteem of women who choose motherhood may become entrenched in the successful completion of this task. The knowledge of carrying an imperfect pregnancy may affect a woman's self-esteem detrimentally and leave her with feelings of inadequacy and failure. Jones 1986, Raphael Leff 1991. Indeed, Kemp and Page, 1987, found that women carrying high-risk pregnancies scored lower than women with normal pregnancies on measures of self-esteem. More recently, Kemp and Hatmaker, 1992, found that women with high-risk pregnancies also scored lower on a measure of self-actualization. If we subscribe to the view of pregnancy as an identification with the mother and the feminine ideal, then this low self-esteem and low self-actualization may even affect a woman's sense of herself as a woman. Psychologic stages in high-risk pregnancy. Any event perceived as threatening by the mother may compromise her ability to master the various stages of pregnancy. Cohen 1979. In examining the impact of a designation of high risk on psychologic development in pregnancy, we have focused on the responses of the mother. The reactions of the partner and older children are also significant, however, and although beyond the scope of this chapter, must be considered in the care of the high-risk mother. When the label of high risk is given, either before conception or very early on, the first psychologic task in pregnancy is more complex and at times paradoxical. These women must accept the pregnancy but concomitantly are faced with the threat to the survival of that pregnancy. Pentecoff 1982. The normal ambivalence of early pregnancy may be prolonged and may persist for the duration of the pregnancy or until the perceived threat has subsided or resolved. Pentecoff 1982. In the next psychologic phase of pregnancy, one fundamental task is attachment to the fetus. Research examining this question in high-risk pregnancies is limited, and although earlier findings suggested that these mothers were no different from normal control subjects, clinical observation, and more 24 psychological aspects of women's health care, second edition recent investigation suggests that the label of high risk may interfere with attachment. In two earlier studies, Kemp and Page, 1986a, 1987, used fetal attachment measures to compare women carrying low and high-risk pregnancies during their third trimester. They found no significant differences in degree of maternal attachment to the fetus. The authors speculated that a certain degree of denial regarding the severity, or even the presence, of the high-risk designation may allow for attachment to proceed relatively normally. However, they also noted that the subjects were all beyond 28 weeks gestation and may have become more optimistic because of the long duration of the pregnancy. Kemp and Page 1986a. Furthermore, because quickening usually occurs around 20 weeks gestation, many may have actually begun the task of attachment to the fetus prior to receiving the diagnosis of high risk. Therapists working with expectant parents with high-risk pregnancies have noted that this population holds off on developing feelings of attachment to the fetus for fear of disappointment. Moore 1983, Pentecoff 1982. More recently, Kemp and Hatmaker, 1992, looked at health-promoting and health-protective behaviors in pregnant women from a homogeneous socioeconomic background. They found that women with high-risk pregnancies were less likely to engage in health-protective and health-promoting behaviors than were those with low-risk pregnancies. Although these findings run counter to what one might hope for in high-risk pregnancies, one can speculate that the absence of these behaviors may reflect an absent or diminished attachment to the fetus. In other words, attachment is negatively affected by the diagnosis of high risk. Therefore, these women are less likely to demonstrate protective and nurturant behaviors toward their fetuses. Notably, unlike the earlier study on attachment, these women were polled between 20 and 41 weeks gestation, and thus some may have received their diagnoses before quickening, when attachment seems to begin. Although it seems likely that maternal attachment to the fetus is altered or delayed in high-risk pregnancies, more research is needed in this area to clarify how and when this occurs. Separation issues, which also come to the fore once fetal movements are perceived, may also be affected by a high-risk pregnancy. Not only is the woman aware of fetal movements, but some of the interventions that she must undergo, either for her own health or for that of the fetus, help to underscore both their separateness as well as their merged status. The mother is acutely aware that medications she must take for her own health may pose risks to the developing fetus, Raphael Leff 1991. Similarly, she may receive certain medications, for example, corticosteroids to mature fetal lungs, that normal and medically complicated pregnancies 25 are aimed at helping her fetus but may result in side effects for her. In the case of pre-existing medical conditions, the pregnancy may jeopardize the mother's health or there may be a risk of passing on a genetic or infectious disorder to the infant. Finally, with the intrusion of medical intervention, the usual sense of being treated as a pregnancy may be exaggerated. The mother may feel overlooked, a vessel for the fetus toward whom all attention is being paid. Normal resentment toward the fetus at this time may be compounded and confused by feelings of guilt and responsibility. The final weeks of pregnancy are notable for nesting behaviors as well as for a deepening dependency on social supports. With regard to nesting activity, Pentikoff, 1982, has suggested that preparatory behaviors are diminished or absent in high-risk pregnancies. For example, the couple may postpone preparing the nursery or selecting a name for the baby. As described previously, dependency tends to increase throughout pregnancy and is greatest in the third trimester. The label of high risk has been thought to increase the normal dependency of pregnancy, Woolreich 1986. However, some controversy exists as to whether this increase is adaptive. Woolreich, 1986, hypothesized that heightened dependency and the assumption of the sick role may make the frequency of visits and intensive testing more tolerable. In addition, the regression and passivity of pregnancy may allow for increased compliance with parental figures such as medical personnel. On the other hand, this increased dependency and tolerance of the sick role may mean that the mother anticipates a more negative outcome, Kemp and Page 1987. Such a belief may lead to a sense of learned helplessness, depression, and decreased compliance. In contrast, being treated as sick may be very difficult for some because these women often do not feel ill, Gupton et al. 1997, Jives 1985. In such situations one might expect a more resistant or independent stance, which also results in decreased compliance with medical regimens. In women who are hospitalized or are prescribed bed rest, regression and dependency may be further intensified by the enforced abandonment of usual activities, including work, and the provision of most aspects of daily care by others, Rogers 1989. Studies in recent years have looked at the effect of antepartum bed rest or hospitalization on psychologic functioning, Gupton et al. 1997, White and Ritchie 1984. Several issues have been found to create stress and anxiety in these women, such as concern about one's own health and that of the fetus, uncertainty and lack of control, feeling like a prisoner, feeling that one is missing out, concern about other children in the family, role reversals with the partner, and in the case of hospitalized patients, the separate 26 psychological aspects of women's health care, second edition from the usual supports of spouse and family, Gupton et al. 1997. White and Ritchie 1984. There is also financial stress if the expectant mother stops working or requires costly procedures, treatments, or services. For many women with medically complicated pregnancies, the birth of a healthy baby signifies a resolution of the uncertainties experienced during pregnancy. Nevertheless, difficulties from earlier developmental periods may spill over into this next stage, leading to problems in the early mother-infant dyad and perhaps beyond, Bibring 1959, Pentikoff 1982. In fact, Priel and Cantor, 1988, found that women who had carried high-risk pregnancies not only perceived their newborn infants as more difficult than the average baby but also expected the average baby to be much easier than did mothers who had experienced normal pregnancies. Berger and colleagues, 1993, found that at 4 to 8 years postpartum, mothers who had had complicated pregnancies viewed their children as vulnerable to illness almost twice as frequently as did women without pregnancy complications. This significant difference remained even when those infants who were in fact ill in the postpartum were removed from the analyses and only mothers with healthy newborns were included. Mothers with severe prenatal complications were also significantly more likely to report having had a postpartum depression. Viewing a child as more difficult or more vulnerable, as well as having postpartum depression, has serious implications for parent-child interactions. It would seem, then, that the psychological difficulties that women with high-risk pregnancies may experience can have consequences that reach well into the postnatal period. It should also be noted, however, that several studies examining pregnant women diagnosed as high risk have found that they manage fairly well. In a study examining the psychological impact of the diagnosis of gestational diabetes, Spirito et al., 1989, found that most women coped well with this unanticipated development. Subjects were interviewed several weeks after the diagnosis was established, which may have allowed for a period of adjustment. Kemp and Page, 1987, also found no significant difference in the anxiety levels of women carrying high-risk pregnancies and those carrying low-risk pregnancies. Again, this study looked at women in their third trimester who may also have had time to adjust and were therefore no longer anxious. As described previously, this study found no differences on measures of attachment. However, the authors did not look at the major tasks of this phase, that is, nesting behaviors and coping with increasing dependency needs. Thus, on certain measures of general adjustment, it is possible that for some women the diagnosis of high risk does not have a deleterious effect. However, normal and medically complicated pregnancies 27, when the specific psychologic tasks are examined at the appropriate developmental phase, a number of these women may be found to be struggling. Clearly, there is a paucity of well-designed studies examining these questions, and definitive conclusions are difficult to make at this time. Women infected with HIV warrant special consideration. Some of their issues highlight difficulties pertinent to all medically ill women embarking on a pregnancy. Other issues differ distinctly. Sowell and Messiner, 1997, used focus groups to examine the reproductive choices of HIV-infected women. Participants who wanted children, once aware of their HIV status, saw childbearing as an opportunity to leave something behind when they were gone, an opportunity to feel complete. In a study of women having children after breast cancer, Dow, 1994, also found women to report feeling complete as a rationale. Furthermore, for many breast cancer survivors, having children also meant getting well again, although they worried that they might not survive to see their children grow up. Regardless of whether this belief turned out to be accurate in the long run, getting well again has at least been a possibility for these women. For those infected with HIV, however, one of the struggles is knowing that they will probably succumb to their illness and leave their children behind. For some of the women in Sowell and Meisner's 1997 study, this knowledge influenced them to not have a baby. Unique to HIV is the meaning of the disease in our culture and the stigmatization and shame that come with the diagnosis. DeFerrari et al., 1993a, 1993b, commented on some of the specific problems associated with HIV infection, such as discrimination, social isolation, poverty, grief, and in the case of pregnant women, guilt over potentially infecting an unborn child. Because a large proportion of HIV-infected pregnant women are substance abusers, their ongoing drug dependence makes them less able to be compliant with health care, thus compounding their sense of culpability and shame. Psychiatric intervention working at the interface of psychiatry and obstetrics and gynecology can be both challenging and rewarding. Psychiatric involvement can be beneficial at every step of the process, from preconception through to the postpartum period. As noted by Bibring, 1959, relatively simple interventions can result in significant change for the mother. Furthermore, the psychiatrist can play a role in helping others in the woman's immediate environment. For some women, the role of the psychiatrist may begin even before Con 28 Psychological Aspects of Women's Healthcare, 2nd edition section. In women with chronic diseases, pre-pregnancy counseling in conjunction with the obstetric team can be very helpful. Couples may need to feel that they have permission to not have a child or to explore options like surrogate pregnancy or adoption. Once the patient becomes pregnant, certain elements in her history may signal perinatal psychiatric difficulties, such as previous obstetric mishap, infertility, familial or congenital diseases, conflicts about separation from parents, and poor relationships with physicians. Cohen 1979, Nadelson 1978. Stewart and Lippert, 1988, reviewed reasons for psychiatric referral during pregnancy and childbirth. They cited extreme ambivalence toward pregnancy, marital conflict related to the pregnancy, psychosocial problems, unstable environment, and prenatal anxiety as common reasons for referral. Another frequent referral question is to review the risk/benefit ratio of continuing psychotropic medications for a pre-existing psychiatric disease during pregnancy or whether to initiate medications during the course of a pregnancy, see Chapter 5. Finally, psychiatric consultation is sometimes sought because of non-compliance with prenatal care. This typically occurs in pregnancies already considered high risk for medical or social reasons or because of substance abuse. Stewart and Lippert 1988. Once a patient is referred, the time-limited nature of pregnancy can be especially suited to short-term psychotherapeutic intervention aimed at improving adjustment and resolving conflicting feelings about the fetus. Bibring 1959, St. Andre 1993, Woolwright 1986. Working with obstetric personnel can be challenging for the consultation liaison psychiatrist. The medical team may have their own reactions to a jeopardized pregnancy that can interfere with providing optimal medical care and emotional support to the pregnant woman. Diplomatically helping the staff understand their responses can assist in modifying unhelpful, over-involved, or even hostile behavior. Jives, 1985, noted stresses particular to the team working with high-risk pregnancies. First is the uncertainty of whether to label something as a problem and whether to inform the patient of it. Second, certain disorders have controversial treatments and dissent may exist within the team as to which direction to take. A further stress for the clinician can occur if the family chooses a course of action that differs from what is recommended. Finally, families often have very high expectations of the team, leaving little room for error in situations in which the outcomes can be devastating. Jives 1985. To be most effective, the psychiatrist working in this multifaceted area must have an understanding of the psychology of normal pregnancy, a familiarity with the medical and obstetric complications and management of high normal and medically complicated pregnancies. 29 Risk pregnancy, and an appreciation of the psychologic reactions associated with high-risk status for the pregnant woman and her family. The impact of interventions at this time can be far-reaching, both for the new mother and for her baby. References: Benedict T., The Psychobiology of Pregnancy, in Parenthood, Its Psychology and Psychopathology. Edited by Anthony E. J., Benedict T. Boston Mott, Little, Brown, 1970, pp 137-151. Birkby, Body Image and Pregnancy, Bridging the Mind, Body Connection. J. Perinatal 13:300, 304, 1993. Bibring G.L., Some Considerations of the Psychological Processes in Pregnancy. Psychoanal Study Child 14:113, 121, 1959. Bibring G.L., Dwyer T., Huntington D., et al., A Study of the Psychological Processes in Pregnancy and the Earliest Mother-Child Relationship. Psychoanal Study Child 16:9, 24, 1961. Biswas M.K., Perloff D.P., Cardiac, Hematologic, Pulmonary, Renal, and Urinary Tract Disorders in Pregnancy, in current obstetric and gynecologic diagnosis and treatment. Edited by Dekearney A., Hernal ML East Norwalk Court, Appleton and Lang, 1994, pp 428-467 Bowers N.A., The Multiple Birth Explosion, Implications for Nursing Practice. J. Obstet-Gynecol Neonatalness 27:302, 310, 1998 Berger J., Horwitz S.M., Forsyth B.W., et al., Psychological Sequelae of Medical Complications During Pregnancy. Pediatrics 91:566, 571, 1993 Centers for Disease Control and Prevention, HIV Testing Among Women Aged 18 to 44 Years, United States, 1991 and 1993. MMWR 45:733, 737, 1996 Cohen R.L., Maladaptation to Pregnancy. Semin Perinatal 3:15, 24, 1979 De Ferrari E., Gager C.L., Summers L., et al., Nurse Midwifery Management of Women with Human Immunodeficiency Virus Disease. J. Nurse Midwifery 38:86, 96, 1993 De Ferrari E., Payne L.L., Gager C.L., et al., Midwifery Care for Women with Human Immunodeficiency Virus Disease in Pregnancy, a demonstration project at the Johns Hopkins Hospital. J. Nurse Midwifery 38:97, 102, 1993 B. Dow K.H., Having Children After Breast Cancer. Cancer Prac 2:407, 413, 1994 Fleming as, Rubel D., Krieger H., et al., Hormonal and Experiential Correlates of Maternal Responsiveness During Pregnancy and the Puerperitum in Human Mothers. Hornby Hop 31:145, 158, 1997 Fowler M.G., Melnick S.L., Matheson B.J., Women and HIV, Epidemiology and Global Overview. Obstet-Gynecol Clin North AM 24:705, 729, 1997 30 Psychological Aspects of Women's Healthcare, 2nd edition Freud S., Femininity, 1933, in the Standard Edition of the Complete Psychological Works of Sigmund Freud, Vol. 22. Translated and edited by Strachey J. London, England, Hogarth, 1964, pp 128. Gabby S.G., Intrauterine Growth Retardation, in Obstetrics, Normal and Problem Pregnancies. Edited by Gabby S.G., Niebil J.R., Simpson J.L. New York, Churchill Livingstone, 1986, pp 769-785 Gupton A., Heman M., Ashcroft T., Bed Rest from the Perspective of the High-Risk Pregnant Woman. J. Obstet-Gynecol Neonatalness 26:423, 430, 1997, Jives Mount, The Psychosocial Impact of High-Risk Pregnancy. ADV Psychosome Met 12:71, 80, 1985 Hoffmeyer G.J., Marcos F., Butchert A.M., Pregnant Women's Perceptions of Themselves, A Survey. Birth 17:205, 206, 1990 Hoyt L., HIV Infection in Women and Children, Special Concerns in Prevention and Care. Postgrad Med 102:165, 176, 1997 Jones M.B., The High-Risk Pregnancy, in Nursing Assessment and Strategies for the Family at Risk, 2nd edition. Edited by Johnson S.H. Philadelphia PA, J.B. Lippincott, 1986, pp 111-128. Kemp V.H., Hatmaker D.D., Health Practices and Anxiety in Low-Income, High, and Low-Risk Pregnant Women. J. Obstet-Gynecol Neonatalness 22:266, 272, 1992 Kemp V.H., page CK, Maternal Prenatal Attachment in Normal and High-Risk Pregnancies. J. Obstet-Gynecol Neonatalness 15:179, 184, 1986 A Kemp V.H., page CK, The Psychosocial Impact of a High-Risk Pregnancy on the Family. J. Obstet-Gynecol Neonatalness 15:232, 236, 1986 B. Kemp VH, page CK, Maternal Self-Esteem and Prenatal Attachment in High-Risk Pregnancy. Mattern Childness J16:195, 206, 1987 Kestenberg J.S., Regression and Reintegration in Pregnancy, in Female Psychology, Contemporary Psychoanalytic Views. Edited by Bloom B.L. New York, International Universities Press, 1977, pp. 213-250. Landon M.B., Gabby S.G., Diabetes mellitus and Pregnancy. Obstet-Gynecol Clin North AM 19:633, 651, 1992 Lifer M., Psychological Changes Accompanying Pregnancy and Motherhood. Genet Psychol Monogra 95:55, 96, 1977 Lester E.P., Notman M.T., Pregnancy, Developmental Crisis, and Object Relations, Psychoanalytic Considerations. Int J Psychoanal 67:357, 366, 1986 Maybe W.C., Sci B.M., Hypertensive States of Pregnancy, in Current Obstetric and Gynecologic Diagnosis and Treatment. Edited by Dekerney A., Hernal M.L. East Norwalk Court, Appleton and Lang, 1994, pp. 380-397 Mackey M.C., Women's Evaluation of Their Childbirth Performance. Mattern Childness J23:57, 72, 1995 Marto T.M., Kidd J., Cook R., et al., Perceived Risk, Not Actual Risk, Predicts Uptake of Amniocentesis. B.R.J. Obstet-Gynecol 98:282, 286, 1991 Normal and Medically Complicated Pregnancies 31 Minkoff H., Henderson C., Mendez H., et al., Pregnancy Outcomes Among Mothers Infected with Human Immunodeficiency Virus and Uninfected Control Subjects. AMJ Obstet-Gynecol 163:1598, 1604, 1990 Moore Mill, The High-Risk Mother, in Realities in Childbearing, 2nd edition. Edited by Moore M.L. Philadelphia PA, W.B. Saunders, 1983, pp. 331-332 Morris M.G., Psychoanalytic and Literary Perspectives on Procreation Conflicts in Women. Psychoanal Rev 84:109, 128, 1997 Nadelson C.C., Normal and Special Aspects of Pregnancy, A Psychological Approach, in the Woman Patient, Vol. 1. Edited by Notman M., Nadelson C. New York, Plenum, 1978, pp. 73-86. Neuhaus W., Sharkus S., Ham W., et al., Prenatal Expectations and Fears in Pregnant Women. J. Perinatal Med 22:409, 414, 1994 Nichols M.R., Adjustment to New Parenthood, Attenders versus Non-Attenders at Prenatal Education Classes. Birth 22:21, 26, 1995 Palmer S.M., Diabetes, in Current Obstetric and Gynecologic Diagnosis and Treatment. Edited by Dekerney A., Hernal M.L. East Norwalk Court, Appleton and Lang, 1994, pp. 368-379 Pentecoff J.H., Psychological Implications in High-Risk Pregnancy. Nisklin North AM 17:69, 78, 1982 Pernal Mill, Late Pregnancy Complications, in Current Obstetric and Gynecologic Diagnosis and Treatment. Edited by Dekerney A., Hernal M.L. East Norwalk Court, Appleton and Lang, 1994a, pp. 331-343 Pernal M.L., Third Trimester Hemorrhage, in Current Obstetric and Gynecologic Diagnosis and Treatment. Edited by Dekerney A., Hernal M.L. East Norwalk Court, Appleton and Lang, 1994b, pp. 398-409 Pernal M.L., Garmel S.H., Early Pregnancy Risks, in Current Obstetric and Gynecologic Diagnosis and Treatment. Edited by Dekerney A., Hernal M.L. East Norwalk Court, Appleton and Lang, 1994, pp 306-330 Pines D, Pregnancy and Motherhood, Interaction Between Fantasy and Reality. BRJ Med Psychol 45:333, 343, 1972 Pines D, The Relevance of Early Psychic Development to Pregnancy and Abortion. Int J Psychoanal 63:311, 319, 1982 Priel B, Cantor B, The Influence of High-Risk Pregnancies and Social Support Systems on Maternal Perceptions of the Infant. Infant Mental Health Journal 9:235, 244, 1988 Raphael Leff J, Psychological Processes of Childbearing. London, England, Chapman, and Hall, 1991, pp 48-102 Rogers MP, Psychological Aspects of Pregnancy in Patients with Rheumatic Disease, in Rheumatic Disease Clinics of North America, Vol 15. Philadelphia, PA, W. B. Saunders, 1989, pp 361-374. Rubin R., Cognitive Style in Pregnancy. A. M. Jaina 70:502, 508, 1970 32 Psychological Aspects of Women's Healthcare, 2nd edition Sandalowski M., Black P.B., The Epistemology of Expectant Parenthood. Western Jainas Res 16:601, 622, 1994 Schoenbaum E. Weber MP, The Under-Recognition of HIV Infection in Women in an Inner-City Emergency Room. AMJ Public Health 83:363, 368, 1993 Searle J., Fearing the Worst, Why Do Pregnant Women Feel at Risk? Ost NZJ Obstet Gynecol 36:279, 286, 1996 Selwyn P.A., Schoenbaum E., Davani K., et al., Prospective Study of Human Immunodeficiency Virus Infection and Pregnancy Outcomes in Intravenous Drug Users. JAMA 261:1289, 1294, 1989 Sharp K., Brindle P.M., Brown M.W., et al., Memory Loss During Pregnancy. BRJ Obstet Gynecol 100:209, 215, 1993 Sherwin B.B., Estrogen and Cognitive Functioning in Women. PROCSOCEXP Biomed 217:17, 21, 1998 Sherwin Lane Melly C.N., Assessing and Identifying the High-Risk Pregnancy, A Holistic Approach. Topics in Clinical Nursing 833, 44, 1986 SciBM, Hypertension in Pregnancy. Obstet Gynecol Clin North AM 19:615, 631, 1992 Sokol R.J., Jones T.B., Pernal M.L., Methods of Assessment for Pregnancy at Risk, in Current Obstetric and Gynecologic Diagnosis and Treatment. Edited by Dekearney A., Pernal M.L. East Norwalk Court, Appleton and Lang, 1994, pp 275-305. Sowell R.L., Messiner T.R., Decisions to Have a Baby by HIV-Infected Women. Western Jainas Res 19:56, 70, 1997 Spirito A., William C., Ruggiero L., et al., Psychological Impact of the Diagnosis of Gestational Diabetes. Obstet Gynecol 73:562, 566, 1989 St. Andre M., Psychotherapy During Opportunities and Challenges. AMJ Psych Other 47:572, 590, 1993 Stern D.N., The Motherhood Constellation, A Unified View of Parent, Infant Psychotherapy. New York, Basic Books, 1995, pp 18-40 Stewart D., Lippert G.P., Psychiatric Consultation Liaison Services to an Obstetrics and Gynecology Department. Ken J. Psychiatry 33:285, 289, 1988 Trad P., Adaptation to Developmental Transformations During the Various Phases of Motherhood. JAM Academic Psychoanal 19:403, 421, 1991 White M., Richie J., Psychological Stressors in Antepartum Hospitalization, Reports from Pregnant Women. Mattern Childness J13:47, 56, 1984 Woolreich M.M., Psychiatric Aspects of High-Risk Pregnancy. Psychiatriclin North AM 10:53, 68, 1986 Swelling E, Childbirth Education in the 1990s and Beyond. J. Obstetgynekal Neonatalness 25:425, 432, 1996 3 Fetal Anomaly Gail Ehrlich Robinson, M.D., D.Psych, FRCPC Catherine L. Wisner, M.D., M.S. Fetal anomalies may be genetically programmed at conception by the transmission of defective genes or chromosomes, or they may arise during pregnancy as a result of maternal illness or exposure to harmful substances. Prenatal genetic counseling and diagnostic techniques have made possible the in utero detection of a large number of these fetal defects. These technologic advances also bring psychologic stresses in the form of decisions about whether to have testing, anxieties related to the tests and the wait for results, and the possibility of having to choose whether to terminate a pregnancy. This chapter discusses these reactions as well as the emotional consequences and management of elective genetic terminations or of giving birth to a child with a defect. The psychiatrist may have a role in direct counseling of patients who are adjusting to the emotional trauma of losing a wanted pregnancy or who are adapting to having a child with abnormalities. The psychiatrist may also be involved in supervising or assisting other members of the treatment team. Pre-pregnancy risk of hereditary disorders. Geneticists and genetic counselors advise patients who are at risk for a hereditary disorder about the consequences of the disorder, the probability of the 33-34 Psychological Aspects of Women's Healthcare, 2nd edition, developing the disease or transmitting the gene, and the ways in which this transmission may be prevented. Ideally, this information is given before pregnancy so the couple can make informed decisions about childbearing. Counselors also provide general information on the risk of chromosome abnormalities for women of late maternal age. The risk of chromosomal abnormalities being detected at 16 weeks gestation in a woman who is 35 years old is 1/250 for Down syndrome and 1/130 for all chromosome abnormalities. These risks increase until, in a woman who is 46 years of age, they are 1/15 and 1/10, respectively, Hook 1983. If a woman has previously given birth to an abnormal child, the geneticist uses clinical assessment of the affected infant, confirmation from medical records, and construction of a family genetic tree to make an accurate diagnosis and estimate the risk for future pregnancies. Single gene or Mendelian disorders have 3 inheritance patterns: autosomal dominant, autosomal recessive, and X-linked recessive or dominant genes. When one parent has an autosomal dominant disorder, such as tuberous sclerosis or Huntington's disease, there is a 50% probability that the offspring will be affected. Autosomal recessive disorders include the hemoglobinopathies and several progressive metabolic disorders such as Tay-Sachs disease. When both parents are carriers of an autosomal recessive condition, the risk of transmission to children is 25%, and each child has a 50% risk of being a carrier. When the mother carries an X-linked recessive disorder, such as hemophilia or Duchenne dystrophy, there is a 50% risk that each son will be affected as well as a 50% probability that each daughter will be a carrier. Most common birth defects, such as cleft lip, cleft palate, and neural tube defects, involve multifactorial inheritance. The recurrence risk of these disorders is rarely over 5% when only one parent is affected, Harper 1983. Chromosome disorders may involve numerical abnormalities caused by nondisjunction, example Down syndrome due to trisomy 21, or structural abnormalities such as chromosome translocations, example Down syndrome due to a translocation between chromosomes 14 and 21. The risk of nondisjunction after one occurrence is approximately 1%. With translocations, chromosomal material may be neither lost nor gained but merely out of place. In these cases, the translocation is said to be balanced and the individual will be a carrier, i.e., not symptomatic. Asymptomatic carriers of balanced translocations, however, have a 5% 20% risk of transmitting the unbalanced chromosome complement, i.e., too little or too much genetic material, to the child, who will, therefore, exhibit symptoms. Jackson 1980. Fetal anomaly 35 psychologic reactions to discovery of risk factors. The parent's perceived risk for any genetic disorder differs from the statistical risk. Swartz 1987. 5 major factors influence perceived risk. 1. The potential degree of harm or lethality. 2. The degree to which the risk can be controlled through safety or rescue measures. 3. The number of people affected. 4. The degree of familiarity with the consequences and effects of the disorder. And 5. The degree to which the parent's exposure to the risk is voluntary. Couples who have an increased risk for giving birth to a child with a genetic disorder are faced with the complications of a natural biologic process that is usually taken for granted. They may have a strong feeling of being defective. This presents a narcissistic threat to their self-esteem, to the extent that self-esteem is based on the expectation of creating a normal healthy child. Bloomberg et al. 1975. A sense of guilt associated with being a carrier of a genetic disease may also be present. It is common for these couples to feel anger toward women who are enjoying normal pregnancies and to feel guilt because of difficulties with reproduction. G. E. Robinson and Stewart 1989. They may undergo a grieving process for the loss of their idealized family. Their sexual enjoyment may be affected by both their distress and by the realization that the procreative act can result in tragedy. Marital distress caused by this crisis complicates decisions about future pregnancies. Genetic counseling and the possibility of detecting fetal defects prenatally play an important role in making decisions about further pregnancies. Bouet et al. 1991. Over half of counseled families who have infants with Down syndrome and up to 80% of those who have a child with neural tube defects reported that they were positively influenced in their decision to have more children by the information received during counseling sessions. Preconception counseling may reduce the couple's guilt, their sense of defectiveness, and their grief. Pregnancy indications for prenatal genetic testing. The goals of prenatal diagnosis are detection of fetal genetic disorders, improvement of outcome, provision of information to prepare parents, and identification of severely affected pregnancies that parents can elect to terminate. Indications for prenatal testing include advanced maternal age, women over 36, psychological aspects of women's health care, second edition 35 years of age, a known balanced translocation in one of the parents, a previous child with a chromosome disorder or neural tube defect, a mother who is a carrier for an X-linked disease, to determine fetal gender and to provide molecular diagnosis, where applicable, and parents who are both carriers of recessively inherited metabolic disorders. Galbus et al. 1974. Some examples of the types of disorders that are common indications for prenatal diagnostic testing are shown in Table 3-1. This list is not exhaustive, as hundreds of conditions can now be diagnosed through prenatal testing. The type of prenatal diagnostic test, the timing of testing, and the approximate waiting time for results are depicted in Table 3-2. Couples may not be willing to undergo prenatal diagnostic testing because of lack of information about the test, a perception of being at low risk for a fetal abnormality, concern about fetal injury or loss following the test, religious beliefs, or an unwillingness to consider elective termination as an option. Davies and Doran 1982, Dixon et al. 1981. Prenatal diagnostic test. Serum screening alpha-fetoprotein, AFP, is a normal human fetal protein that is found in high concentrations in the fetal serum throughout gestation. Rising levels of AFP can be detected in the sera of pregnant women as early as 7 weeks gestation, and levels increase steadily until at least 30 weeks gestation. Burton 1988. Elevated levels of maternal serum AFP, MSAFP, can be used to detect 80–85% of open neural tube defects and other malformations, including omphalocele or gastroschisis, intestinal atresias, congenital nephroses, and Turner's syndrome. MSAFP levels are approximately 25% lower when the fetus has Down syndrome. Knight et al. 1988. The use of multiple markers, MISAF, human gonadotropin, and unconjugated estriol, can detect 60%, 85% of anomalies, Wenstrom et al. 1995. MISAF screening can be done with reasonable reliability between 15 and 21 weeks gestation. About 4% of women will have an elevated MISAF level on initial testing, and 30% of these women will have a normal result on repeat testing. For multiple marker screening, 8% of women will have a positive result on the initial test, but only 1%, 2% of those will have an abnormal fetus, Carroll 1994. Patients who have abnormalities in the serum screening and are found through ultrasound and examination to have a single viable fetus at the anticipated gestational age may be advised to undergo amniocentesis. Table 3-1. Indications for prenatal diagnostic testing CVS/amniocentesis diagnostic ultrasound type of disorder example single gene disorders, known, or suspected cystic fibrosis multifactorial disorders, known or suspected neural tube disorders chromosomal disorders in the consultant or a family member Fragile X syndrome X abnormal trait or carrier state Tay-Sachs disease X prenatal diagnosis for late maternal age or other causes Down syndrome X teratogen exposure fetal alcohol syndrome X DNA analysis chromosome analysis enzyme analysis XXXX CVS equals chorionic villus sampling, MISAF equals maternal serum alpha-fetoprotein. XXX fetal anomaly note. MISAF 3738 Psychological Aspects of Women's Healthcare, 2nd edition Table 3-2. Prenatal diagnostic testing type of test early amniocentesis time of testing, weeks of gestation, waiting time for results, weeks, 10 to 14 2 to 3 9 to 12 1 to 2 diagnostic ultrasound, routine screening, 18 to 19 immediate mid-trimester amniocentesis 16 to 18 2 to 4 maternal serum screening 15 to 21 1 chorionic villus sampling serum testing may create unnecessary maternal anxiety because some women will be falsely identified as having high-risk pregnancies, Evans et al. 1988. Patients undergoing genetic testing because of elevated MISAF levels have been found to have a higher state of anxiety than those undergoing testing because of advanced maternal age. This anxiety only returns to normal levels after assurance of a definitively negative amniocentesis result, J. Robinson et al. 1984. Women who undergo serum screening have significantly lower anxiety levels in the 3rd trimester of pregnancy than do women who have not been screened, Marto et al. 1988. Ultrasound. Two main types of ultrasound are in common use. Continuous ultrasound is used to detect moving structures such as the fetal heart, whereas pulse ultrasound is used to outline structures within the uterus. In obstetrics, ultrasound is used for the screening and diagnosis of fetal age, multiple pregnancy, intrauterine growth retardation, and fetal malformations including craniospinal defects such as anencephaly, cardiac defects, and musculoskeletal, gastrointestinal, and renal abnormalities. Diagnostic ultrasound has no known risks to the fetus or mother and produces little anxiety in low-risk women, Campbell et al. 1982. Women tend to view scans as benign procedures allowing them to confirm the baby is healthy, J. Green and Stratham 1996. Scans may promote maternal, fetal bonding, Campbell et al. 1982, and may lead to a decrease in behaviors such as smoking and drinking, Reading et al. 1982, especially in women who receive a high level of feedback during the ultrasound examination, Reading et al. 1988. Mid-trimester genetic amniocentesis. Mid-trimester genetic amniocentesis is carried out at approximately 16 weeks gestation. After the exact positions of the placenta, fetus, and umbilical cord, fetal anomaly 39 are determined by ultrasound. A needle is inserted through the abdomen into the amniotic sac. Amniotic fluid is withdrawn for AFP and karyotype testing. In several studies, the rates of total fetal loss in the group receiving mid-trimester amniocentesis, 3.5%, and in non-randomized control subjects, 3.2%, were not significantly different. It is estimated that the risk of fetal loss because of mid-trimester amniocentesis does not exceed 0.5% in experienced hands, Low et al. 1978. Serious fetal injury and bacterial infection within the uterus are extremely infrequent. The results are usually available 2 to 4 weeks later at approximately 20 weeks gestation. Early genetic amniocentesis. Early genetic amniocentesis can be performed between 10 and 14 weeks gestation, although accuracy is greater at 12 to 14 weeks gestation, Rooney et al. 1989. Preliminary reports suggested that early genetic amniocentesis was safer than chorionic villus sampling, CVS, Godmelo et al. 1988, and as safe and accurate as mid-trimester genetic amniocentesis, J. M. Johnson et al. 1996. Rates of procedure-related fetal loss have been reported to range between 3.3% and 6.6%, Hackett et al. 1991, Hansen et al. 1987, with an average loss of 2.7%. A recent multi-center study found that women who have early genetic amniocentesis have an increased risk of having children born with talipes equinovarus, Canadian Early and Mid-Trimester Amniocentesis Trial Group 1998. Chorionic villus sampling. Chorionic villus sampling is another method of obtaining fetal cells for genetic analysis. Using ultrasound guidance, a catheter is inserted through the cervix or a needle is passed through the abdominal wall to aspirate chorionic tissue from the developing placenta. The material obtained is then sent for karyotype determination and other studies as indicated. In a multi-center, randomized clinical trial of CVS and mid-trimester genetic amniocentesis, the difference between the rates of pregnancy loss with the two procedures was determined to be no greater than 2.8% for women 35 years of age and older, Canadian Collaborative CVS Amniocentesis Clinical Trial Group 1989. The most likely risk is probably 1%, 1.5%. Early reports about a possible association with fetal limb defects when CVS is performed at less than 10 weeks gestation, Firth et al. 1991, have not been validated, Koliev et al. 1996. 40 Psychological Aspects of Women's Healthcare, 2nd edition. Psychologic Consequences of Chorionic villus sampling, Mid-Trimester Genetic Amniocentesis, and Early Genetic Amniocentesis. Couples who undergo prenatal diagnostic testing may experience significant psychologic stress. Prior to testing, women worry the procedure will be painful, cause injury to the fetus, or result in miscarriage, J. Green and Stratham 1996, Marto and Slack 1992. They may also be concerned about the results of the test, Evers Kayabums et al. 1988, Finley et al. 1977. Women with decreased social support have increased anxiety, J. Robinson et al. 1975. Beeson and Galbus, 1979, found increased anxiety in women who already had children with chromosomal disorders, but other investigators have not, Evers Kayabums et al. 1988, Tabor and Johnson 1987. Women having the tests as a result of positive screening tests are particularly anxious, J. Green and Stratham 1996. No increase in anxiety has been found in women who have been adequately counseled, although counseling done immediately prior to the test was not found to be beneficial, Nielsen 1981. Anxiety levels are also elevated in women prior to undergoing CVS, G. E. Robinson et al. 1988, Spencer and Cox 1987. A drop in anxiety immediately after testing has been noted for patients who underwent mid-trimester genetic amniocentesis, Tabor and Johnson 1987, Early Genetic Amniocentesis, G. E. Robinson et al. 1998, or CVS, G. E. Robinson et al. 1988. Tabor and Johnson, 1987, found this to be especially true for younger women and women who perceive themselves to be at low risk for an abnormality. Older women remained anxious until the results were obtained. Beeson and Galbus, 1979, found an immediate drop in anxiety with a subsequent rise during the wait for a possible miscarriage and test results. Women receiving results earlier in the pregnancy experienced anxiety reduction much earlier than did the group receiving results after 17 to 18 weeks, G. E. Robinson et al. 1988, 1998. Even after obtaining the results, about 25% of women receiving mid-trimester amniocentesis remained concerned about the outcome of the pregnancy, Dixon et al. 1981. McCormick et al. 1990, found that most patients had a better experience with CVS than with previous mid-trimester genetic amniocentesis. Women who undergo CVS develop an increase in maternal-fetal bonding earlier than do those having mid-trimester amniocentesis, Kacha et al. 1991. Pregnancy loss after testing. Women who have a miscarriage after a genetic procedure experience grief, guilt, and anger. Women who have CVS may perceive the procedure to be fetal anomaly 41 more risky and may feel additional guilt over having chosen it, G. E. Robinson et al. 1991. Also, because of the early timing of CVS, a miscarriage that would have spontaneously occurred may be falsely attributed to the procedure and create needless guilt. Even after genetic terminations or miscarriages, women tend to prefer earlier procedures, G. E. Robinson et al. 1988, 1998. Reactions to detection of fetal anomaly. Detection of a fetal anomaly is always a disturbing event, J. Green and Stratham 1996. A pregnancy that has been desired and perhaps long sought may suddenly lose its value. The first reaction is one of shock and denial, either expressed openly or masked by an apparent calm acceptance of the diagnosis, Jackson 1980. It is often difficult for couples to absorb information during this period of shock. The second stage is characterized by anxiety as they try to come to terms with future plans and alternatives for care. Many individuals have problems grasping the meaning of probability figures and using them for decision-making, Diadwal and Evers-Kayabums 1987. Either parent may exhibit hostile and angry behavior directed at the partner, the physician, or the counselor. The parents may then enter a phase of depression as they deal with this difficult problem. These stages vary in length and severity and may fluctuate before the parents reach the stage of acceptance and equilibrium. Reactions to genetic termination. Reproductive loss for any reason is always distressing. In an elective termination because of genetic disorders, i.e., genetic termination, the couple must face not only the loss of a wanted pregnancy but the fact of making a conscious decision to end it, Leon 1995. Ideally, discussion about the actions to be taken if an abnormal result is discovered occurs during pre-test counseling, Margot 1995. If the disorder is incompatible with life, the decision may be reasonably straightforward. For many others, a clear identification of a problem with known consequences, such as Down syndrome, will allow them to make the choice despite ambivalence and pain. Problems in decision-making increase with the identification of mosaicism or sex chromosomal disorders in which the outcome is not clearly a severe abnormality, Drugan et al. 1990. Acute grief reactions are experienced by 77%, 92% of women and 82% of men following a genetic termination, Bloomberg et al. 1975, Lloyd and 42 Psychological Aspects of Women's Healthcare, 2nd edition Lawrence 1985. This distress may last for many years after termination, White Van Morik et al. 1992. Couples often feel guilty about their decision to terminate a pregnancy. Couples who are at risk of having a child with an X-linked disorder and who terminate a pregnancy based only on knowledge of male gender must deal with the added guilt of knowing there is a 50% probability that the fetus would not have had the disorder, Bloomberg et al. 1975. Couples may experience marital problems caused by projection of their anger onto each other or by isolation due to depression. The woman may have stronger feelings about the loss or may be more open about expressing her feelings. In an attempt to handle his own sadness as well as deal with his partner's grief, the man may suppress his own feelings. The woman who has an induced abortion following genetic amniocentesis has probably experienced fetal movement, has usually been visibly pregnant, and has had to undergo delivery in order to terminate the pregnancy. It has been hypothesized that elective terminations following CVS may be less traumatic, but G. E. Robinson et al., 1991, found that women who had an elective termination following either method had equally elevated levels of depression. Couples who terminate a pregnancy for genetic reasons experience a grief reaction and mourn for their unborn child, Maguire et al. 1987. Protocols for the management of neonatal death have been proposed, Langer and Ringler 1989, Maguire et al. 1987, Phipps 1981. In the protocol of Maguire et al., 1987, the finding of an abnormality is discussed immediately with the parents in the context of a non-directive planning meeting. The couple is given a factual description of the termination procedure. Mothers who choose termination are admitted to a private room on a non-maternity ward where the spouses can remain together during the procedure. The psychologic management of pregnancy loss is discussed in more detail in Chapter 8. Selective termination may be considered in multiple gestations in which one or more fetuses are severely abnormal or when continuation of the multiple pregnancy presents a risk to the mother or the pregnancy, Zahner et al. 1990. This problem is more common in infertile patients who achieve pregnancy after ovulation induction. Zahner et al. 1990. Have argued that restricting selective termination to pregnancies of 3 or more fetuses provides the greatest chance of causing the least harm. They also advise early counseling for couples involved in ovulation induction to prepare them for the possibility fetal anomaly 43 of selective termination. McKinney et al. 1996, found that women who underwent selective reduction experienced guilt, ambivalence, and bereavement, but most felt they had made the right decision for themselves and their families. Fetal gender determination can be done by ultrasound or chromosomal examination. In cases of X-linked recessive disorders, if the fetus is male and molecular analysis cannot detect whether it is affected, the couple may elect to terminate the pregnancy knowing that there is only a 50% chance it would be affected. Termination of fetuses of a particular gender merely for socio-cultural reasons presents an ethical problem. Some physicians suggest that the gender of the fetus should be kept from the parents unless it is related to a genetic disorder. Others believe that caregivers do not have the right to withhold this information. Termination for the purpose of gender selection rarely occurs after mid-trimester amniocentesis, S. R. Johnson and Elkins 1988. Psychologic reactions to perinatal death, stillbirth or neonatal death caused by genetic abnormalities elicits not only grief reactions but guilty feelings on the part of the parents for having produced a defective child. Waiting for the autopsy results to confirm or allay their fears of having passed on a chromosomal defect to their baby is painful. Carrying a chromosomal defect that may harm future children is emotionally distressing. Children also react to the death of a sibling. The parents can assist by providing accurate information about the death, explaining that it was not the surviving child's fault, including the child in mourning ceremonies, and sharing parental grief, Leon 1990. Children's repetition of questions parallels the same phenomenon seen in parents' questioning of doctors. For a sibling who is free of a genetic illness, assurances that the fatality is not contagious and cannot happen to him or her can be helpful. Postpartum psychologic reactions to the malformed baby. The birth of a malformed baby constitutes an intense narcissistic injury for parents. Already coping with the psychophysiologic depletion that follows Law 44 Psychological Aspects of Women's Health Care, 2nd edition Bore and Delivery, these couples must also grieve the loss of the expected infant and accept the malformed child, Solid and Stark 1961. They must attempt self-regulation in the face of chronic depression and rage when confronted with the disappointment inherent in producing a damaged child, Fajardo 1987. Couples may feel unable to accept the child because the narcissistic injury is intolerable, or alternatively, they may experience severe guilt leading to over-involved parental dedication, Solid and Stark 1961. Parents of children with problems such as congenital heart disease may have more problems accepting the child's condition because outwardly the child appears completely normal, Emery 1989. This stress intensifies any pre-existing relationship difficulties. Men and women may handle the stress differently. Women may be more preoccupied with hands-on care, whereas men may focus on trying to emotionally support the wife. Svavarsdottir and McCubbin 1996. Mourning a malformed infant does not take place in the usual manner because the continuation of the child's life and the increased demands for physical care preoccupy most parents. Drotar et al., 1975, found that, despite reassurances, concern that the baby will die interferes with attachment to the child. Premature mourning for a child who subsequently recovers requires the parent to reverse psychologic energy and reintegrate the child into the family. Difficulty accomplishing this task can result in disturbed parent-child relationships and behavioral dysfunction in children. M. Green and Solid 1964, Naylor 1982. The continuation of mourning into a persistent, depressed, self-reproachful state is more likely if the mother's mourning reaction is not understood and if the care and planning for the child are carried out without her active participation. Parents of a malformed infant experience guilt and shame and frequently seek causal connections between the defect and prior thoughts, fantasies, wishes, or actions. Kessler et al. 1984. This guilt may or may not be realistic. Defenses against guilt include repression, behaviors such as substance abuse, intellectualization and rationalization, and isolation of affect. A common way for couples to handle the guilt is to decide against further reproduction. Shame is frequently associated with responses to the anticipated or actual disapproval of others. Common defenses against shame include denial, reaction formation, compensation, or displacement, such as focusing on the deficiencies of the medical caregivers. The parents must begin a lifelong reconciliation to the ongoing disappointments and special care required by the limitations of a child with a genetic defect. The child may be at risk of abuse, particularly if either parent fetal anomaly 45 has a history of child abuse, or of extreme social isolation from family and friends. Faust 1981. Parents of children born with malformations may not remember the rational content of the first conversation with their doctor. Solid and Stark 1961. They need repeated contact with their physician to accomplish the task of mourning. Parents also need assistance with decision structuring as they take responsibility for evaluative judgments and accept/reject decisions. Vielek 1987. Psychotherapy in the initial stages of work with families in which a child is malformed. Solid and Stark, 1961, recommended support and clarification of the reality of the child's condition as the parents are able to discuss their questions and fears. Avoiding the interpretation of unconscious conflicts during mourning was recommended. Group support for parents of children with fatal genetic illnesses can decrease parental isolation, allow discussion of the parent's need for both closeness and distance from the infant, and calm their fears about events immediately preceding their child's death. Mack and Berman 1988. In such a group, the parents may be able to admire the lovable qualities about each other's children and share in each other's grief when the children die. Zusker, 1987, advocated a short-term family crisis intervention model for managing the psychologic reactions to a baby born with genetic defects. This model includes multiple short meetings, initial work with the couple alone followed by placement into couples groups, an empathic and accepting therapeutic style to facilitate adaptation, provision of a supportive environment for emotional work, direct confrontation of beliefs about the fetus's impairment as causality, and attention to the marital relationship. Attention to biologic information and reproductive technology, the parent's psychologic capacities to receive information and use coping skills, and the parent's social milieu will allow the therapeutic team to develop a comprehensive treatment plan and achieve the most successful outcome. Acknowledgement. The authors wish to acknowledge the valuable assistance of Dr. Elaine Hutton in reviewing the information on genetics. 46 Psychological Aspects of Women's Healthcare, 2nd edition. References: Beeson D., Galbus M.S., Anxiety Engendered by Amniocentesis, in Risk, Communication, and Decision-Making in Genetic Counseling. Edited by Epstein C.J., Curry C.J., Packman S., ETAL, the National Foundation March of Dimes Birth Defects Original Article Series. White Plains, New York, Alan R. Liss, 1979, pp 191-197. Bloomberg B.D., Galbus M.S., Hansen, K.H., The Psychological Sequelae of Abortion Performed for a Genetic Indication. AMJ Obstetgynecol 12:799, 808, 1975. Boye, Muller F., Simon Bowie B., et al., Consequences of Prenatal Diagnosis of Cystic Fibrosis on the Reproductive Attitudes of Parents of Affected Children. Prenat Dian 11:209, 214, 1991. Burton B.K., Elevated Maternal Serum Alpha-Fetoprotein, Misap Interpretation and Follow-Up. Clin Obstetgynecol 31:293, 305, 1988. Kacha N., Johnson J.M., Robinson G.E., et al., Impact of Prenatal Testing on Maternal Fetal Bonding, Chorionic Villus Sampling versus Amniocentesis. AMJ Obstetgynecol 165:1122, 1125, 1991. Campbell S., Reading A.E., Cox D.N., et al., Ultrasound Scanning in Pregnancy, The Short-Term Psychological Effects of Early Real-Time Scans. J. Psychosome Obstetgynecol 1:57, 61, 1982. Canadian Collaborative CVS Amniocentesis Clinical Trial Group, Multi-Center Randomized Clinical Trial of Chorion Villus Sampling and Amniocentesis. Lancet 1:16, 1989. Canadian Early and Mid-Trimester Amniocentesis Trial, CEMAT, Group, Randomized Trial to Assess Safety and Fetal Outcome of Early and Mid-Trimester Amniocentesis. Lancet 35:242, 247, 1998. Carroll J.C., Maternal Serum Screening. Kinfam Physician 40:1756, 1764, 1994. Davies B.L., Dor and Ta, Factors in a Woman's Decision to Undergo Genetic Amniocentesis for Advanced Maternal Age. NISRES 31:56, 59, 1982. Dixon B., Richards T., Reinsch S., et al., Mid-Trimester Amniocentesis, Subjective Maternal Responses. J. Reprod Med 26:10, 16, 1981. Drotar D., Basquios A., Irvin N., et al., The Adaptation of Parents to the Birth of an Infant with a Congenital Malformation, a Hypothetical Model. Pediatrics 56:710, 717, 1975. Drugan A., Greb A., Johnson M.P., et al., Determinants of Parental Decisions to Abort for Chromosome Abnormalities. Prenat Dian 10:483, 490, 1990. Diadwal G., Evers Kayabums G., Experiments on Genetic Risk Perception and Decision Making, Explorative Studies. Birth Defects 23:209, 225, 1987. Emery J. L., Families with Congenital Heart Disease. Archdis Child 64:150, 154, 1989. Fetal Anomaly 47. Evans M.I., Bottoms S.F., Carlucci T., et al., Determinants of Altered Anxiety After Abnormal Maternal Serum Alpha-Fetoprotein Screening. AMJ Obstetgynecol 156:1501, 1504, 1988. Evers Kayabums G., Swartz A., Van den Berg H., Psychological Aspects of Amniocentesis, Anxiety Feelings in 3 Different Risk Groups. Clingenet 33:196, 206, 1988. Fajardo B., Parenting a Damaged Child, Mourning, Regression, and Disappointment. Psychoanal Rev 74:19, 43, 1987. Finley S.C., Varner P.D., Vinson P.C., et al., Participants' Reactions to Amniocentesis and Prenatal Genetic Studies. JAMA 238:2377, 2379, 1977. Firth H.V., Boyd P.A., Chamberlain P., et al., Severe Limb Abnormalities After Chorion Villus Sampling at 56 to 66 Days Gestation. Lancet 337:762, 763, 1991 Faust N., Counseling Families Who Have a Child with a Severe Congenital Anomaly. Pediatrics 67:321, 324, 1981 Godmelo L., Wiener S., Dunn L.K., Early Genetic Amniocentesis, Experience with 600 Consecutive Procedures and Comparison with Chorionic Villus Sampling, Abstract. AMJ Hum Genet 43, Supple A234, 1988 Galbus MS, Conti Fa, Schneider L., et al., Intrauterine Diagnosis of Genetic Defects, Results, Problems, and Follow-up of 100 Cases in a Prenatal Genetic Detection Center AMJ Obstet Gynecol 118:897, 905, 1974 Green J., Stratham H., Psychosocial Aspects of Prenatal Screening and Diagnosis, in the Troubled Helix, Social and Psychological Implications of the New Human Genetics. Edited by Marto T. Richards M. Cambridge, England, Cambridge University Press, 1996, pp 140-163 Green M., Solid A, Reactions to the Threatened Loss of a Child, a Vulnerable Child Syndrome. Pediatrics 34:58, 66, 1964 Hackett G.A., Smith J.H., Rebello C.T.H., Early Amniocentesis at 11 to 14 weeks Gestation for the Diagnosis of Fetal Chromosomal Abnormality, a Clinical Evaluation. Prenat Dian 1135, 40, 1991 Hansen F.W., Zorn M., Tennant F.R., et al., Amniocentesis before 15 weeks gestation, Outcome, Risks, and Technical Problems. AMJ Obstet Gynecol 156:1524, 1531, 1987 Harper P.S., Genetic Counseling and Prenatal Diagnosis. BR Med Bull 39:302, 309, 1983 Hook E.B., Chromosomal Abnormality Rates at Amniocentesis and in Liveborn Infants. JAMA 249:2034, 2038, 1983 Jackson L.G., Prenatal Genetic Counseling, in Psychosomatic Obstetrics and Gynecology. Edited by Youngs D.D., Earhart A. New York, Appleton Century Crofts, 1980, pp 129-144 Johnson J.M., Wilson R.D., Winson E.J.T., et al., The Early Amniocentesis Study, a randomized clinical trial of early amniocentesis versus mid-trimester amniocentesis. Fetal Diander 11:85, 93, 1996 48 Psychological Aspects of Women's Healthcare, 2nd edition Johnson S.R., Elkins T.E., Ethical Issues in Prenatal Diagnosis. Clin Obstet Gynecol 31:408, 420, 1988 Kessler S., Kessler H., Ward P., Psychological Aspects of Genetic Counseling, 3, Management of Guilt and Shame. AMJ MetGenet 17:673, 697, 1984 Knight G.J., Palomaki G.E., Haddo J.E., Use of maternal serum alpha-fetoprotein measurements to screen for Down syndrome. Clin Obstet Gynecol 31:306, 327, 1988 Koliev A., Jackson L., Froster U., et al., Chorionic Villus Sampling Safety. AMJ Obstet Gynecol 174:807, 811, 1996 Langer M., Ringler M., Prospective Counseling After Prenatal Diagnosis of Fetal Malformations and Parental Reactions. Acta Obstet Gynecol Scan 68:323, 329, 1989 Leon I.G., When a Baby Dies, Psychotherapy for Pregnancy and Newborn Loss. New Haven Court, Yale University Press, 1990, pp 131-187 Leon I.G., Pregnancy Termination Due to Fetal Anomaly, Clinical Considerations. Infant Mental Health Journal 16:112, 126, 1995 Lloyd J., Lawrence K. M., Sequelae and Support After Termination of Pregnancy for Fetal Malformation. BMJ 290:907, 909, 1985 Low Cu, Alexander D., Bryla D., et al., eds. The Naked Amniocentesis Registry, The Safety and Accuracy of Mid-Trimester Amniocentesis, DHEW Publication No. NIH 78-190, Bethesda, Maryland, Department of Health, Education, and Welfare, 1978 Mac Essay, Berman L.C., A Group for Parents of Children with Fatal Genetic Illnesses. AMJ Orthopsychiatry 58:397, 404, 1988 Maguire P.A., Wade Hasse B.A., IFT-RD, et al., A Supportive Intervention Protocol for Couples Terminating a Pregnancy for Genetic Reasons, in Strategies in Genetic Counseling, The National Foundation March of Dimes Birth Defects Original Article Series, Vol. 23. Edited by Paul N. W., Traverse H. White Plains, New York, Alan R. Liss, 1987, pp. 75-83 Marto T.M., Toward Informed Decisions About Prenatal Testing, A Review. Prenat Dian 15:1215, 1226, 1995 Marto T.M., Slack J., Psychological Implications of Prenatal Diagnosis for Patients and Health Professionals, in Prenatal Diagnosis and Screening. Edited by Brock D.J.H., Rodex C.H., Ferguson Smith Ma. London, England, Churchill Livingstone, 1992, pp. 663-673 Marto T.M., Johnston M., Pleniker M., et al., Development of a Self-Administered Questionnaire to Measure Women's Knowledge of Prenatal Screening and Diagnostic Tests. J. Psychosome Res 32:403, 408, 1988 McCormick M.J., Relansme, Mackenzie W., et al., Patients' Attitudes Following Chorionic Villus Sampling. Prenat Dian 10:253, 255, 1990 McKinney, Tuber S.B., Downey G., Multifetal Pregnancy Reduction, Psychodynamic Implications. Psychiatry 59:393, 407, 1996 Fetal Anomaly 49 Naylor A., Premature Mourning and Failure to Mourn, Their Relationship to Conflict Between Mothers and Intellectually Normal Children. AMJ Orthopsychiatry 52:679, 687, 1982 Nielsen C.C., An Encounter with Modern Medical Technology, Women's Experiences with Amniocentesis. Women Health 6:109, 124, 1981 Phipps S., Morning Response and Intervention in Stillbirth, An Alternative Genetic Counseling Approach. SOC Biol 28:1, 13, 1981 Reading A.E., Campbell S., Cox D.N., et al., Health Beliefs and Healthcare Behavior in Pregnancy. PsycholMed 12:1, 5, 1982 Reading A.E., Cox D.N., Campbell S., A Controlled Prospective Evaluation of the Acceptability of Ultrasound in Prenatal Care. J. Psychosome Obstet Gynecol 8:191, 198, 1988 Robinson G.E., Garner D.M., Olmsted M., et al., Anxiety Reduction Following Chorionic Villus Sampling and Genetic Amniocentesis. AMJ Obstet Gynecol 159:953, 956, 1988 Robinson G.E., Stewart D., Motivation for Motherhood and the Experience of Pregnancy. Ken J. Psychiatry 34:861, 865, 1989 Robinson G.E., Carr M., Olmsted M.P., et al., Psychological Reactions to Pregnancy Loss After Prenatal Diagnostic Testing, Preliminary Results. J. Psychosome Obstet Gynecol 12:181, 192, 1991 Robinson G.E., Johnson Jam, Wilson R.D., et al., Anxiety Reduction After Early and Mid-Trimester Prenatal Diagnostic Testing. Archives of Women's Mental Health 13944, 1998 Robinson J., Tennies K., Robinson A., Amniocentesis, Its Impact on Mothers and Infants. A 1-year follow-up study. ClinGenet 8:97, 106, 1975 Robinson J., Hibbard B. M., Lawrence K. M., Anxiety during a crisis, emotional effects of screening for neural tube defects. J. Psychosome Res 28:163, 169, 1984 Runita, McLaughlin N., Smith J., et al., Early Amniocentesis, a Cytogenetic Evaluation. BMJ 299:25, 1989 Solid AJ, Stark MH, Mourning and the Birth of a Defective Child. Psychoanal Study Child 16:523, 537, 1961 Spencer J.W., Cox D.N., Emotional Responses of Pregnant Women to Chorionic Villi Sampling or Amniocentesis. AMJ Obstetgynecol 157:1155, 1160, 1987 Svavars.ir.ek, McCubbin M., Parenthood Transition for Parents of an Infant Diagnosed with a Congenital Heart Condition. J. Pediatrinas 11:207, 216, 1996 Swartz A., Impact of Genetic Counseling and Prenatal Diagnosis for Down Syndrome and Neural Tube Defects. Birth Defects 23:61, 83, 1987 Tabor A., Johnson M.H., Psychological Impact of Amniocentesis on Low-Risk Women. Prenat Dian 7:443, 449, 1987 V. Lexi, Risk Assessment, Risk Perception, and Decision-Making about Courses of Action Involving Genetic Risk, an Overview of Concepts and Methods, in Strategies in 50 Psychological Aspects of Women's Healthcare, 2nd edition Genetic Counseling, the National Foundation March of Dimes Birth Defects Original Article Series, Vol. 23. White Plains, New York, Alan R. Liss, 1987, pp 171-207 Wenstrom K.D., Desai R., Owen J., et al., Comparison of Multiple Marker Screening with Amniocentesis for the Detection of Fetal Aneuploidy in Women greater than or equal to 35 years old. AMJ Obstetgynecol 173:1287, 1292, 1995 White Van Morik MCA, Connor J. M., Ferguson Smith Ma, The Psychosocial Sequelae of a Second Trimester Termination of Pregnancy for Fetal Abnormality. Prenat Dian 12:189, 204, 1992 Zahner R.M., Boehm F.H., Hill G.A., Selective Termination in Multiple Pregnancies, Ethical Considerations. Fertile Sterile 54:203, 205, 1990 Zusker D.M., The Psychological Impact of Prenatal Diagnosis of Fetal Abnormality, Strategies for Investigation and Intervention. Women Health 12:91, 103, 1987 For Psychiatric Disorders During Pregnancy Laura J. Miller, M.D. Introduction Pregnancy is a time of profound biologic, psychologic, and interpersonal change in the lives of many women. Although transient reactions of anxiety and sadness are common, most women navigate this transition without major psychopathology. However, for women who experience an episode of mental illness while pregnant, the effects on them, their offspring, and their families can be devastating. This chapter aims to summarize research and clinical findings that shed light on the interaction between pregnancy and psychiatric disorders and to suggest interventions that stem from these findings. Psychiatric disorders temporally related to pregnancy, schizophrenia and related psychotic disorders. Changes brought about by deinstitutionalization and socio-cultural factors have resulted in increased rates of pregnancy among women with schizophrenia, Miller 1997. Compared with demographically similar non-mentally ill women, women with schizophrenia have significantly fewer planned Preg 51-52 Psychological Aspects of Women's Healthcare, 2nd edition Nancy's and More Unwanted Pregnancies, McNeil et al. 1983, Miller and Finnerty 1996. Pregnancy among women with schizophrenia is often accompanied by risk factors such as substance abuse, poverty, homelessness, insufficient prenatal care, poor nutrition, poor social support, and being a victim of violence, McNeil et al. 1983, Miller and Finnerty 1996, Rudolph et al. 1990, Sacker et al. 1996, Stewart 1984. Risks are further increased by the direct effects of psychotic symptoms on behavior. For example, women with delusions about their pregnancies are significantly less likely to recognize labor than are mentally ill women without such delusions, Spielvogel and Weil 1992. Delusions related to pregnancy may also result in attempts at premature self-delivery, sometimes by self-injurious methods, Yolda's et al. 1996. These risk factors result in increased morbidity for both pregnant women and their offspring. Most women with schizophrenia report a worsening of their mental status during pregnancy, McNeil et al. 1984. Many women lose assisted housing arrangements because they are pregnant, Bockrich 1988, and have difficulty finding facilities equipped to deliver needed mental health and prenatal care, Dolliner 1993. Offspring, in addition to inheriting a vulnerability to schizophrenia, suffer the consequences of increased obstetric complications, Sacker et al. 1996. A central problem for many pregnant women with schizophrenia is the fear of losing custody of their babies. Anticipated custody loss may trigger exacerbations of psychosis and other grief-related reactions, Apfel and Handel 1993. Fear of custody loss often deters women from seeking intervention, Stewart 1984. Although symptoms of schizophrenia may affect parenting capability, for example, because of hallucinations and delusions about children, reduced ability to read and respond to nonverbal cues, interpersonal remoteness, and unpredictable behavior, many women with schizophrenia are capable of safe parenting. A comprehensive parenting assessment can serve as a basis for rational decisions about parenting capability. Such assessments use standardized tools to evaluate parenting behavior, mother-child attachment patterns, understanding of child development, and internal representations of the child, Jacobson et al. 1997. The pattern and content of specific symptoms, insight into illness, acceptance of and response to treatment, comorbid risks, and social support are also assessed. Parenting rehabilitation strategies including parenting coaching, therapeutic nurseries, parenting support groups, and parenting classes can target specific parenting problems. Unfortunately, many mental health facilities are ill-equipped to assess parenting capability and prepare women for custody determinations, Nicholson et al. 1993, Rudolph et al. 1990. Psychiatric disorders during pregnancy. 53 Mood disorders. Major depression. Mild to moderate symptoms of depression are relatively common during pregnancy, although episodes of major depression seem no more likely to occur during pregnancy than at other times in a woman's life. Afonso et al. 1991, Kobel et al. 1994a, Kitamura et al. 1994, Kumar and Robson 1984, O'Hara 1986. Antenatal depressive symptoms are especially prevalent among adolescents, inner-city women, and women with past histories of major depression, Barnett et al. 1996, Kobel et al. 1994a, Hopfall et al. 1995. Psychosocial risk factors for depression during pregnancy include less social and spousal support, more previous children, early parental bereavement, and termination of a prior pregnancy, Afonso et al. 1991, Barnett et al. 1996, Dematiner et al. 1995, Hopfall et al. 1995, Kitamura et al. 1994, Kumar and Robson 1984, O'Hara 1986. Antenatal depression is significant not only because of its prevalence but also because of its consequences. Depression can impair the mother's nutritional intake and prenatal care, increase her likelihood of using potentially harmful addictive substances, and lead to suicide attempts, Coverdale et al. 1997, Pyre 1995. Untreated antenatal depression significantly increases the likelihood of postpartum depression, Barnett et al. 1996, Hopfall et al. 1995, which in turn may affect the woman's long-term prognosis, Perry 1999, and parenting capability, Jacobson 1999. A depressive outlook may also color women's decisions about pregnancy outcome and obstetric interventions, Coverdale et al. 1997. For example, some depressed women feel so inadequate that they cannot imagine raising a child and ask to terminate a pregnancy they might otherwise want to continue. Others may decline treatment for pregnancy complications because they believe a negative outcome is inevitable. Diagnosing depression can be more difficult during pregnancy because insomnia, decreased energy, decreased concentration, and appetite changes are common to both pregnancy and depression. Screening instruments such as the Beck Depression Inventory may overdiagnose depression because of these overlapping somatic effects, Solomero et al. 1994, but these can be modified for use during pregnancy, O'Hara et al. 1984. More problematic, however, is underdiagnosis of depression during pregnancy. In clinics without screening measures, significant depression is often missed despite high levels of contact with healthcare professionals during pregnancy, Kumar and Robson 1984, Powers et al. 1993. 54 Psychological Aspects of Women's Healthcare, 2nd edition. Bipolar mood disorder. Because of the potential risks of prescribing mood-stabilizing medication during pregnancy, see Chapter 5, it is particularly important to understand the potential risks of untreated bipolar mood disorder during pregnancy. Although some women with bipolar disorder improve during pregnancy, sustaining euthymic baseline states without medication, Sharma and Prasad 1995, others develop acute manic episodes if unmedicated. Untreated mania can decrease compliance with prenatal care, increase addictive drug use, increase high-risk sexual behavior that exposes both mother and fetus to sexually transmitted diseases including HIV infection, and increase the likelihood of the woman being a perpetrator or a victim of violence, Finnerty et al. 1996. When pregnancy complications develop, mania may interfere with obstetric treatment, example making it impossible for a woman to maintain bed rest. Dixon et al. 1992 or comply with a diet for gestational diabetes. Mellitus Finnerty et al. 1996. Anxiety disorders. Panic disorder. A subset of women experience a decrease in the frequency and severity of panic attacks during pregnancy, Villepinto et al. 1992, whereas other women experience new onset of panic disorder, Cowley and Royburn 1989, or worsening panic during pregnancy, Grease et al. 1995. Panic attacks occurring during pregnancy may be confused with preeclampsia, Benjamin and Benjamin 1993, or may contribute to complications like placental abruption, presumably by producing sympathetic nervous system arousal and transient hypertension, Cohen et al. 1989. Agoraphobia associated with panic disorder can compromise women's ability to visit a prenatal clinic, Olson et al. 1992. Obsessive-compulsive disorder. Pregnancy is one of the most common triggers for the onset or exacerbation of obsessive-compulsive disorder, Nezaroglu et al. 1992. When severe, compulsions may directly affect obstetric risk factors, such as when nutritious foods are avoided because of contamination fears or when time-consuming rituals preclude prenatal clinic visits. Obsessions sometimes include egodystonic thoughts of harming the fetus that women may be afraid to mention. Psychiatric disorders during pregnancy. 55 to others, Iancu et al. 1995. Occasionally, symptoms remit at the time of birth, Iancu et al. 1995, but this is not the norm. Post-traumatic stress disorder. Symptoms of post-traumatic stress disorder arising during pregnancy may be related to one of the following situations. 1. Women with histories of sexual abuse whose traumatic memories are reactivated by the experience of pregnancy and childbirth. 2. Women who develop post-traumatic stress disorder as a result of traumatic childbirth experiences. 3. Women who develop both post-traumatic stress disorder and pregnancy because of a rape. The experiences of pregnancy, childbirth, and obstetric interventions can reactivate memories of sexual abuse. Some women experience flashbacks and/or sensations analogous to forced intercourse and/or overwhelming feelings that their bodies are out of control, that they must depend on others in a way that frightens them, Rhodes and Hutchinson 1994. These feelings can result in difficulty collaborating with labor, so that there is a failure to progress. For example, a woman might tense her thigh and vaginal muscles rather than relax them to push, or might direct all of her pushing efforts into her arms, as if to break the process of delivery. Other manifestations include dissociation during labor and regressive behavior, such as assuming a childlike voice, hiding under the covers, and assuming a fetal position. Rhodes and Hutchinson 1994. As a coping strategy, some women may attempt to control every aspect of delivery to the point at which they are seen as over-controlling by obstetric staff. If the reasons for the behavior are not understood, obstetric personnel may come to regard the mother as an adversary who must be overcome in order to provide care to the baby. Josephs 1996. These patterns are especially common in pregnant adolescents because many pregnant teenagers have been sexually abused. Boyer and Fine 1992. Even with no pre-existing trauma history, childbirth itself is a sufficiently traumatic experience for some women that it produces symptoms of post-traumatic stress disorder. Ralph and Alexander 1994. Childbirth is sometimes inadvertently rendered more traumatic by prenatal classes that convey the impression that women who use analgesia during labor are failures. Stewart 1985. Although this feeling, in itself, is unlikely to cause post-traumatic stress disorder, it can be a contributory factor. Another vulnerable group is that of women who became pregnant as a result of rape. Many are unaware of the pregnancy for the first few months. Post-rape counseling may help women recognize the possibility of pregnancy earlier as well as decrease the psychiatric sequelae. 56 Psychological Aspects of Women's Healthcare, 2nd edition. Sleep disorders. It is normal for sleep patterns to be altered during pregnancy. The most common pattern consists of longer sleep and more naps in the first trimester, normal sleep in the second trimester, and numerous nighttime awakenings in the third trimester. Brunner et al. 1994, Coble et al. 1994b, Suzuki et al. 1993. Frequent awakenings toward the end of pregnancy are partly caused by increased urinary frequency, pain, fetal movements, and difficulty finding a comfortable position. Brunner et al. 1994, Suzuki et al. 1993. They may also be caused by qualitative changes in sleep architecture, perhaps hormonally induced. Brunner et al. 1994. In some women, pregnancy is associated with new onset or recurrence of sleep disorders, including sleepwalking. Berlin 1988, night terrors. Snyder 1986, restless leg syndrome. O'Keefe 1996, and obstructive sleep apnea. Littner and Brock 1996. Of these, the most common is restless leg syndrome, an unpleasant sensation in the legs that is relieved by movement and causes sleep disturbance because it usually occurs at night. O'Keefe 1996. It occurs in up to 27% of pregnant women, especially in the second half of pregnancy. This disorder is associated with depression and is exacerbated by deficiencies of folate, vitamin B12, and/or iron. The symptoms are also intensified by the use of caffeine, cigarette smoking, or alcohol, although the reasons for this are unknown. Treatment includes eliminating caffeine and alcohol ingestion, stopping smoking, supplementing with folate, B12, and/or iron as indicated, and taking hot baths before bedtime. Severe cases can respond to psychopharmacology with L-Dopa, bromocriptine, clonazepam, carbamazepine, clonidine, or oxycodone, but the risks of prescribing these agents during pregnancy must be taken into account. See Chapter 5. Obstructive sleep apnea is rare during pregnancy but is important to detect because severe cases result in sufficient maternal hypoxemia to cause fetal intrauterine growth retardation. Non-invasive tests of fetal well-being, such as non-stress tests, serial ultrasound examinations, kick counts, and umbilical Doppler flow studies, can help determine whether the fetus is being affected by maternal sleep apnea. Littner and Brock 1996. In some cases, Apnea is a result of sleeping in the supine position and can be remedied by instructing the woman to sleep on her side. Lau Btal 1996. In other cases, treatment measures such as continuous positive airway pressure, dental prostheses, tracheostomy, or overnight supplemental oxygen are necessary. Littner and Brock 1996. Psychiatric disorders during pregnancy 57 Factitious disorders in the context of pregnancy. Factitious disorder is the feigning or intentional production of signs and symptoms of pregnancy complications. These can include vaginal bleeding, premature labor, premature rupture of membranes, vomiting, reduction in fetal movements, pyrexia, and seizures. Goodlin 1985, Juriadini 1993. Failure to detect the factitious nature of symptoms can result in misdiagnoses such as placenta previa, placental abruption, and fetal distress and can lead to premature delivery by cesarean section. Factitious disorder during pregnancy poses a risk for the later development of factitious disorder by proxy, which is the feigning or production by the mother of symptoms or illness in her child, Juriadini 1993, and of other forms of child abuse, Goodlin 1985. Recognizing the factitious nature of symptoms is challenging but can be facilitated by 1. Including factitious disorder in the differential diagnosis of pregnancy complications, 2. Communicating with other healthcare providers for patients who seek care from multiple sites, and 3. Eliciting a history of prior child custody loss. Management is usually best conducted by obstetricians in consultation with psychiatrists. Although patients rarely improve from direct interpretation of their behavior, an understanding of their motivations may be obtained through collateral historians and may guide intervention. Collaboration with child welfare agencies may offer protection for offspring as well as help motivate women to consider psychiatric intervention and parenting rehabilitation. Disorders specific to pregnancy. Hyperemesis gravidarum. Hyperemesis gravidarum is a condition of intractable vomiting during pregnancy that is of sufficient severity to result in electrolyte imbalance, weight loss, ketosis, acetonuria, and/or organ damage and is without a known organic cause other than pregnancy. Although mild nausea and vomiting are experienced in most normal pregnancies, hyperemesis gravidarum is relatively rare and occurs in approximately 0.5–10/1,000 pregnancies. Hod et al. 1994. Endocrinologic explanations for the etiology of hyperemesis gravidarum have been postulated, although none have been clearly proven. The etiologic role of psychogenic factors has been controversial. Belief in such factors arose 58 psychological aspects of women's health care, 2nd edition because vomiting ceased in some cases with placebo treatments, hospital admission alone, or psychosocial interventions. Psychodynamic explanations initially centered on vomiting as an unconscious attempt to get rid of the fetus, O'Brien and Newton 1991. Empirical studies have suffered from methodologic difficulties, including a lack of adequate control subjects and a failure to differentiate the psychologic causes of hyperemesis from its effects. One well-controlled follow-up study found no evidence of significant differences in long-term psychopathology between women with hyperemesis and control subjects, although acute psychiatric disturbance could not be excluded. Majoris et al. 1960. Other studies have found hyperemesis to be associated with factors such as hysterical personality, below-average intelligence, poor mother-daughter relationships, unplanned and/or undesired pregnancies, susceptibility to hypnosis, and eating disorders. Apfel et al. 1986, Fairweather 1968, Fitzgerald 1984. Hyperemesis has also been conceptualized as a learned behavior in response to psychosocial triggers that vary from woman to woman. In some cases, it is postulated that the trigger is an extreme anxiety response to normal nausea and vomiting of pregnancy, which in turn worsens the nausea and vomiting, creating a vicious circle. Tucker 1995. Overall, available data suggest a spectrum of psychophysiologic causation, with some cases heavily influenced by psychopathology, others apparently unrelated to psychologic disturbance, and some having both emotional and somatic determinants. A logical clinical approach begins with screening for the presence of a personality disorder, current interpersonal conflict, eating disorder, ambivalence about the pregnancy, extreme anxiety, and/or specific psychosocial triggers of vomiting. Noting apparent connections between the factors and the symptoms can guide effective treatment. Denial of pregnancy. Difficulties with recognizing and accepting pregnancy fall on a continuum from disavowal of the emotional reality of pregnancy through suppression of awareness of pregnancy to psychotic denial of pregnancy. Emotional denial occurs in women who acknowledge that they are pregnant yet do little or nothing to alter their lives accordingly. For example, they do not change diet, wardrobe, exercise regimen, or future plans. They do not fantasize about the baby, think of names for the baby, or prepare a nursery. This type of denial is often seen in women who have lost a prior baby, such as through stillbirth. In these cases, working through unresolved grief may help mothers bond psychiatric disorders during pregnancy 59 with their new babies and allow those babies to have identities separate from those of their lost siblings. This pattern is also seen in many women who use addictive drugs and feel guilty about potential consequences. Spielvogel and Hoener 1995. More extreme denial may be seen in women who suppress awareness of pregnancy through all or most of gestation. Typically, such women gain little or no weight. Those who do gain weight attribute it simply to getting fat. Many have episodes of bleeding throughout the pregnancy. Those who do not may attribute amenorrhea to menopause or to irregular periods. Few experience typical pregnancy-related symptoms such as nausea. Those who do experience such symptoms attribute them to other causes. Symptoms and signs of labor are misinterpreted. For example, contractions may be experienced as the urge to defecate and ruptured membranes as urination. During labor and delivery, these women often show signs of dissociation. In most cases, significant others do not know that the women are pregnant. In part, this is because the women conceal signs of pregnancy, but in many cases it seems to reflect a profound interpersonal isolation and lack of intimacy with significant others. Pregnancy is usually discovered during labor or after the birth of the baby but is occasionally discovered earlier by accident, for example, by viewing fetal bones on X-rays that the mother receives for unrelated complaints. Brzezinska et al. 1994, Brzozowski and Follett 1971, Finnegan et al. 1982. Women who deny pregnancy in this way are a heterogeneous group. Risk factors for this form of denial include 1. Young age. Most reported cases are in adolescence. 2. Passivity. Example, women who do not refuse unwanted sex and/or do not insist on contraception, then become pregnant and do not seek abortions even if they want them. 3. Family and/or cultural taboos. Example, families or subcultures in which it is unthinkable to become pregnant while unmarried, or families in which a woman believes dire consequences will result from pregnancy if you ever got pregnant, your father would have a heart attack. 4. History of sexual abuse, leading women to deny pregnancy in order to stave off traumatic memories. 5. Limited intelligence or paucity of knowledge about reproductive anatomy and physiology. 6. Relevant life stressors, such as separation from the father of the child. And 7. Social isolation. Brzezinska et al. 1994, Finnegan et al. 1982, Resnick 1970, Saunders 1989, Spielvogel and Hoener 1995. Certain obstetric and gynecologic conditions also enhance the likelihood of pregnancy denial. These include breech presentation, which causes body habitus to be less recognizable as pregnant, and irregular menses, which make pregnancy-related amenorrhea less noticeable. Brzezinska et al. 1994. 60 Psychological Aspects of Women's Healthcare, 2nd edition. The consequences of extreme pregnancy denial can include failure to receive prenatal care, inadequate nutrition during pregnancy, failure to avoid pregnancy-related risks such as radiologic procedures or teratogenic drugs, failure to notice warning signs of premature labor, premature rupture of membranes, or other pregnancy complications, unassisted delivery, sometimes accompanied by complications such as excessive bleeding or infection, neonaticide, occurring either actively, example the mother is overwhelmed by fear and rage after the sudden breakdown of defensive denial and kills the baby, or passively, example the baby drowns in the toilet because of being mistaken for a bowel movement, and loss of custody of the child, Brezinka et al. 1994, Resnick 1970, Saunders 1989, Spielvogel and Hoener 1995. Psychotic denial of pregnancy usually occurs in women with pre-existing psychotic disorders, most commonly schizophrenia. It consists of maintaining the belief that one is not pregnant despite experiencing the physical changes of pregnancy and experiencing positive pregnancy tests, ultrasound examinations, fetal heart tones, and even the baby after birth. In many cases, the denial comes and goes and is intensified by stress. Psychotic denial is more common in women who have lost custody of a baby and/or anticipate losing custody, suggesting that it is a defense against overwhelming feelings of loss, Miller 1990. Denial and its resultant risks can be minimized by screening for pregnancy in high-risk populations, example adolescents and women with schizophrenia or drug addiction, discussing sexuality and reproduction in a non-judgmental manner, and screening for past sexual abuse and past fetal/neonatal loss. Emotional denial often responds to brief, focused psychotherapy. Extreme, non-psychotic denial usually collapses in the face of external validation of pregnancy, but supportive psychotherapeutic and family interventions may be necessary depending on the sources of denial and the consequences of acknowledging the pregnancy. Psychotic denial may respond to pharmacotherapy and supportive psychotherapy. If persistent, however, hospitalization may be required in order to avoid precipitous, unassisted delivery and/or harm to the fetus or neonate, Miller 1990, Spielvogel and Hoener 1995. General principles of intervention during pregnancy. The increased contact with healthcare professionals afforded by prenatal care allows for early detection of psychiatric disorders during pregnancy. Early detection, in turn, allows prompt intervention and prevention of exacerbation psychiatric disorders during pregnancy. 61 later in pregnancy or postpartum. This may decrease the need for medication during pregnancy, decrease obstetric complications, and promote optimal parenting. Early detection can be promoted by the use of screening tools designed for this purpose, Powers et al. 1993. Mental health screening questions can be incorporated into general prenatal intake histories in the form of self-administered questionnaires, on paper or computer, or as semi-structured interviews. In addition to instruments that screen for general psychiatric symptoms, instruments are available that have been developed specifically for use with pregnant women in prenatal care settings. These include the Maternal Attitudes to Pregnancy Instrument, MAPI, Blau et al. 1964, the Life Event Scale for Obstetric Groups, Barnett et al. 1983, the Maternal Adjustment and Maternal Attitudes Scale, MAMA, Kumar et al. 1984, and the Pregnancy Psychologic Attitudes Test, PPAT, Mamali et al. 1989. When psychiatric symptoms are present, a comprehensive psychiatric evaluation can assist in making a diagnosis and guiding interventions. For certain symptoms, specific forms of psychotherapy may be particularly effective, for example, cognitive behavioral therapy for depression, obsessive-compulsive disorder, and panic disorder, relaxation techniques and hypnosis for hyperemesis gravidarum, or interpersonal psychotherapy for depression. In cases of severe psychiatric disorders, the risks of active symptoms may outweigh potential risks of pharmacotherapy or electroconvulsive therapy during pregnancy, see Chapter 5. Decisions about somatic treatment during pregnancy must take into account not only the risks of treatment and of untreated symptoms but also the patient's insight into her illness, her ability to recognize early symptoms, her social supports, and her therapeutic alliance. Involving the family members and self-help support networks of pregnant women may be helpful, given the high levels of psychosocial stress associated with many antenatal psychiatric conditions. When presenting mentally ill pregnant women with decisions about obstetric interventions, it is important to evaluate whether and how psychiatric symptoms are affecting the decision-making process. For women with prior histories of psychiatric disorder who become pregnant, healthcare directives stating treatment preferences can be written in anticipation of possible relapse, Coverdale et al. 1997. For women with extreme anxiety about obstetric interventions, example in cases of post-traumatic stress disorder, helping them gain and maintain a sense of control is helpful. This can be facilitated, for example, by avoiding unnecessary vaginal examinations, preparing them emotionally for necessary examinations, getting explicit permission to touch them before 62 Psychological Aspects of Women's Healthcare, second edition doing so, and maintaining their active involvement in decision-making throughout the pregnancy, Rhodes and Hutchinson 1994. After difficult labors, postnatal debriefing either individually or in a group may prevent the later development of anxiety symptoms, Ralph and Alexander 1994. For patients who require psychiatric hospitalization during pregnancy, setting up collaborative links between mental health, obstetric, and pediatric staff can facilitate optimal care, Miller 1992, McTatter et al. 1986. In some cases, hospitalization can be avoided with prenatal home visits by case managers and nurse midwives, such as for women with agoraphobia. Major mental illness during pregnancy raises questions about a woman's ability to care for her baby after birth. Assessment of parenting capability, Jacobson et al. 1997, followed by provision of extra social support and parenting rehabilitation when needed, may decrease the possibility of custody loss and may improve the future course of the lives of the mother, the baby, and the rest of the family. References Afonso D., Lovett S., Paul S., et al., Predictors of Depression Symptoms During Pregnancy and Postpartum. J. Psychosome Obstet Gynecol 12:255, 271, 1991. Apfel R., Handel M.H., Madness and the Loss of Motherhood, Sexuality, Reproduction, and Long-Term Mental Illness. Washington, D.C., American Psychiatric Press, 1993. Apfel R., Kelly S., Frankel F., The Role of Hypnotizability in the Pathogenesis and Treatment of Hyperemesis Gravidarum. J. Psychosome Obstet Gynecol 5:179, 186, 1986. Bockrich L.L., Chronically Mentally Ill Women, An Overview of Service Delivery Issues, in Treating Chronically Mentally Ill Women. Edited by Bockrich L.L., Nadelson C.C. Washington, D.C., American Psychiatric Press, 1988, pp. 1-17. Barnett B., Jaffe, Doug and A.K., et al., Depressive Symptoms, Stress, and Social Support in Pregnant and Postpartum Adolescence. Archpediatra Adolesc Med 150:64, 69, 1996. Barnett B., Hannah B., Parker G., Life Event Scales for Obstetric Groups. J. Psychosome Rest 27:313, 320, 1983. Benjamin J., Benjamin M., Panic Disorder Masquerading as Preeclampsia. J. Obstet Gynecol Reprod Bile 51:81, 82, 1993. Berlin R.M., Sleepwalking Disorder During Pregnancy, A Case Report. Sleep 11:298, 300, 1988. Psychiatric Disorders During Pregnancy 63. Blau A., Welkowitz J., Cohen J., Maternal Attitude to Pregnancy Instrument. ArchGen Psychiatry 10:324, 331, 1964. Boyer D., Fine D., Sexual Abuse as a Factor in Adolescent Pregnancy and Child Maltreatment. FamPlan Perspect 24:4, 12, 1992. Brzezinka C., Hutter O., Beal W., et al., Denial of Pregnancy, Obstetrical Aspects. J. Psychosome Obstet Gynecol 15:1, 8, 1994. Brzozowski M., Follett H., Neonaticide, Clinical and Psychodynamic Considerations. JAM Academic Child Psychiatry 10:673, 683, 1971. Brunner D.P., Munch M., Biederman K. et al., Changes in Sleep and Sleep Electroencephalogram During Pregnancy. Sleep 17:576, 582, 1994 Cobaltier, Reynolds C.F., Kupfer D.J., et al., Childbearing in Women with and Without a History of Affective Disorder, I. Psychiatric Symptomatology. Compare Psychiatry 35:205, 214, 1994 Cobaltier, Reynolds C.F., Kupfer D.J., et al., Childbearing in Women with and Without a History of Affective Disorder, 2. Electroencephalographic Sleep. Compare Psychiatry 35:215, 224, 1994 B. Cohen L.S., Rosenbaum J.F., Heller V.L., Panic Attack, Associated Placental Abruption, a Case Report. J. Klin Psychiatry 50:266, 267, 1989 Coverdale J.H., McCullough L.B., Chervenak Fa, et al., Clinical Implications of Respect for Autonomy in the Psychiatric Treatment of Pregnant Patients with Depression. Psychiatrist 48:209, 212, 1997 Cowley D.S., Royburn P.P., Panic Disorder During Pregnancy. J. Psychosome Obstet Gynecol 10:193, 210, 1989 D. Matiner K., Leonards H., Nijis P., et al., Individual Coping Style and Psychological Attitudes During Pregnancy Predict Depression Levels During Pregnancy and During Postpartum. Acta Psychiatriscand 91:95, 102, 1995 Duker N., Nausea and Vomiting in Pregnancy, a review of the problem with particular regard to psychological and social aspects. BRJ Obstet Gynecol 102:6, 8, 1995 Dixon L.R., Miller W.H., Hyatt M.C., Pregnancy Complicated by Acute Mania and Preeclampsia. Psychosomatics 33:221, 224, 1992 Doliner L.J., Obstacles to the Care of Patients with Medical Psychiatric Illness on General Hospital Psychiatry Units. Gen Hosp Psychiatry 15:14, 20, 1993 Fairweather DVI, Nausea and Vomiting in Pregnancy. AMJ Obstet Gynecol 102:135 175, 1968 Finnegan P., McKinstry E., Robinson G. E., Denial of Pregnancy and Childbirth. Ken J. Psychiatry 27:672, 674, 1982 Finnerty M., Levin Z., Miller L.J., Acute Manic Episodes in Pregnancy. AMJ Psychiatry 153:261, 263, 1996 Fitzgerald C.M., Nausea and Vomiting in Pregnancy. BRJ Med Psychol 57:159, 165, 1984 Goodlin R.C., Pregnant Women with Munchausen Syndrome. AMJ Obstet Gynecol 153:207, 210, 1985 64 Psychological Aspects of Women's Healthcare, 2nd edition Gries E.J.L., Hauser R., Meyer J., Pregnancy and Estrogen-Induced Panic, Letter. AMJ Psychiatry 152:1688, 1995 Hopfall S.E., Ritter C., Lavin J., et al., Depression Prevalence and Incidence Among Inner-City Pregnant and Postpartum Women. J. Consult Clin Psychol 63:445, 453, 1995 Hot M., Orvieto R., Kaplan et al., Hyperemesis Gravidarum, a review. J. Reprod Med 39:605, 612, 1994 Ianka J., Lepkifker J., Danon P., et al., Obsessive Compulsive Disorder Limited to Pregnancy. Psych Other Psychosome 64:109, 112, 1995 Jacobson T., Effects of Postpartum Disorders on Parenting and on Offspring, in Postpartum Mood Disorders. Edited by Miller L.J. Washington, D.C., American Psychiatric Press, 1999, pp 119-139 Jacobson T., Miller L.J., Kirkwood K.P., Assessing Parenting Competency in Individuals with Serious Mental Illness, a Comprehensive Service. J. Ment Health ADM 24:189-199, 1997 Josephs L., Women and Trauma, a contemporary psychodynamic approach to traumatization for patients in the OB/GYN psychological consultation clinic. Bullman Clin 60:22, 38, 1996 Juriadine IJ, Obstetric Factitious Disorder and Munchausen Syndrome by Proxy. J. Nerve Mentis 181:135, 137, 1993 Kitamura T., Tota Ma, Shima S., et al., Early Loss of Parents and Early Rearing Experiences Among Women with Antenatal Depression. J. Psychosome Obstet Gynecol 15:133 139, 1994 Kumar R., Robson K. M., A Prospective Study of Emotional Disorders in Childbearing Women. BRJ Psychiatry 14435, 47, 1984 Kumar R., Robson K. M., Smith A. M. R., Development of a Self-Administered Questionnaire to Measure Maternal Adjustment and Maternal Attitudes During Pregnancy and After Delivery. J. Psychosome Rest 28:43, 51, 1984 Littner M. R., Brock B. J., Snoring in Pregnancy, Disease or Not. Chest 109:859, 861, 1996 Laub D., Pasita J. S., Morales M. C., et al., Self-Reported Snoring in Pregnancy, Association with Fetal Outcome. Chest 109:885, 889, 1996 Majoras P.W., Goes S.B., DeLong W.B., et al., Psychologic Factors and Psychiatric Disease in Hyperemesis Gravidarum, a follow-up study of 69 vomiters and 66 controls. AMJ Psychiatry 117:421, 428, 1960 Mameli N., Mison A., Munoz F., et al., Development and Use of a Self-Administered Questionnaire for Assessment of Psychologic Attitudes Toward Pregnancy and Their Relation to a Subsequent Premature Birth. AMJ Epidemial 13989, 998, 1989 McNeil T.F., Kij L., Malquist Larson A., Pregnant Women with Non-Organic Psychosis, Life Situation and Experience of Pregnancy. Acta Psychiatriscan 68:445, 457, 1983 McNeil T.F., Kij L., Malmquist Larson A., Women with Non-Organic Psychosis, Pregnancy's Effect on Mental Health During Pregnancy. Acta Psychiatriscan 70:140 148, 1984 Psychiatric Disorders During Pregnancy 65 Miller L.J., Psychotic Denial of Pregnancy, Phenomenology and Clinical Management. Hospital and Community Psychiatry 41:1233, 1237, 1990 Miller L.J., Comprehensive Care of Pregnant Mentally Ill Women. J. Ment Health Admin 19:170, 177, 1992 Miller L.J., Sexuality, Reproduction, and Family Planning in Women with Schizophrenia. Schizophobol 23:623, 635, 1997 Miller L.J., Finnerty M., Sexuality, Pregnancy, and Childrearing Among Women with Schizophrenia Spectrum Disorders. Psychiatrist 47:502, 506, 1996 McTatter S., Hammond M.W., Molnar G., Management of Psychotic Pregnant Patients in a Medical Psychiatric Unit. Psychosomatics 2731, 33, 1986 Nezaroglu F., Anemone R., Yari Uridabias J.A., Onset of Obsessive Compulsive Disorder in Pregnancy. AMJ Psychiatry 149:947, 950, 1992 Nicholson J., Geller J.L., Fisher W.H., et al., State Policies and Programs that Address the Needs of Mentally Ill Mothers in the Public Sector. Hospital and Community Psychiatry 44:484, 489, 1993 O'Brien B., Newton N., Psyche vs. Soma, Historical Evolution of Beliefs About Nausea and Vomiting During Pregnancy. J. Psychosome Obstet Gynecol 12:91, 120, 1991 O'Hara M.W., Social Support, Life Events, and Depression During Pregnancy and the Puerperium. ArchGen Psychiatry 43:569, 573, 1986 O'Hara M.W., Noon Aber DJ, Zekowski M., Prospective Study of Postpartum Depression, Prevalence, Course, and Predictive Factors. J. Abnorm Psychol 93:158, 171, 1984 O'Keefe St., Restless Leg Syndrome, a Review. Arch Intern Med 156:243, 248, 1996 Olson Me, Toepensprig B., Krell Ma, Prenatal Care and Delivery in an Agoraphobic Woman, a Case Report. J. Reprod Med 37:466, 468, 1992 Pyre K., New Strategies in the Treatment of Depression in Women. J. Clin Psychiatry 56, Supple 230, 37, 1995 Perry B., Postpartum Depression in Relation to Other Reproductive Cycle Mood Changes, in Postpartum Mood Disorders. Edited by Miller L.J. Washington, D.C., American Psychiatric Press, 1999, pp 21-45 Powers V.L., Zahorik P., Morrow B., An Evaluation of Residents' Recognition of Depressive Symptoms in Obstetrical Patients. J10 Med Association 86:147, 149, 1993 Ralph K., Alexander J., Born Under Stress. NIS Times 90:28, 30, 1994 Resnick P.J., Murder of the Newborn, A Psychiatric Review of Neonaticide. AMJ Psychiatry 126:1414, 1420, 1970 Rhodes N., Hutchinson S., Labor Experiences of Childhood Sexual Abuse Survivors. Birth 21:213, 220, 1994 Rudolph B., Larson G. L., Sweeney S., et al., Hospitalized Pregnant Psychotic Women, Characteristics and Treatment Issues. Hospital and Community Psychiatry 41:159 163, 1990-66 Psychological Aspects of Women's Healthcare, 2nd edition Sacker A., Dunn D.J., Crow T.J., Obstetric Complications in Children Born to Parents with Schizophrenia, a Meta-Analysis of Case Control Studies. Psychol Med 26:279, 287, 1996 Solomero M., Marcos T., Gutierrez F., et al., Factorial Study of the BDI in Pregnant Women. Psychol Med 24:1031, 1035, 1994 Saunders E., Neonaticides Following Secret Pregnancies, 7 Case Reports. Public Health Rep 104:368, 372, 1989 Sharma V., Prasad E., Effect of Pregnancy on 3 Patients with Bipolar Disorder. And Clin Psychiatry 739, 42, 1995 Snyder S., Unusual Case of Sleep Terror in a Pregnant Patient, Letter. AMJ Psychiatry 143:391, 1986 Spielvogel A., Hoener H.C., Denial of Pregnancy, a Review and Case Reports. Birth 22:220, 226, 1995 Spielvogel A., Weil J., Treatment and Outcomes of Psychotic Patients During Pregnancy and Childbirth. Birth 19:131, 137, 1992 Stewart D., Pregnancy and Schizophrenia. Kinfam Physician 30:1537, 1542, 1984 Stewart D., Possible Relationship of Postpartum Psychiatric Symptoms to Childbirth Education Programs. J. Psychosome Obstet-Gynecol 4:295, 301, 1985 Suzuki S., Dennerstein L., Greenwood K.M., et al., Melatonin and Hormonal Changes in Disturbed Sleep During Late Pregnancy. J. Pineal Res 15:191, 198, 1993 Villeponto V.A., Lydiard R.B., Laraya M.T., et al., The Effects of Pregnancy on Pre-Existing Panic Disorder. J. Clin Psychiatry 53:201, 203, 1992 Yoldas V., Iskin A., Yoldas T. et al., A Woman Who Did Her Own Caesarean Section. Lancet 348:135, 1996. 5 Psychotropic drugs and electroconvulsive therapy during pregnancy and lactation. Donna E. Stewart, MD, D.Psych, FRCPC. Gail Ehrlich Robinson, MD, D.Psych, FRCPC. Any discussion on the effects of psychotropic drugs in pregnancy and lactation must start by stating the limits to our knowledge. Many studies have failed to consider confounding variables such as diagnosis, maternal age, use of alcohol, tobacco, or street drugs, gravidity, socioeconomic status, previous pregnancy loss, genetic history, use of multiple drugs, timing of drug exposure, and dosage. Few prospective controlled studies of the treatment of psychiatric disorders in pregnant women are available. Altschuler et al. 1996. Moreover, drugs that consistently produce defects in other animals may not have similar effects in humans. Elia et al. 1987. It is wise to remember that the U.S. Food and Drug Administration, 1979, has not approved any psychotropic drugs for administration during pregnancy and urges caution in their use. A multidisciplinary task force is developing new guideline documents. Center for Drug Evaluation and Research, 1997. During the 1990s, patterns of psychotropic drug exposure in pregnancy changed. Selective serotonin reuptake inhibitors are now the most commonly prescribed antidepressant drugs, and a host of new anti-anxiety and psychotropic drugs have been approved for clinical use. 67-68 Psychological Aspects of Women's Healthcare, Second edition. Effects of pregnancy on drug metabolism, action, and side effects. Pregnant women may receive psychotropic drugs for several reasons. Some may be undergoing treatment with antidepressants, antipsychotics, mood stabilizers, or minor tranquilizers, either for an acute psychiatric illness or for maintenance therapy, when they become pregnant. Other women may develop a psychiatric illness that requires treatment during pregnancy or lactation. Robinson et al. 1986. The potential benefits of pharmacotherapy in the pregnant or lactating woman must be carefully weighed against the possible risks to the woman and her developing fetus or infant. The risk side of the risk/benefit equation includes the risks of maternal and newborn toxicity, side effects, and withdrawal, and fetal physical or behavioral teratogenicity. Cohen et al. 1989. Although the benefits of psychotropic drugs for the severely psychotic, depressed, or suicidal pregnant woman may outweigh the risks to the infant, a careful appraisal of current knowledge in this area is essential before a rational clinical decision can be reached. Robinson et al. 1986. This chapter contains current information on the use of antipsychotics, antidepressants, mood stabilizers, and anxiolytics during pregnancy and lactation. Use of electroconvulsive therapy, ECT, in pregnancy is also discussed. Despite public education, drug use in pregnancy is still commonplace. Because more than 50% of pregnancies are unplanned, many drug exposures will occur before the pregnancy is even diagnosed. Rayburn et al., 1982, showed that 90% or more of all pregnant women take one or more drugs in addition to dietary supplements during pregnancy. In a North American study, Heinonen et al., 1977, reported that 36% of pregnant women took sedatives, tranquilizers, or antidepressants at some time during their pregnancies. Several physiologic changes in pregnancy alter the effects of drugs. Data on drug metabolism rates, dosages, and side effects in non-pregnant women may not apply to pregnant women. The significant increases in total body water content that occur during pregnancy may result in lower drug serum concentrations than are found in non-pregnant women. Total protein is also reduced in pregnancy, thereby altering drug binding. A physiologic drop in blood pressure in the second trimester of pregnancy may result in orthostatic hypotension, causing significant problems in pregnant women treated with some antipsychotic and tricyclic antidepressant drugs. The emptying rate of psychotropic drugs and ECT during pregnancy and lactation. 69 The gastrointestinal tract is decreased by 30%, 50%, and gastric acid is decreased, thus altering drug absorption. Constipation, a common condition in pregnancy, may be worsened by medications with anticholinergic side effects. Glomerular filtration rates are increased in pregnancy, causing some drugs such as lithium to be excreted more quickly and thereby requiring higher doses to achieve therapeutic serum levels. Hepatic hydroxy losses involved in drug metabolism may be inhibited during pregnancy, Mortala 1989, Wisner and Pearl 1988. The physiologic changes of pregnancy necessitate careful monitoring of a woman's drug response, side effects, and toxicity throughout the pregnancy and early postpartum period, Wisner and Pearl 1988. Higher doses are sometimes required in pregnancy to achieve therapeutic serum levels. After delivery, the doses may need to be decreased to prevent maternal toxicity, Copland 1983, Stewart 1988. All psychotropic drugs cross the placenta and enter the fetal circulation to some degree. The penetration to the fetal compartment is influenced by the characteristics of the drug, the dosage, and the stage of pregnancy, Merkin 1976. When repeated doses of a psychotropic drug are administered to sustain plasma concentrations, the drug is usually distributed equally to mother and fetus, G. H. Levy 1981. Both the placenta and the fetus have enzyme systems involved in drug metabolism, but many details are as yet incompletely understood, Chow and Jicha 1983. It is also known that some enzyme systems are not mature at birth, impairing the ability of the newborn's liver to conjugate the metabolites of common drugs such as diazepam, Canto 1982. Thus, fetal physiology must also be considered in prescribing psychotropic drugs in pregnancy. General effects on the fetus and neonate: morphologic teratogenicity during the first several cell divisions. The developing embryo is thought to be protected against the effects of drugs administered to the mother because the placenta has not yet formed. This period of protection is between conception, approximately day 14, and the first missed period, approximately day 28 of a 28-day cycle. After the first missed period, however, the placenta is sufficiently developed to transfer drugs in the maternal circulation to the developing fetus, Cohen 1989. 70 Psychological Aspects of Women's Healthcare, 2nd edition. It is impossible to guarantee that any psychotropic drug is not teratogenic and able to cause fetal deformity because the baseline rate of birth defects in the Western world is approximately 3%, and the cause of most birth defects remains unknown, Bealey 1986. Although the incidence of birth defects caused by drugs is probably low, low levels of teratogenicity caused by drugs are extremely difficult to distinguish from the spontaneous occurrence of anomalies and require large exposure samples, American Medical Association 1983. Several factors, however, are known to increase the teratogenic risks of a drug. 1. Exposure to the drug during organogenesis, central nervous system, gestational days 10 to 25, limb development, days 24 to 26, cardiovascular system development, days 20 to 40. 2. Dosage and regularity of use. Lack of maternal toxicity does not indicate lack of fetal toxicity. 3. Interaction with other environmental factors, such as other drugs, alcohol, tobacco, and other toxins. And 4. The genetic constitution of the mother and fetus. It is hypothesized that the continuum of abnormal development ranges from fetal death, resulting in miscarriage or stillbirth, to physical malformation, growth retardation, or functional deficits. Behavioral teratogenicity, J. G. Wilson 1977. Behavioral teratogenicity. The rapidly developing field of behavioral teratogenicity includes functional deficits such as delayed behavioral maturation, abnormal activity, and impaired problem solving and learning, all of which may develop following fetal exposure to teratogens, Voorhees and Butcher 1982. Research in animals has shown that most drugs that act on the central nervous system have a low potential for physical teratogenicity but a higher potential as behavioral teratogens, which probably arises from less severe damage, Voorhees and Butcher 1982. Many behavioral teratogenic agents may not yet have been identified in humans because they are unaccompanied by physical malformation. Few studies on the long-term follow-up of children exposed to psychotropic drugs in utero are available. See specific information on major tranquilizers, antidepressants, and lithium in the section on known effects of specific psychotropic drug groups in this chapter. Other investigators have criticized the available studies for their small sample sizes, lack of data on dosage and timing, circumscribed inquiry, lack of standardized psychometric instruments, and inadequate follow-up period, Edlund and Craig 1984. It is therefore unwise to assume that any psychotropic agent is safe in pregnancy, Wisner and Pearl 1988, although the use may be appropriate in many clinical situa psychotropic drugs and ECT during pregnancy and lactation 71 chins. Use of psychotropic drugs during pregnancy and lactation should include thoughtful weighing of risks of prenatal exposure versus risks of maternal mental illness or relapse following drug discontinuation, Altshuler et al. 1996. Effects of psychotropic drugs during second and third trimester and labor. Psychotropic drugs appear to be safer during the second and third trimester of pregnancy. Major malformations are not produced during the second and third trimesters, but drugs can affect the growth and functional development of the fetus. In particular, the central nervous system continues to develop throughout pregnancy and the neonatal period, and damage after the first trimester can produce microcephaly, mental retardation, Bealey 1986, and behavioral teratogenicity. Some clinicians recommend that the drug doses be lowered or discontinued approximately 2 weeks prior to the expected date of delivery to reduce the possibility of side effects, toxicity, and withdrawal in the newborn, Kearns 1986, Robinson et al. 1986, Wisner and Pearl 1988, whereas other experts do not discontinue psychotropic drugs before labor in order to reduce the risk of in vitro fetal withdrawal or maternal relapse of psychiatric illness, Altshuler et al. 1996. Both the major and the minor tranquilizers have been used by obstetricians during labor to reduce anxiety, increase relaxation, or decrease nausea. Long-acting benzodiazepines, however, should be avoided in the third trimester because they adversely affect the neonate, Mandrelli et al. 1975. If benzodiazepines are required, they should be used in the lowest effective dose for the shortest period of time necessary to minimize fetal exposure, Altshuler et al. 1996. Effects on the neonate. Antipsychotics, tricyclic antidepressants, and benzodiazepines are lipid-soluble and largely protein-bound and are slowly eliminated from the newborn. The neonate may be more susceptible to these drugs because liver enzymes are not fully developed, plasma protein concentrates are lower, leading to increased free drug available to act on the brain, the blood-brain barrier is incomplete, and the immature central nervous system may be more sensitive to these drugs, Altshuler et al. 1996, Nahas and Gujard 1978. 72 Psychological Aspects of Women's Healthcare, 2nd edition. Effects during lactation. Psychotropic drugs, like most medications, are excreted to some degree in breast milk. The concentration of the drug in breast milk depends on its solubility, protein binding, and drug pH compared with plasma, Robinson et al. 1986. There are wide variations among drugs, and concentrations may vary in breast milk samples taken at different times of the day. The American Academy of Pediatrics Committee on Drugs, 1994, has classified major and minor tranquilizers and antidepressants under the category of drugs whose effects on nursing infants is unknown but may be of concern. Various case reports of toxic effects, drowsiness, impaired temperature regulation, and no ill effects have been described in breastfed infants of mothers receiving psychotropic or mood-stabilizing drugs, Gellenberg 1987. The effects of these drugs on the immature neurotransmitter system are unknown, Mortala 1989, Robinson et al. 1986. Wisner et al. 1996, reviewed the use of antidepressants during lactation, and although they found limited findings to be reassuring, they recommended an expanded database of mother-baby serum levels, behavioral assessments of babies during nursing and longitudinal development, and evaluation of nurslings. Known effects of specific psychotropic drug groups. Antipsychotic agents. Teratogenicity. Numerous reports in the literature describe individual or short series of cases in which the use of neuroleptics in the first trimester has coincided with the occurrence of congenital anomalies, Table 5:1. Results of larger studies are conflicting. The French National Institute of Health and Medical Research conducted a retrospective study involving 12,764 births, Rumi Auroquet et al. 1977. Infants in the control group demonstrated congenital malformation not considered to be related to chromosomal abnormalities in 1.6% of cases. Of the 315 women who received phenothiazines during the first trimester, 3.5% gave birth to malformed infants. This was considered a statistically sig. Table 5:1. Psychotropic drugs in pregnancy and lactation. Teratogenicity effects on the neonate lactation. Antipsychotics. Phenothiazines, especially aliphatics, congenital anomalies increased if used third trimester. Use of neuroleptics May weeks 6 to 10. Cardiovascular anoma cause extrapyramidal symptoms in inleys increased. Use with caution. Infant, excessive crying, motion, hyper first trimester. Appears to be fairly tonia, hyperreflexia, respiratory safe. Distress, vasomotor instability, and slow early learning tasks. Jaundice possible, especially in prematures. Excreted in breast milk. No serious side effects reported as yet. Increased drowsiness. Use with caution. Butyrophenones. No evidence at present for teratogenicity. Haloperidol toxic in animal studies. Use with caution. Clozapine, olanzapine, risperidone, quetiapine unknown. Effects unknown. Effects unknown. Antidepressants. Tricyclics and heterocyclics. No link with fetal deformity or limb withdrawal symptoms in infant. May excreted in breast milk. No ephdysgenesis. Use with caution. In first include heart failure, tachycardia, effects shown for amitriptyline, trimester. Appears to be fairly safe. Myoclonus, seizures, respiratory dysnortriptyline, desipramine, clot res, urinary retention, cyanosis, mipramine, or dithiopin. Irritability, feeding difficulty. Serotonin reuptake inhibitors. Caution in first trimester. Data on fluoxetine exposed infants show no small amounts in breast milk. Fluoxetine, paroxetine, sertraline, difference up to school age compared. Early data show no serious and fluvoxamine show no evidence with control subjects. Other drugs. Effects for sertraline, fluoxetine, of malformation. Appear fairly safe. Unknown. Or paroxetine. Monoamine oxidase inhibitors. Phenylzyme teratogenic in animals. Avoid in first trimester. Effects unknown. Psychotropic drugs and ECT during pregnancy and lactation. Drugs. Effects unknown. 73-74 Table 5:1. Psychotropic drugs in pregnancy and lactation, continued. Drugs. Effects on the neonate lactation. Lithium carbonate. Increased cardiovascular anomalies. Use with caution in first trimester. Give in small divided doses if necessary. Refer for fetal ultrasonography. Third trimester use may cause hypo excreted in breast milk. Severe tonia, lethargy, cyanosis, poor sucking, toxic reactions. Contraindicate shallow respiration, low APGAR score, ED while breastfeeding. Arrhythmias, hypotension. Valproic acid. Spina bifida reported, 1%, 5%. Effects unknown. Carbamazepine. Craniofacial defects and spina bifida effects unknown. Ported. Mood stabilizers. Limited data compatible with breastfeeding. American Academy of Pediatrics, limited data compatible with breastfeeding. American Academy of Pediatrics, anxiolytics. Benzodiazepine. Safety in first trimester not established. With chronic use in pregnancy, with excreted in breast milk. Lesser incidence of cleft lip/palate may be. Indrawal symptoms include tremor, GY, jaundice, poor temperature, creased hypertonia, and hyperreflexia. High regulation possible. Long half doses prior to delivery result in low-life drugs contraindicated while APGAR scores, hypothermia, and new breastfeeding. Rheologic depression. Floppy infant syndrome, decreased sucking rate, and jaundice possible. Meprobomates cleft lip/palate, and other severe congenital anomalies possible. Do not use. Psychological aspects of women's healthcare, 2nd edition teratogenicity table 5:1. Psychotropic drugs in pregnancy and lactation, continued, teratogenicity effects on the neonate lactation barbiturates associated with dose-related growth chronic use in pregnancy associated long-term effects unknown. Retardation, facial dysmorphism, oral with withdrawal in infant 10 to 14 days clefts, and skeletal anomalies when after birth, increased tone, tremor, used in first trimester. And irritability. Hydroxyzine teratogenic in animals. Antiparkinsonian agents no studies. Usually given with effects unknown. Neuroleptic. Amantadine teratogenic in animals. Cardiovascular malformation. Jitteriness, myoclonic jerks, and hypotonia possible after large doses prior to delivery. Effects unknown. Psychotropic drugs and ECT during pregnancy and lactation drugs 75-76 Psychological aspects of women's healthcare, 2nd edition significant increase in malformations, especially following the use of aliphatic phenothiazines, but it is not clear whether confounding variables such as dosage, concurrent drugs, and maternal health and age were taken into account. Sloan et al., 1977, reported the results of the collaborative perinatal project of 5,282 gravidas and their children, including 1,309 cases of prenatal exposure to phenothiazines. The authors found no significant increase in the incidence of congenital malformations related to exposure in the first trimester except for a questionable association with cardiovascular malformations. Perinatal mortality rate, birth weight, and IQ at age 4 were all found to be normal in this group. The California Child Health and Development Project, which studied over 19,000 births, originally showed no increase in congenital anomalies following phenothiazine use in pregnancy, Milkovich and Van den Berg 1976. On reanalyzing the data, Ed Lund and Craig, 1984, demonstrated a trend toward increased congenital anomalies when the drugs were given after 4 weeks, the most critical period being from 6 to 10 weeks gestation. The exposed samples yielded an incidence of congenital anomalies of 5.4% versus 3.2% in the control subjects. Studies to date have not revealed a significant increase in fetal abnormalities for pregnant women receiving thioridazine, perfenazine, trifluoperazine, fluphenazine, or haloperidol, Anant 1975, Goldberg and Damasio 1978. No evidence has been found of teratogenicity for the dibenzoxazepanese, dioxanthenes, or diphenylbutylpiperidines. Their safety in pregnancy, however, has not been established. Caution must be exercised in drawing conclusions from these studies. Ed Lund and Craig, 1984, and others have pointed out numerous confounding methodologic errors. Many studies may have minimized potential effects by looking at non-psychotic populations using small amounts of drugs as antiemetics or anxiolytics rather than the dosages typically used to treat psychoses. There is also some evidence that children of psychotic women have a higher risk of fetal damage independent of drug exposure. Stewart 1984, WREDEETAL 1980. On the basis of available data, it appears that psychotic illness per SE may confer the greatest increase in risk of poor fetal outcome. Perinatal exposure to low-potency phenothiazines may confer an additional risk of poor outcome in 4/1,000 patients, 0.4%. Altschuler et al. 1996. In general, the higher potency drugs such as haloperidol appear to be safer. However, little data are yet available on clozapine, olanzapine, risperidone, or quizapine. Psychotropic drugs and ECT during pregnancy and lactation. 77 effects on the neonate. The use of neuroleptics in the last trimester has been reported to cause extrapyramidal symptoms in the neonate, sometimes lasting up to 6 months. W. Levy and Wisniewski, 1974. Infants regularly exposed to neuroleptics in the third trimester may be especially difficult to care for because they may suffer from excessive motion, crying and sucking, hypertonicity, hyperreflexia, and vasomotor instability. Brazelton, 1970, found effects on neonatal weight, response to nursing, and early learning tasks, but these seem to occur only in the immediate postnatal period. Effects on breastfeeding infants. The quantity of major tranquilizers excreted in breast milk is usually less than 30% of the maternal plasma concentration, Anant, 1978. An exception may be haloperidol excretion, which was reported in one case study to be approximately 60%, Wally et al. 1981. Aside from some drowsiness with chlorpromazine and some galactorrhea with chlorpromazine and thioridazine, no significant human neonatal side effects have been reported despite several large studies, Anant, 1978. Some studies in animals, however, have shown behavioral abnormalities in offspring following administration of haloperidol during lactation, Anant, 1978. Infants who are breastfed while their mothers are receiving major tranquilizers should be carefully clinically monitored. Serum levels in the infant may be helpful in assessing risk and drowsiness. Long-term effects on children exposed in utero. Sloan et al., 1977, studied 4-year-old children whose mothers had received phenothiazines during pregnancy and found their IQ scores to be the same as those of a control population. Chris, 1965, followed up a small sample of children who had been exposed to 50 to 150 milligrams chlorpromazine in utero and found the children to be healthy with normal behavior. The flaws of these studies are described in the behavioral teratogenicity section earlier in this chapter. Antidepressants. Teratogenicity. Crombie et al., 1975, reviewed 10,000 pregnancies in England and Wales, and Ginsberg and Knox, 1972, reviewed another 15,000 pregnancies in 78 psychological aspects of women's health care, 2nd edition, Scotland. The Finnish Register of Congenital Malformations for 1964 to 1972 was used by Iden Ponhikala and Saxon, 1973, to analyze 2,784 cases of birth defects and an equal number of matched control births. No link was found between fetal deformities, including limb dysgenesis, and the use of tricyclic antidepressants in pregnancy in these studies. The Collaborative Perinatal Project, Heinonen et al. 1977, prospectively examined the relationship of tricyclic antidepressants to pregnancy outcome, but the numbers were too small to justify generalizations. The European Network of the Teratology Information Services has prospectively collected and evaluated data on 689 pregnancies exposed to tricyclic and non-tricyclic antidepressants. The incidence of spontaneous abortion and late fetal/neonatal deaths was within normal limits. 2/3 of mothers were receiving multiple drugs and 95% were exposed in the first trimester. Of infants without malformations, 31 had neonatal problems associated with chronic multi-drug use, especially near-term. Evaluated after the first few weeks of postnatal life, 97% of live-born babies were morphologically normal and there was no increase in particular malformations or patterns of defects, McElhatton et al. 1996. A prospective study from a drug exposure in pregnancy registry was unable to demonstrate any teratogenicity following first trimester exposure to fluoxetine, Pastisak et al. 1993. A study of infants exposed to fluoxetine in utero showed no increased rate of major birth defects but found higher rates of minor abnormalities, preterm births, low birth weights, and admissions to special nurseries, Chambers et al. 1996. However, this study did not control for depression effects, was randomized, and the women receiving fluoxetine were older than control mothers. A well-designed study of infants exposed to tricyclic drugs or fluoxetine in utero was unable to demonstrate any teratogenic, birth weight, APGAR score, language development, IQ, or social development changes in exposed infants followed up to school entry compared with unexposed control infants, Nullman et al. 1997. A recent meta-analysis of epidemiologic studies showed no association between first trimester fluoxetine use and human teratogenic effects, Addis and Corin 2000. In another study, no congenital anomalies were found in 63 infants exposed to paroxetine in the first trimester, Inman et al. 1993. A recent study of exposure to sertraline, 147 women, paroxetine, 97 women, and fluvoxamine, 26 women, showed no increase of infant teratogenicity at birth, Colon et al. 1998. Inadequate data are available to evaluate new antidepressants such as bupropion, trazodone, buspirone, nefazodone, mirtazapine, or venlafaxine. Monoamine oxidase inhibitors have been shown to have teratogenic properties, Heinonen et al. 1977, Polson and Robson 1964. Although the number psychotropic drugs and ECT during pregnancy and lactation 79 bears in these studies are small, it is probably wise to use other antidepressants in pregnancy. Stimulants such as methylphenidate or amphetamines are also used to treat depression. Unfortunately, most case reports of their use in pregnancy are from women who abused these drugs. In large doses these drugs are associated with fetal growth retardation, premature delivery, irritability, jerkiness, shrill cries, lassitude, and apnea, Briggs et al. 1994, Oro and Dixon 1987. One study found medical use of amphetamines to be associated with fetal oral clefts, Milkovic and Van den Berg 1977. Effects on the neonate withdrawal symptoms, irritability, and convulsions in the neonate have been reported following the use of desipramine, imipramine, and nortriptyline during pregnancy, Shearer et al. 1972, Webster 1973. There have been case reports of infants born with heart failure, tachycardia, bowel obstruction, respiratory distress, and urinary retention. Signs of toxicity in the infants of mothers taking large amounts of these medications just before delivery may include breathlessness, cyanosis, tachypnea, irritability, seizures, and feeding difficulties, Anant 1976, Egermont et al. 1972. More admissions to special care nurseries were reported in infants exposed to fluoxetine in utero, Chambers et al. 1996. Effects on breastfeeding infants. Controversy exists concerning the effects of antidepressants on breastfeeding infants. Sovner and Orsulak, 1979, suggested that amounts of imipramine and desipramine in breast milk samples are similar to those found in plasma and recommended that women not breastfeed while receiving antidepressants because of concern about subtle effects on the neurologic or behavioral maturation of the infant. Wisner et al., 1996, 1999, critically reviewed the literature on antidepressants during lactation and reported that amitriptyline, nortriptyline, desipramine, clomipramine, dithiopin, and sertraline were not found in quantifiable amounts in nurslings and no adverse effects were reported. The authors felt these were the drugs of choice for breastfeeding women. Adverse effects were reported in some young infants whose mothers has been treated with doxepin or fluoxetine during breastfeeding. However, they found that infants older than 10 weeks showed no accumulation of drugs and were at low risk for adverse effects. Moreover, Chambers et al., 1999, found lower weight 80 psychological aspects of women's health care, second edition gain in 26 breastfed infants whose mothers were receiving fluoxetine. However, Stowe et al., 2000, found only low concentrations of paroxetine in infants' serum and a lack of any observable adverse effects after maternal use while breastfeeding. Current information, therefore, does not warrant an absolute recommendation on the use of antidepressant drugs in women who are breastfeeding, because the risk-benefit ratio must be assessed on an individual basis. Infants who are breastfed while their mothers are receiving antidepressants should be carefully clinically monitored, and infant serum levels of antidepressants should be measured in cases of extended drug exposure. Birnbaum et al. 1999. The American Academy of Pediatrics, 1994, does not believe that maternal antidepressant use precludes breastfeeding, but it classifies antidepressants as drugs whose effects on nursing infants are unknown but may be of concern. Lithium, carbamazepine, and valproic acid teratogenicity. Weinstein, 1980, reviewed the records of the International Register of Lithium Babies and found an 11% rate of malformation in 225 exposed infants. Of these malformations, 8% were Ebstein's anomaly or other major cardiovascular malformations. Ebstein's anomaly is a rare condition that occurs in one infant per 20,000 live births. Subsequent investigators, Collin and Tandberg 1983, also reported that exposure to lithium is linked to cardiovascular anomalies, resulting in a contraindication for lithium in the first trimester. Two more recent studies, Jacobson et al. 1992, Zalstein et al. 1990, however, suggested that the link to Ebstein's anomaly is much weaker than previously reported. A pooled overview of studies suggests the risk of Ebstein's anomaly following first trimester lithium exposure is 10 to 20 times as common as in the general population, 0.1%. Altschuler et al. 1996. Therefore, in women with unstable bipolar disorder or a recent severe affective illness, it may be reasonable to continue lithium and screen for cardiovascular effects with a targeted ultrasound at week 18 of gestation. The use of lithium in the second and third trimesters may infrequently cause a large fetal goiter that may necessitate a cesarean section, Nars and Gerard 1977, or may cause cardiac arrhythmias, Llewellyn et al. 1998. Carbamazepine, previously considered safe in pregnancy, has now been associated with fetal craniofacial defects, developmental delay, nail hypoplastic drugs and ECT during pregnancy and lactation. 81 SIA, Jones et al. 1989, and spina bifida, Rosa 1991. Caution should be exercised until further data are available. Valproic acid, another mood stabilizer used in bipolar affective disorder, has been associated with spina bifida in 1%, 5% of the offspring of mothers treated during the first trimester. The risks of valproic acid are even greater than those of lithium for teratogenic potential, and its use is probably contraindicated in pregnancy. Several other malformations, including ear rotation, short nose, depressed nasal bridge, elongated upper lip, and fingernail hypoplasia, have been described in infants with in utero exposure to anticonvulsants. Gailey and Grandstrom 1992, Skonik et al. 1994. Effects on the neonate. Life-threatening toxicity from lithium has been noted in some newborns of mothers receiving lithium in the third trimester, particularly when maternal lithium levels exceed therapeutic levels. Morel et al. 1983. Affected babies may show hypotonia, lethargy, cyanosis, depressed APGAR scores, hypotension, cardiac arrhythmias, poor sucking reflex, and shallow respiration. Anunk 1976, Llewellyn et al. 1998, and Wilson et al. 1983. Lithium levels may remain high for more than a week. The serum half-life in infants has been estimated at 96 hours. McKay et al. 1976. Effects on breastfeeding infants. Levels of lithium in breast milk average 40%, 50% of those in maternal serum, and levels in infant serum are approximately equal to those in breast milk. Sko and M. Dyson 1973. Lithium in breast milk has been associated with cyanotic episodes, lethargy, hypothermia, and hypotonia in the neonate. Tunnison and Hertz 1972. Because the long-term effects of lithium on neonates are unknown, mothers receiving lithium are advised not to breastfeed. Anunk 1978, Robinson et al. 1986, Wisner and Pearl 1988. Use of lithium during lactation is considered contraindicated by the American Academy of Pediatrics, 1994. Valproic acid and carbamazepine are considered compatible with breastfeeding by the American Academy of Pediatricians, 1994, but the available data are very limited. Long-term effects on children exposed in utero SCO, 1976, discovered no significant differences in physical or mental anomalies at age 5 between children exposed to lithium in utero and their UN-82 Psychological Aspects of Women's Healthcare, second edition exposed siblings. This study was too poorly designed, however, to draw definitive conclusions. Anxiolytics teratogenicity. Several studies have yielded conflicting evidence about the relationship between the use of benzodiazepines during pregnancy and the occurrence of fetal malformations, especially cleft lip with or without cleft palate. In a pooled overview of studies, Ottarskog 1975, Legriot et al. 1990, Rosenberg et al. 1983, Safra and Oakley 1975, Saxon and Saxon 1975, St. Clair and Schirmer 1992, use of benzodiazepines in first trimester increased the odds of having oral clefts. Because the subjects were heterogeneous, several benzodiazepines were studied, and the anomalies were reported in different drugs. The final answer to the oral cleft question remains uncertain and caution should be exercised. The literature on in utero benzodiazepine exposure and behavioral teratogenicity in humans is limited, but some studies suggest that benzodiazepine exposure may cause developmental delays. Vegetal et al. 1993. Effects on the neonate. Benzodiazepines that are lipid-soluble and have a low molecular weight can easily cross the placenta, especially late in pregnancy, Canto 1982. The long half-lives of these drugs may result in marked accumulation in the mother and the fetus when regularly administered, Merkin 1976. Chronic use of diazepam throughout pregnancy has been reported to lead to withdrawal symptoms including tremor, hypertonia, and hyperreflexia lasting up to 8 weeks in the neonate, Volpe 1981. These irritable infants are difficult to care for. Mandrelli et al. 1975, reported hypotonia, low APGAR scores, hypothermia, impaired response to cold, and neurologic depression in infants whose mothers had received high doses of diazepam prior to delivery. The muscular hypotonia sometimes found in these infants has been labeled floppy infant syndrome, Gilberg 1977. Use of injectable diazepam at delivery has been linked to kernicterus because of competition between bilirubin and the preservative sodium benzoate, Schiff et al. 1971. Long-acting benzodiazepines should be avoided in the third trimester because they may inhibit newborn respiration and diminish responsiveness immediately after birth. Moreover, the immature liver has difficulty metabolizing these drugs, Canto 1982. Larger doses of diazepam may result in low APGAR scores at birth, apneic spells, hypotonia, psychotropic drugs and ECT during pregnancy and lactation 83 and poor sucking, Cree et al. 1973. All sedative drugs have been associated with decreased newborn sucking rates, Canto 1982. Chronic use of barbiturates prior to delivery can lead to withdrawal symptoms in the newborn that may not occur until 10 to 14 days after birth. Symptoms may include tremulousness, crying, irritability, hyperphagia, and increased tone, Hill and Stern 1979. Effects on breastfeeding infants. Benzodiazepines constitute a risk to nursing newborns because they produce lethargy and impaired temperature regulation. They are not metabolized in the fetal liver or gut, and from days 1 to 4 the infant is unable to conjugate them with glucuronic acid, which may result in newborn jaundice, Canto 1982. If a mother needs benzodiazepines on a prolonged basis, breastfeeding is contraindicated because of the possibility of accumulation and lack of data on the effects of long-term exposure through breast milk, Mortala 1989, Robinson et al. 1986. When given to the nursing mother in therapeutic doses, phenobarbital appears to have little or no demonstrable effect on the infant, but long-term effects are unknown, Anant 1978. Agents used to treat the extrapyramidal side effects of neuroleptics. Few studies are available on the specific teratogenicity of agents used to treat the extrapyramidal side effects of neuroleptics in the first trimester because these agents are co-administered with neuroleptics. Some reports link diphenhydramine to congenital anomalies, Heinen et al. 1977, and cardiovascular malformation has been reported in an infant exposed to amantadine during the first trimester, Nora et al. 1975. Guidelines for the clinical use of psychotropic drugs. The goals for treating psychiatric disorders in pregnancy may be altered to achieve control of symptoms rather than complete remission. Non-pharmacologic strategies, such as cognitive behavioral therapy, interpersonal therapy, dynamic psychotherapy, family therapy, marital therapy, light therapy, ECT, environmental support, and sometimes hospitalization, may be preferable to 84 Psychological Aspects of Women's Health Care, 2nd edition. The use of drugs in first trimester, Mortala 1989, Nurnberg and Prudhomme 1984, Wisner et al. 1999. Despite these strategies, psychotropic drugs are sometimes required, particularly if the woman is so severely depressed or psychotic that her well-being or that of her fetus is in jeopardy. Altschuler et al. 1996. A severely ill woman may fail to eat properly, may not attend appointments for prenatal care, and may respond to command hallucinations to harm herself or her fetus. The American Medical Association, 1983, recommends the following guidelines for physicians when prescribing drugs to women of childbearing age or those who are already pregnant. 1. Avoid unnecessary exposure to drugs and select those drugs with the most favorable risk/benefit ratios. 2. Inform patients of the implications of drug exposures in pregnancy. 3. When drugs are necessary, advise patients of the need for contraceptive measures when indicated. And 4. Identify and report any birth defects. In general, psychotropic drugs should be used in pregnancy only when they are clearly indicated for the prophylaxis or treatment of psychiatric illness, and then only in the lowest effective doses for the shortest period of time necessary. An individual risk/benefit appraisal is required. Because of altered pharmacokinetics and metabolism during pregnancy, higher doses may be required than are used in non-pregnant women. It is generally believed that divided maternal doses have less effect on the fetus than once-daily dosing schedules. New drugs should be avoided until safety and side effects have been well established through use in non-pregnant women. Wisner and Pearl 1988. Antipsychotics. Few data support the choice of one antipsychotic over another during pregnancy. Halogenated phenothiazines, however, appear to slightly increase teratogenicity. Rumi Auroquette et al. 1977. We favor high-potency agents because they usually cause fewer autonomic, anticholinergic, hypotensive, sedative, and cardiovascular side effects. We currently prescribe haloperidol during pregnancy and lactation in the lowest effective divided dose and try to avoid its use in the first trimester when possible. Antidepressants. Because the dose, response curves and therapeutic efficacy of any antidepressant have not yet been established in pregnancy, the choice of which of these drugs to use is primarily based on side effects and safety. We tend to favor psychotropic drugs and ECT during pregnancy and lactation. 85-nortriptyline, desipramine, or fluoxetine during pregnancy and lactation because of their reduced side effects, including hypotension, better published evidence for safety, and the correlation between serum levels and therapeutic effect. Tricyclic antidepressants and fluoxetine have the most robust published, long-term, neurobehavioral data on exposed infants. Nullman et al. 1997. We administer the lowest effective dose and try to avoid first trimester exposure when possible. We avoid maproteline because maternal seizures have been reported. Edwards 1979. And monoamine oxidase inhibitors because they may be teratogenic. Heinen et al. 1977. Data evaluating some of the newer serotonin reuptake inhibitors or reversible monoamine oxidase inhibitors in pregnancy are still insufficient. Lithium and carbamazepine. General recommendations for use of lithium in women of childbearing age include the following. 1. The drug should be given for unequivocal indications. 2. Patients should be warned of the possible teratogenic and toxic effects on the fetus. 3. Effective contraception should be encouraged. 4. The drug should be gradually withdrawn in first trimester in cases of unexpected pregnancy, except in severe or unstable bipolar illness. And 5. Referral for a targeted ultrasound. Examination to detect fetal cardiovascular malformations should be considered. Gellenberg 1983, Llewellyn et al. 1998, Weinstein 1980. A recent study showed that recurrence risks for bipolar disorder rose sharply in the postpartum period when lithium was discontinued during pregnancy. Vigora et al. 2000. Recurrence risk was greater after rapid discontinuation than after gradual discontinuation. We reserve lithium in pregnancy and lactation for patients with unstable or severe bipolar disorder and usually taper the dose by 30% the week before the expected due date to reduce the risk of toxicity. Recent studies suggest that lithium may be less teratogenic than previously thought. See earlier discussion. Patients maintained on lithium should be closely monitored and targeted ultrasounds should be performed at gestational week 18 to examine for cardiovascular malformation. Weinstein, 1980, has suggested that when lithium is used in pregnancy, sodium-depleting diuretics and low-salt diets should be avoided. Serum lithium levels should be closely monitored, at least once per month in early pregnancy and weekly toward the end. Care should be taken to distinguish the nausea and vomiting of pregnancy from those associated with lithium toxicity. Serum levels should be kept at the lowest effective level, and Lithium 86 Psychological Aspects of Women's Health Care. Second edition should be given in 3 to 5 equal doses not exceeding 300 mg/dose. Lithium levels should be carefully monitored after delivery to avoid toxicity because physiologic fluid shifts occur. We reserve carbamazepine and valproate for women who have lithium-resistant unstable bipolar disorder. We augment with folate, 4 mg per day in the hope that this may reduce the risk of neural tube defect. An ultrasound is performed at gestational weeks 10 to 19 to rule out neural tube defect and other congenital anomalies. Anxiolytics non-pharmacologic interventions should be the main strategy for the management of most anxiety or insomnia during pregnancy and lactation. These interventions include relaxation, cognitive behavioral therapy, psychotherapy, and environmental change and support. No anxiolytic can be regarded as completely safe in pregnancy or lactation, but if circumstances dictate, such as in panic disorder, lorazepam may be a reasonable choice because of its lack of active metabolites and its glucuronide metabolism, high potency, and good absorption. Wisner and Pearl 1988. The drug should be given at the lowest effective dosage for the briefest possible time and avoided, if possible, in the first trimester and near term. It is prudent to bear in mind that sleep disturbance and anxiety are common in late pregnancy and that risk/benefit considerations seldom warrant hypnotics or anxiolytics at this time except for the treatment of severe anxiety and panic disorder. Use of antidepressants to control panic disorder should also be considered. Electroconvulsive therapy in pregnancy indications. Electroconvulsive therapy is generally regarded as a safe and effective treatment for specific psychiatric diagnoses in pregnancy and the puerperitum, National Institute of Health Consensus Conference 1985, and is underused in treating pregnant women with psychiatric illnesses. It is primarily useful for severe depression, psychosis with affective features, and catatonia. ECT may be prescribed in the following situations: 1. On an emergency basis when the psychiatric status of the mother presents a hazard to herself or the fetus. 2. As a backup for failure of other treatments in severe psychiatric conditions. And 3. To avoid the risk of exposure to potential teratogens in first trimester. Think psychotropic drugs and ECT during pregnancy and lactation. 87-1981. It may also be used in pregnant patients who have a history of successful ECT treatment. ECT is an effective treatment for postpartum psychosis that allows continuation of breastfeeding if desired. Clinical considerations. Remick and Maurice, 1978, and Wise et al., 1984, have commented on the lack of conclusive data on ECT in pregnancy and have suggested the following guidelines: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Thorough physical examination. Involvement of an obstetrician. Consideration of high-risk pregnancy as a relative contraindication. External fetal monitoring for several hours before and after ECT. Endotracheal intubation. Low voltage, non-dominant ECT with electroencephalographic monitoring. Electrocardiographic monitoring of the mother. Oxygen pretreatment and assisted ventilation until the return of spontaneous respiration in the mother. Evaluation of maternal arterial blood gases during or after ECT. Doppler ultrasonography of fetal heart rate. Tachydynamometer recording of uterine tone. Glycopyrrolate as anticholinergic of choice. Screening for pseudocholinesterase deficiency if using succinylcholine. Weekly non-stress tests of fetal well-being. Careful monitoring and control of maternal blood pressure. The patient should be placed in the left lateral position with a wedge under the right hip to ensure that the gravid uterus does not obstruct blood flow through the inferior vena cava. These very cautious considerations are for general information only, and the advice of an obstetrician and anesthesiologist should be obtained for the individual patient. Conclusions: the clinician presented with a psychiatrically ill pregnant or lactating patient must make important clinical decisions about psychotropic drugs and ECT. 88 Psychological aspects of women's health care, 2nd edition. In the face of considerable uncertainty, Color et al. 1996. Careful attention to the most recent and reliable information available and consideration of the unique features of each patient's circumstances will assist in weighing the risk/benefit ratio and determining the best clinical strategy. Written documentation of the factors considered, the patient's informed consent, and careful, ongoing monitoring are vital in the optimal management of this difficult clinical dilemma. References: ARSCOG D. Association between maternal intake of diazepam and oral clefts, letter. Lancet 2:921, 1975. Addis A., Corin G., Safety of fluoxetine during the first trimester of pregnancy, a meta-analytical review of epidemiological studies. PsycholMed 30:89, 94, 2000. Altschuler LL, Cohen L., Suba, MP, et al., Pharmacologic Management of Psychiatric Illness During Pregnancy, Dilemmas and Guidelines. AMJ Psychiatry 153:592 606, 1996. American Academy of Pediatrics Committee on Drugs, the Transfer of Drugs and Other Chemicals into Human Milk. Pediatrics 84:924, 936, 1989. American Academy of Pediatrics Committee on Drugs, the Transfer of Drugs and Other Chemicals into Human Milk. Pediatrics 93:137, 150, 1994. American Medical Association, Drug Interactions and Adverse Drug Reaction, in American Medical Association Drug Evaluations. Chicago, AMA, 1983, pp. 31-44. Anant J., Congenital Malformations with Psychopharmacologic Agents. Compare Psychiatry 16:437, 445, 1975. Anant J., Side Effects on Fetus and Infant of Psychotropic Drug Use During Pregnancy. In Pharmacopsychiatry 11:246, 260, 1976. Anant J., Side Effects in the Neonate from Psychotropic Agents Excreted Through Breastfeeding. AMJ Psychiatry 135:801, 805, 1978. Beely L., Adverse Effects of Drugs in the First Trimester of Pregnancy. Clinobstet Gynecol 13:177, 195, 1986. Birnbaum C.S., Cohen L.S., Bailey J.W., et al., Serum Concentrations of Antidepressants and Benzodiazepines in Nursing Infants, a Case Series, Abstract. Pediatrics 104E11, 1999. Brazelton T.B., Effect of Prenatal Drugs on the Behavior of the Neonate. AMJ Psychiatry 126:1261, 1266, 1970. Briggs G., Freeman R., Yaff S., Drugs in Pregnancy and Lactation. Baltimore, MD, Williams and Wilkins, 1994. Psychotropic drugs and ECT during pregnancy and lactation. 89. Center for Drug Evaluation and Research, Notice of Part 15 Hearings, Prescription Drugs and Biological Products Labeling. Federal Register 20247, 1997. Chambers C.D., Johnson Cott, Dick L.N., et al., Birth Outcomes in Pregnant Women Taking Fluoxetine. An English J. Met 335:1010, 1015, 1996. Chambers C.D., Anderson Poe, Thomas R.G., et al., Weight Gain in Infants Breastfed by Mothers Who Take Fluoxetine, Abstract. Pediatrics 104E61, 1999, Chow Street Jicha M.R., Placental Drug Metabolism, Teratogenesis, and Reproductive Toxicology. Edited by Johnson M., Koch R.D.M. New York, Springer Verlag, 1983, pp. 31-48. Cohen L.S., Heller V.L., Rosenbaum J.F., Treatment Guidelines for Psychotropic Drug Use in Pregnancy. Psychosomatics 30:25, 33, 1989. Cree J.E., Meyer J., Haley D.M., Diazepam in Labor, Its Metabolism and Effect on the Clinical Condition and Thermogenesis of the Newborn. BMJ 4:251, 255, 1973. Crombie D.L., Pinsent R.J., Fleming D.M., et al., Fetal Effects of Tranquilizers in Pregnancy. An English J. Med 293:198, 199, 1975. Edlund M.J., Craig T.J., Antipsychotic Drug Use and Birth Defects, An Epidemiologic Reassessment. Compare Psychiatry 2532, 37, 1984. Edwards J.G., Antidepressants and Convulsions. Lancet 2:1368, 1369, 1979. Egermont E., Ravescott J., Dini V., et al., The Adverse Influence of Imipramine on the Adaptation of the Newborn Infant to Extrauterine Life. Acta Pediatribelg 26:197, 204, 1972. Elia J., Katz I.R., Simpson G.M., Teratogenicity of Psychotherapeutic Medications. Psychopharmacol Bull 23:531, 586, 1987. Fink M., Convulsive and Drug Therapies in Depression. Anu Rev Met 32:405, 412, 1981. Gailey E., Grandstrom M.L., Minor Abnormalities in Children of Mothers with Epilepsy. Neurology 42, Sup 128, 131, 1992. Gellenberg A.J., When a Woman Taking Lithium Wants to Have a Baby. Biological Therapies in Psychiatry 6:19, 20, 1983. Gellenberg A.J., Antidepressants in Milk. Biological Therapies in Psychiatry 10:1, 1987. Gilberg C., Floppy Infant Syndrome and Maternal Diazepam. Lancet 2:244, 1977. Goldberg Hill Damasio A., Psychotropic Drugs in Pregnancy, in Psychopharmacology, A Generation of Progress. Edited by Lipton Mott, Damasio A., Killam K.F. New York, Raven Press, 1978, pp. 1047-1055. Heinen Op., Sloan D., Shapiro S., Birth Defects and Drugs in Pregnancy. Littleton Mott, Publishing Sciences Group, 1977. Hill R.M., Stern L., Drugs in Pregnancy, Effects on the Fetus and Newborn. Drugs 17:182-197, 1979. Eidenponhikula J., Saxon L., Possible Teratogenicity of Imipramine Chloropyramine. Lancet 2:282, 284, 1973. 90 Psychological Aspects of Women's Healthcare, 2nd edition. Inman W., Kubota K., Pierce G., Prescription Event Monitoring of Paroxetine. Prescription Event Monitoring Reports 1993, pp. 1-44. Jacobson S.J., Jones K., Johnson K., et al., Prospective Multi-Center Study of Pregnancy Outcome After Lithium Exposure During First Trimester. Lancet 339:530, 533, 1992 Jones K.L., Lacroix R.V., Johnson Ka, et al., Pattern of malformations in the children of women treated with carbamazepine during pregnancy. An English J. Met 320:1661 1666, 1989 B. Tandberg A. Lithium and Pregnancy, a cohort study on manic depressive women. Acta Psychiatriscans 68:134, 139, 1983 Canto J.H., Use of benzodiazepines during pregnancy, labor, and lactation with particular reference to pharmacokinetic considerations. Drugs 23:354, 380, 1982 Kearns L.L., Treatment of Mental Disorders in Pregnancy. J. Nerve Mentis 174:652, 659, 1986 Copland C.R., The Use of Psychotropic Drugs During Pregnancy and Nursing, in Practitioner Guide to Psychiatric Drugs, 2nd edition. Edited by Basak L., Schoonover S.C., Gellenberg A.J. New York, Plenum, 1983, pp 353-372 Chris E.B., Children of Mothers Maintained on Pharmacotherapy During Pregnancy and Postpartum. Kerr The Residential Clin EXP 7:785, 789, 1965 Kinsberg Ev, Knox J.D., Imipramine in Pregnancy. BMJ 2:292, 1972:N, Pastasak A., Sage S.R., et al., Pregnancy Outcome Following Maternal Use of the New Selective Serotonin Reuptake Inhibitors. JAMA 279:609, 610, 1998 Kohler J.A., Bashford R.A., Wells S.R., et al., Pharmacologic Treatment of Psychiatric Disease in Pregnancy and Lactation, Fetal and Neonatal Effects. Obstetgynecol 87:789 794, 1996 Legriad L., Oligard R., Conradi N., et al., Congenital Malformations and Maternal Consumption of Benzodiazepines, a Case Control Study. DevMed Child Neurol 32:432, 441, 1990 Llewellyn A., Stozzi N., Strader J.R., The Use of Lithium and Management of Women with Bipolar Disorder During Pregnancy and Lactation. J. Clin Psychiatry 59, Supple 57, 64, 1998 Levy G.H., Pharmacokinetics of Fetal and Neonatal Exposure to Drugs. Obstetgynecol 58, Supple 95, 165, 1981 Levy W., Wisniewski K., Chlorpromazine causing extrapyramidal dysfunction in newborn infants of psychotic mothers. New York State J. Medicine 74:684, 685, 1974, McKay Avenue Luce R., Glen A.I., Labor on Lithium. BMJ 1:878, 1976 MANDLEM, Moores LEP, Nordic S., et al., Placental Transfer of Diazepam and its Deposition in the Newborn. Clin Pharmacolder 17:564, 572, 1975, McElhatton Prairie Honig M.G., Elephant E., et al., The Outcome of Pregnancy in 689 Women Exposed to Therapeutic Doses of Antidepressants, a collaborative study of the European Network of Teratology Information Services. Reprod Toxicol 10:285, 294, 1996 Psychotropic Drugs and ECT During Pregnancy and Lactation 91 Milkovic L., Van den Berg B.J., An Evaluation of the Teratogenicity of Certain Antinauseant Drugs. AMJ Obstetgynecol 125:244, 248, 1976 Milkovic L., Van den Berg B.J., Effects of Antenatal Exposure to Anorectic Drugs. AMJ Obstetgynecol 129:637, 642, 1977 Merkin B.L., Drug Disposition and Therapy in the Developing Human Being. Pediatra and 5:542, 557, 1976 Morel P., Sutherland G.R., Buama P.K., et al., Lithium Toxicity in a Neonate. Archdis Childhood 58:538, 539, 1983 Mortala J.F., The Use of Psychotropic Agents in Pregnancy and Lactation. Psychiatriclin North AM 12:69, 87, 1989 Nahas C., Gujar J., Phenothiazines, Benzodiazepines, and the Fetus, in Reviews in Perinatal Medicine. Edited by Scarpelli M., Kosany Ev. New York, Raven Press, 1978, pp 243-280 Nars Pw, Gerard J., Lithium carbonate intake during pregnancy leading to large goitre in a premature infant. AMJ Dischild 131:924, 925, 1977 National Institute of Health Consensus Conference, Electroconvulsive Therapy. JAMA 254:2103, 2108, 1985 Nora J.J., Nora A., Wei G.L., Cardiovascular Maldevelopment Associated with Maternal Exposure to Amantadine. Lancet 2:607, 1975 Nullman I., Rovet J., Stewart D., et al., Neurodevelopment of Children Exposed in Utero to Antidepressant Drugs. An English JMed 4:258, 262, 1997 Nuremberg G.H., Prudhomme J., Guidelines for Treatment of Psychosis During Pregnancy. Hospital and Community Psychiatry 35:67, 71, 1984 Oro as, Dixon S.D., Perinatal Cocaine and Methamphetamine Exposure, Maternal and Neonatal Correlates. JPD 111:571, 578, 1987 Pastisak A., Shikbosketo B., Zuber C., et al., Pregnancy Outcome Following First Trimester Exposure to Fluoxetine, Prozac. JAMA 269:2246, 2248, 1993 Polson E., Robson J. M., Effect of Phenelzyne and Some Related Compounds on Pregnancy. J. Endocrinol 30:205, 215, 1964 Rayburn W., Weibel-Kant J., Bledsoe J., Changing Trends in Drug Use During Pregnancy. J. ReProdMed 27:569, 575, 1982 Remick R.A., Maurice W. L., ECT in Pregnancy. AMJ Psychiatry 135:761, 762, 1978 Robinson G.E., Stewart D., Flack E., The Rational Use of Psychotropic Drugs in Pregnancy and Postpartum. Ken J. Psychiatry 31:183, 190, 1986 Rosa F., Spina bifida in Infants of Women Treated with Carbamazepine During Pregnancy. An English JMed 324:674, 677, 1991 Rosenberg L., Mitchell A., Parcells J. L., et al., Lack of Relation of Oral Clefts to Diazepam Use During Pregnancy. An English JMed 309:1282, 1285, 1983 Rumi Auroket C., Gujar J., Hewell C., Possible teratogenic effects of phenothiazines in human beings. Teratology 15:57, 64, 1977-92 Psychological Aspects of Women's Healthcare, 2nd edition Safra M.D., Oakley G.P., Association between cleft lip with or without cleft palate and prenatal exposure to diazepam. Lancet 2:478, 540, 1975 Saxon I., Saxon L., Letter, Association between maternal intake of diazepam and oral clefts. Lancet 2:498, 1975 Shifty, Chanji, Stern L., Fixed Drug Combinations and the Displacement of Bilirubin from Albumin. Pediatrics 8:139, 141, 1971 SCO M., What Happened Later to the Lithium Babies. Follow-up study of children born without malformations. Acta Psychiatriscan 54:193, 197, 1976 SCO M., Amdizin A., Lithium and Pregnancy, Lithium Ingestion by Children Breastfed by Women on Lithium Treatment. BMJ 2:138, 1973 Skonik D., Nullman I., Rovet J., et al., neurodevelopment of children exposed in utero to phenytoin and carbamazepine monotherapy. JAMA 271:767, 770, 1994 Shearer W.T., Schreiner R.L., Marshall Re, urinary retention in a neonate secondary to maternal ingestion of nortriptyline. JPD at 81:570, 572, 1972 Sloan D., Suskind v. Heinonen op. et al., antenatal exposure to the phenothiazines in relation to congenital malformations, perinatal mortality, birth weight, and intelligence quotient score. AMJ Obstetgynekal 128:486, 488, 1977 Sovner R., Orsilac P.J., excretion of imipramine and desipramine in human breast milk. AMJ Psychiatry 136:451, 452, 1979 St. Clair S.M., Schirmer R.G., first trimester exposure to alprazolam. Obstetgynekal 80:843, 846, 1992 Stewart D., schizophrenia and pregnancy. Kinfam Physician 30:1537, 1542, 1984 Stewart D., prophylactic lithium in postpartum affective psychosis. J-Nerve Mentis 176:485, 489, 1988 Stosy N., Cohen L.S., Hostetter A., et al., paroxetine in human breast milk and nursing infants. AMJ Psychiatry 157:85, 189, 2000 Tunnison WWJR, Hertz CG, Toxic Effects of Lithium in Newborn Infants, a commentary. JPD at 81:804, 807, 1972 U.S. Food and Drug Administration, Drug Bulletin. Washington, D.C., U.S. Food and Drug Administration, September 1979, pp 22-23 Vigetel G., Hagberg B.S., Legriot L., et al., Mental Development in Late Infancy After Prenatal Exposure to Benzodiazepines, a Prospective Study. J. Child Psychol Psychiatry 34:295, 305, 1993 Vigora A.C., Nonax R., Cohen L.S., et al., Risk of Recurrence of Bipolar Disorder in Pregnant and Non-Pregnant Women After Discontinuing Lithium Maintenance. AMJ Psychiatry 157:179, 184, 2000 Volpe J.J., Teratogenic Effects of Drugs and Passive Addiction, in Neurology of the Newborn. Edited by Volpe J.J. Philadelphia PA, W.B. Saunders, 1981, pp 601-635 Voorhees C.V., Butcher Re, Behavioral Teratogenicity, in Developmental Toxicology. Edited by Snell K. New York, Praeger, 1982, pp 249-298 Psychotropic Drugs and ECT During Pregnancy and Lactation 93 Webster POC, Withdrawal Symptoms in Neonates Associated with Maternal Antidepressant Therapy. Lancet 2:318, 319, 1973 Weinstein M.R., Lithium Treatment of Women During Pregnancy and in the Post-Delivery Period, in Handbook of Lithium Therapy. Edited by Johnson F. N. Lancaster, England, MTP Press, 1980, pp 421-429 Wally L.J., Blaine P.G., Prime J.K., Haloperidol secreted in breast milk. BMJ 282:1746 1747, 1981 Wilson J.G., Current Status of Teratology, General Principles and Mechanisms Derived from Animal Studies, in Handbook of Teratology, General Principles and Etiology, Vol. 1. Edited by Wilson J.G., Fraser F.C. New York, Plenum, 1977, pp 47-74 Wilson N., Forfar J.C., Godman M.J., Atrial flutter in the newborn resulting from maternal lithium ingestion. Archdis Childhood 58:538, 539, 1983 Wise M.G., Ward S.C., Townsend Parchman W., et al., Case Report of ECT During High-Risk Pregnancy. AMJ Psychiatry 141:99, 101, 1984 Wisner KL, Findling RL, Pearl JM, Antidepressant Treatment During Breastfeeding. AMJ Psychiatry 153:1132, 1137, 1996 Wisner KL, Gellenberg AJ, Leonard H., et al., Pharmacologic Treatment of Depression During Pregnancy. JAMA 282:1264, 1269, 1999 WREDEG, Mednick S.A., Hutton and M.O., et al., Pregnancy and Delivery Complications in the Births of an Unselected Series of Finnish Children with Schizophrenic Mothers. Acta Psychiatriscan 62:369, 381, 1980 Zalstein E., Corin G., Inarson T., et al., a case control study on the association between first trimester exposure to lithium and Epstein's anomaly. AMJ Cardial 65:817 818, 1990 This page intentionally left blank. 6 Adolescent Pregnancy Diana L. Dell, MD, FACOG. Scope of the issue: each year in the United States about 10% of all adolescent women between the ages of 15 and 19 become pregnant. Of these, only about 13% consciously plan their pregnancies, approximately 33% will abort their pregnancies, 14% will miscarry, and 52% will bear children. Of the 500,000 adolescent women who give birth each year, more than 175,000 are 17 years of age or younger. Of these 500,000 births, only 75% are first births and 72% are out of wedlock, Maynard 1997. The United States has far higher rates of pregnancy, childbirth, and abortion among adolescents than other Western industrialized nations, example Canada, England, Wales, France, Sweden, and the Netherlands. The adolescent abortion rate in the United States is often higher than the entire pregnancy rate, abortion plus childbearing, seen in the other nations, even though access to abortion services is much easier in other countries. Rates of unintended or mistimed pregnancy do not appear to be a function of higher rates of sexual activity among teenagers in the United States, because rates of sexual activity are about the same in all of the nations compared. The bottom line is that American teens do not practice contraception as often or as effectively as teens in other nations, Zabin and Hayward 1993. Unfortunately, the largest differences in birth rates are usually seen at the youngest ages. For example, the birth rate for 14-year-old women in the United States is 5/1,000, which is 4 times higher than that of second-ranking Canada. Among American women aged 18 years or younger, there are fewer births in affluent areas and much higher rates for birth and abortion. Conson 95-96 Psychological Aspects of Women's Health Care, 2nd edition, traded in the most economically deprived areas. These economically deprived areas are the same areas that have the highest rates for infant mortality, violent deaths among youths, violent crime, illicit drug use, and homicide. Zabin and Hayward 1993. The question of why adolescents do not use contraception more effectively has been the object of intensive research. In a recent survey of 200 consecutively enrolled patients aged 13 to 18 years in an adolescent-oriented maternity program, more than 40% of the respondents had positive attitudes toward childbearing. Interviewed during the 3rd trimester, 20% of respondents said that they did not mind getting pregnant, 17.5% said I wanted to get pregnant, and 5% said that their boyfriend wanted them to get pregnant. Only 12% of participants attributed their pregnancies to contraceptive failure. Even smaller percentages cited a fear or dislike of contraceptive side effects, 5%, or a fear of parental discovery and/or disapproval, 5%, as the reason for not using contraception. The authors concluded that a positive attitude toward pregnancy rather than a negative attitude toward contraceptive technologies was most likely to predict whether adolescents used contraception. Stephen Simon et al. 1996b. Normal adolescent development. Attempting to understand the phenomenon of adolescent pregnancy and to provide adequate care for pregnant adolescents requires an understanding of the cognitive and psychosocial development of adolescents. Although age ranges are often assigned to the developmental tasks for early, middle, and late adolescence, the chronologic age does not always correspond to the level of maturity. Additionally, an individual adolescent may be functioning at one level cognitively and at another level psychosocially. Drake 1996. In the terms used by Piaget, C. Singer and Robinson 1978, cognitive development moves from the concrete operations of children to the formal operations that begin in adolescence. During the stage of concrete operations, children can manipulate concrete objects but can function only in the present, with no capacity to conceptualize the future. With the emergence of formal operations at about 11 years of age, adolescents learn to evaluate the environment in less concrete ways. They develop increasing capacities to think logically, work with abstract ideas, predict consequences of behavior, and speculate about future events. Drake 1996. Normal psychosocial development is often divided into 3 stages, each of which spans about 3 years. Adolescent pregnancy 97. Some authors have further defined stages of psychosexual development that roughly correspond to the same chronologic time spans. Early adolescence is characterized by turmoil stemming from the physical changes of puberty, loss of body control, and an intense preoccupation with physical appearance. Drake 1996. Adjusting to their new body image makes early adolescents self-conscious and raises their concerns about being normal and appearing acceptable. Psychosexual development may correspond with undifferentiated exploratory sexual behavior with members of the same or opposite sex. Stephen Simon and Reichert 1994. Very early adolescents seldom seek sexual activity but may be an especially vulnerable group for sexual advances from others. Drake 1996. Middle adolescence focuses on self-identification and self-realization. Girls show more interest in developing intense, loving relationships with boys. Boys are more interested in the pleasure of sexual activity than in the maintenance of loving relationships. Drake 1996. Both genders exhibit behavior that is more defiant, narcissistic, and self-reliant. With narcissism comes a sense of personal omnipotence and what Elkind describes as personal fables, which are stories about one's own uniqueness and invulnerability. For boys, this may be a sense of immortality that fosters risk-taking behavior. For girls, it may be a belief that she cannot become pregnant so she does not need to use contraception. Lewis and Folkmar 1990, p. 218. Middle adolescents often loosen their emotional ties to the family of origin and begin to engage in a series of experimental, monogamous, heterosexual relationships. Stephen Simon and Reichert 1994. In late adolescence, there is a progression away from the narcissistic sense of personal omnipotence toward a more integrated, solid sense of oneself and how that self copes with and integrates into the adult world. Psychosexually, the move is toward developing stable, mutually intimate relationships. Drake 1996, Stephen Simon and Reichert 1994. The developmental stage at which an adolescent woman becomes sexually active is extremely critical. Her level of cognitive and psychosocial development will predict not only how well she protects herself from pregnancy but how she responds to the event of pregnancy if she fails to adequately practice contraception. Because early adolescents are still very present-oriented, self-centered, and less capable of abstract thinking, they have difficulty accepting the reality of a pregnancy. They often deny that they are pregnant, even in the presence of an enlarging abdomen or positive pregnancy test. They are secretive and when possible will often conceal pregnancy until an advanced stage of GASTA 98 Psychological Aspects of Women's Healthcare, 2nd edition. They seldom have more than a casual relationship with the father of the fetus. They anticipate and often receive very negative reactions when family members become aware of the pregnancy. Unless directed by parents or other adults, they tend to seek prenatal care late or not at all. Once enrolled in prenatal care, They have difficulty focusing on threats to their own health or the health of the fetus. They are not emotionally ready to assume a parenting role and require adult guidance and assistance with the responsibility for infant care. Drake 1996. Middle adolescent women often have begun some form of sexual experimentation. They move from a stage of exploratory behavior toward a stage of developing intense, loving relationships. If pregnancy occurs at this stage, the woman often has a deeper emotional attachment to the father of the fetus. She may have consciously or unconsciously chosen to become pregnant as a means of confirming her feminine identity, as a means of securing a closer relationship with the father of the fetus, or as a means of gaining adult status. Some adolescent women, especially those who are doing poorly in school or do not have opportunities for advanced education and career training, will choose pregnancy during this time as a career choice of motherhood over education/employment. Drake 1996. Depending on the circumstances surrounding the decision to seek pregnancy or the more ambivalent posture of just not using contraception, middle adolescents still tend to seek prenatal care later in pregnancy than do more mature groups. However, middle adolescents are more capable than early adolescents of making the needs of the fetus a priority and of assuming responsibility for parenting, although assistance with child care is needed to allow completion of educational goals. Drake 1996. Late adolescents have a much stronger sense of themselves and a stronger relationship with the father of the fetus. They are more like adult women in most categories. They seek prenatal care earlier, are motivated to do what is best for a healthy pregnancy, and can usually assume the task of parenting on their own. Drake 1996. Abnormal adolescent development. Sexual victimization in childhood can adversely affect normal adolescent psychosexual development in addition to being independently associated with a broad spectrum of physical, emotional, and behavioral problems. The association between prior sexual abuse and adolescent pregnancy is very strong. Adolescent pregnancy 99. Numerous studies have demonstrated that former victims of sexual abuse are overrepresented in adolescent prenatal programs, with some groups appearing more at risk than others. Stephen Simon and Reichert 1994. In one sample of 535 pregnant adolescents, 66.2% had some history of sexual victimization. Of these, 70% of the white adolescents had been abused prior to conception, compared with 42% of black adolescents and 37% of Hispanic adolescents. Boyer and Fine 1992. Rainey et al., 1995, prospectively queried 202 consecutive non-pregnant, sexually active, nulliparous adolescent women aged 13 to 19 who sought routine medical care at 2 teen centers. In this group, 20% reported prior sexual abuse. Sexually abused and non-abused girls reported similar ages at menarche, similar rates of miscarriages, abortions, and sexually transmitted disease, similar ages for initiation of consensual sexual intercourse, similar frequencies of intercourse, and similar rates of contraceptive use. Sexually abused adolescents were 3 times more likely than their non-abused peers to state that they were seeking pregnancy, 34.2% versus 11.3%, p. 0.001. Abused patients expressed more concerns about their ability to conceive, were more likely to report previous pregnancy testing, were twice as likely to report feeling that something was wrong with them and that they could not conceive, and were more likely to have older boyfriends who encouraged them to get pregnant. The authors postulated that infertility concerns could be another expression of the low self-esteem commonly seen in adolescents with prior sexual abuse. Rainey et al. 1995. In the same study it was noted that sexually abused girls were more likely to report socially deviant behaviors, smoking cigarettes, frequent alcohol use, other illicit drug use, and involvement with the police or juvenile court system within the preceding 6 months. The authors speculated that adolescent pregnancy may be another manifestation of self-destructive and socially deviant behavior attributable to prior sexual victimization. Rainey et al. 1995. Ongoing violent behavior and sexual victimization are also related to adolescent pregnancy. Current estimates suggest that up to 30% of college-age women have had at least one violent incident in a dating relationship. In one large urban sampling, 32% of pregnant adolescents reported having been physically or sexually abused during the prior year and 22% were being abused during the current pregnancy. Abused women tended to enter prenatal care later. 24% of the abused adolescents in the sample entered prenatal care during the third trimester compared with 9% of those who were not abused. Parker 1993. In abusive relationships, both male and female partners tended to X100 psychological aspects of women's health care. Second edition press more negative feelings toward the pregnancy. 51% of abused women reported negative feelings about the pregnancy compared with 31% of non-abused women, and 29% of the abusing partners reported negative feelings about the pregnancy compared with 13% of the non-abusing partners. Parker 1993. Process of pregnancy resolution. Late diagnosis. For reasons that are not always clear, adolescent women often prolong the interval between suspecting and confirming that they are pregnant. This delay accounts for complications associated with late entry into prenatal care and higher rates of elective second trimester abortion. Bluestein and Rutledge, 1992, reviewed the literature that has been generated to explain this delay and found that this phenomenon was not adequately explained by socio-demographic attributes, including age, race, education, or ability to pay for pregnancy testing, or by clinical attributes, including parity, contraceptive practices, menstrual regularity, and presence of pregnancy symptoms. They surveyed 123 pregnant adolescents aged 14 to 19 years, 54% of whom carried their pregnancies and 46% of whom aborted their pregnancies. The mean duration of delay in seeking a pregnancy test was 4.35 weeks. In this sample, only difficulty in acknowledging the pregnancy exerted a significant net effect on delayed testing, p. 0.05. Interestingly, difficulty acknowledging the pregnancy was also associated with depressive symptoms, p. 0.01, problems talking with partners, p. 0.05, and an initial negative reaction to the pregnancy, p. 0.01, Bluestein and Rutledge 1992. Difficulty acknowledging a pregnancy may be a manifestation of denial that reflects cognitive immaturity. For other adolescents it may represent psychosocial immaturity, with ambivalence, or feelings of guilt about sexual activity. Whatever the reasons, during this period of delay pregnant adolescents may be alone as they face difficult decisions concerning their pregnancy. Bluestein and Rutledge 1992. Counseling. Although unwanted or mistimed pregnancy can create a crisis in the life of a woman at any age, adolescent women are at special risk because of their own developmental issues. Early and middle adolescents, for example, have not adolescent pregnancy 101 completed individuation and are ill-equipped for making autonomous decisions. Older adolescents may have more decision-making ability but are unaccustomed to making decisions of this magnitude. Counseling for pregnancy resolution must explore all available options: abortion, adoption, and keeping the baby. It should include the family whenever possible, must be free of counselor bias, and must be provided in very practical terms that will facilitate appropriate decision-making. J. H. Gold 1991. Keeping the Pregnancy. Farber, 1991, conducted in-depth interviews with 28 unmarried adolescent mothers from 6 subgroups, identified as black and white teens from middle class, working class, and lower class families. In her sample, the process of recognizing the pregnancy took many forms, ranging from immediate acknowledgement to a long period of denial. Fears about the anticipated response of the parents was a consistent finding, both before and especially after confirmation of the pregnancy. Nonetheless, the young women, with only one exception, looked immediately to their families for direction and generally were advised to keep the child. Only one subject even referred to the father of the fetus in the decision-making process. Farber 1991. All adolescent women in this study bore their pregnancy and kept their child. This decision was seldom based simply on the desire to be a mother. The pregnant adolescent was not acting as an isolated individual able to calculate the best outcome for her own self-interest and proceed toward a decision consistent with her level of self-esteem, career aspirations, or cultural load. Parents and extended family members often exerted direct influence on the parenting decision, and the final choice of pregnancy resolution included concerns about obedience to parents and grandparents, a belief in the sanctity of life, acceptance of the consequences of their actions, and the perceived best interests of the child. Farber 1991. One case illustrates how final resolution can be a complex and difficult process that ultimately may be based on identifying the least harmful alternative. One black middle-class teen who had planned to go to medical school did not acknowledge her pregnancy until her preferred choice of safe abortion was no longer an option. She had to choose among hurting her beloved grandmother who opposed adoption, maintaining the support of her mother who favored adoption, and guarding against endangering her career aspirations through early motherhood. She ultimately kept her child, to be raised with assistance from her mother. Farber 1991. Although the sample size of Farber's study was small, some trends were 102 psychological aspects of women's health care, second edition evident. One consistent pattern was the overwhelmingly negative reaction of the families of black middle-class teenagers, with reactions ranging from disappointed shock to fury. Black middle-class and working-class families expressed marked disappointment about their daughters' futures. Among white middle-class and working-class families, the first expression of concern was about potential complications of being pregnant at such a young age. The families of black lower-class teens were also hurt, disappointed, and angry, but the black lower-class teens themselves expressed either positive or neutral feelings about the pregnancy, and with one exception did not report fearing the parents' reaction. Lower-class teens and their parents, especially the mothers, quickly accepted as inevitable that the young woman would keep and raise her child. Farber 1991. Abortion. Although abortion has been legal in the United States since 1973, the availability and accessibility of abortion services to adolescent women has been changing dramatically over the past few years. Decreased public funding, decreased provider availability, and parental consent laws have had a disproportionate effect on adolescent and economically deprived women. For the adolescent woman to make decisions about her pregnancy, she needs information about what specific alternatives are available to her, including the abortion options specific to her stage of gestation as well as community resources that are available for either abortion or prenatal care. If she chooses abortion, she has a much greater need than does an older woman for intensive education about female physiology and specific characteristics of the abortion procedure that will be used. Accurate information about the sensations she will experience can markedly diminish immediate and longer-term negative responses. Zakuz and Wildey 1987. Despite politically motivated reports to the contrary, abortion is followed by relatively few psychologic sequelae. Most women experience some anticipatory grieving during the decision-making process. After the abortion procedure, the resolution of that grief response is relatively rapid, with most women reporting a sense of relief and a rapid return to their previous level of functioning. J. H. Gold 1991, Zakuz and Wildey 1987. Several categories of women have been identified who may be at special risk for emotional difficulties in the months or years after an abortion: women who feel they are not free to make their own choice about terminating a pregnancy. Adolescents are particularly vulnerable to feeling that adolescent pregnancy 103 parents or partners coerce them into having an abortion. Zakuz and Wildey 1987. Unfortunately, the same may also be true for an adolescent woman who carries a pregnancy to term against her wishes. She will experience the same regret, guilt, and anger as the woman coerced into having an abortion. J. H. Gold 1991. Women with a history of sexual abuse. Not only are previously abused adolescent women at greater risk for pregnancy, they appear at greater risk for experiencing gynecologic examinations and the abortion procedure itself as an additional trauma. Zakuz and Wildey 1987. Women with other unresolved grief reactions. For adolescents, it is very common for the crisis of pregnancy to result in dissolution of the relationship with the father of the fetus. Grieving the loss of that relationship may compound a transient abortion-related grief reaction, Zakus and Wilde 1987. Women with pre-existing psychiatric disorders, Zakus and Wilde 1987. Adolescent women who appear at special risk for emotional difficulties in the wake of pregnancy resolution decisions should be identified in the initial counseling whether they decide to carry or abort their pregnancies. These women often benefit from crisis intervention strategies that address the current life situation and the patient's own coping skills, Zakus and Wilde 1987. Adoption. A generation ago, adoption was the most popular option for out-of-wedlock pregnancy, especially among white adolescents and families. Currently, less than 5% of adolescents who give birth choose adoption as the preferred resolution of their pregnancy. In an effort to understand this dramatic shift, Custer, 1993, conducted in-depth interviews of 21 unmarried white adolescents carrying an unplanned pregnancy. The subjects, their significant others, and people they identified as being influential in helping to make decisions about the future were interviewed during the last trimester of pregnancy and again at 6 to 8 weeks postpartum. The most important phenomenon noted was the absence of societal sanctions against adolescent parenthood, concurrent with reciprocal sanctions against relinquishing a child for adoption. The culture was now saying that it is acceptable to be a single adolescent mother but definitely not acceptable to give away a baby, Custer 1993. Societal sanction appeared to be primarily centered on the idea of adoption not being good for the child. Numerous subjects voiced concern that the 104 psychological aspects of women's health care, second edition child would suffer, that it would not be loved and would therefore hate the birth mother. There was also an element of societal disapproval related to the perception that adolescents should assume responsibility for their actions. It's your responsibility to take care of the situations you get yourself into. If you don't want the kid, why were you messing around? Custer 1993. The apparent lack of accurate knowledge among adolescents about adoption was startling. Only limited information was provided to the patients by the healthcare professionals who provided prenatal care. Only 3 of the subjects had any degree of accurate knowledge about adoption, only 8 recalled being asked if they were considering adoption, and only 2 remembered actually receiving any adoption information or counseling at any time during the pregnancy, Custer 1993. Custer concluded that anticipation of psychologic distress is the most powerful immediate barrier to adolescents giving up their infants for adoption. The combination of general societal sanctions, low levels of knowledge, and absence of professional intervention served to confirm the adolescents' beliefs that severe, intolerable, and ongoing psychologic distress would accompany giving up an infant for adoption, Custer 1993. This conclusion gains additional strength when considered in the context of psychosocial development. Middle adolescents conform to societal standards to avoid censure by authority figures, whereas late adolescents conform to maintain the respect of impartial observers and avoid self-condemnation. Drake 1996. General health care for adolescent women. Confidentiality is a major issue in dealing with adolescent patients. Adolescents are more likely to give an accurate history if assured that whatever information they provide is not shared with others unless safety is an issue, as in suspected abuse/neglect or suicidal ideation. Conveying this information to both patients and parents at the initial visit is helpful, Brown-Jones and Orr 1993. Even with this assurance, adolescents may have difficulty communicating information about sexuality to adults who resemble parental authority figures. Sexual activity. Physical maturation profoundly influences the onset of sexual activity and the subsequent risk for adolescent pregnancy. Hormone production in girls usually begins between 7 and 9 years of age, with rapid escalation from age adolescent pregnancy 105-9 until the onset of menstruation. The age of menarche in girls from Western industrialized nations has been steadily declining for the past 100 years, with the average age now cited as 12.6 years. Earlier physical maturation means that the variance between physical maturation and psychosocial maturation is probably greater than that found in previous generations. This disparity may place peripubertal girls at greater risk for pregnancy and the acquisition of sexually transmitted diseases before they have the cognitive and psychosocial skills to manage a sexual life. Zobin and Hayward 1993. Menarche can be considered a marker for the initiation of sexual behavior, with age of first intercourse for girls usually occurring within 2 to 3 years after menarche. The impact is most evident at the youngest ages. By age 13, almost 40% of those girls whose menarche occurred at 11 years or younger are sexually active, 20% of girls with menarche at age 13 to 14 are sexually active at or before menarche, and only 10% of those with menarche after age 14 are sexually active at or before menarche. Brown-Jones and Orr 1993, Zobin and Hayward 1993. Half of all first pregnancies in adolescence occur within the first 6 months of sexual activity, with about 20% occurring in the first month. Early adolescents are less likely than older adolescents to use contraception or to use it effectively. They also have longer delays between initiation of sexual activity and seeking contraceptive services, 23.5 months for women age 15 or younger versus 10.6 months for women ages 16 to 19. Because this activity is occurring in a phase in which the adolescent is relating increasingly to peers and less to parents, the presence of a sexually active and/or non-contracepting peer group may have a much greater impact on younger adolescents than it would have at a later age. Zobin and Hayward 1993. Sexually transmissible disease. 3 million adolescents acquire a sexually transmissible disease every year. They are at greater risk than adults for several reasons. They are more likely to have multiple sex partners, more likely to have high-risk partners, and less likely to use barrier protection for intercourse. For adolescent women there is the additional issue of having an immature cervix, which does not provide the same barrier to infection that a more mature cervix provides and is more likely to be injured by sexually transmissible organisms. In fact, many of the serious health consequences of sexually transmissible diseases that appear in adults, such as cancer and infertility, are the result of infections acquired during adolescence. Donovan 1997. 106 Psychological Aspects of Women's Health Care, 2nd edition. All adolescent women should be encouraged to use both a reliable method of female birth control and condoms. This process is facilitated both by empowering young women to take charge of their bodies and by demonstrating the correct use of condoms on a mannequin in the office setting. Many adolescent women have never seen or touched a condom, and the office demonstration dramatically reduces anxiety, which may facilitate increased use. Brown-Jones and Orr 1993. Unfortunately, evidence indicates that physicians do not always provide adequate information or screening services for sexually transmitted disease. Mahler, 1997, screened 1,217 California physicians who were board certified in either family medicine, internal medicine, obstetrics and gynecology, or pediatrics regarding the routine services they provided to adolescents. Only 47% said that they asked all patients aged 15 to 18 whether they were sexually active, and 3% said that they never asked. Only 31% furnished all teenaged patients with information about sexually transmitted disease, including HIV. Once an adolescent has demonstrated sexual activity by presenting for pregnancy testing, it is important to do immediate screening for sexually transmitted disease. Matson et al., 1993, followed up 168 pregnant adolescents from low socioeconomic backgrounds from their original pregnancy diagnosis to their first prenatal visit. Of those patients who had screening pelvic examinations at the time of pregnancy testing, 29% were positive for gonorrhea, chlamydia, or both. This study design would not detect syphilis, HIV, or other bloodborne infections. The average delay from pregnancy diagnosis to first prenatal visit, at which routine evaluations for sexually transmitted diseases are normally done, was 35.7 days, with 40% of patients seen more than a month after pregnancy diagnosis and an additional 25% seen more than 46 days later. The implications generated by these data are important for both the mother and the fetus. Adolescents are an increasing percentage of the HIV-positive population, with theoretic concerns that their future risk is enormous. D'Angelo et al. 1994. Because recent data show a marked decrease in transplacental transmission of the virus when HIV-pregnant women are treated with antiviral agents during pregnancy, finding ways to ensure early screening and treatment of all HIV-positive women is a public health imperative. Emergency contraception. Emergency contraception is used after unprotected intercourse to prevent pregnancy, but is used so infrequently that it has been called the best-kept adolescent pregnancy. 107 Contraceptive secret in America, M.A. Gold et al. 1997. The most common method used is the IP method, 2 oral contraceptive pills, each containing 50 g of ethinyl estradiol, are taken within 72 hours of unprotected intercourse, followed by 2 additional 50 g pills 12 hours later. Some women experience nausea from this estrogen dose, so an antiemetic may be helpful. If vomiting occurs, the dose should be repeated. In Great Britain, where all contraceptive pills can be purchased over the counter, a pill that is packaged and marketed specifically for postcoital use is also available. M.A. Gold et al. 1997. In the United States, the Food and Drug Administration has approved the use of oral contraceptives in this manner, but information about the method has been slow to disseminate. Emergency contraception may be especially suited for use in the adolescent population, in which first intercourse is usually unplanned and unprotected. The IP method reduces the risk of pregnancy after unprotected intercourse by 75% and could decrease the abortion rate by 50%. Nonetheless, when college students were screened in one women's health clinic, 85% of students who had previously had an abortion did not know anything about emergency contraception. M.A. Gold et al. 1997. Other agents, including mifepristone or antiprogesterone preparations, may also be suited for postcoital use. Further research about long-term effects of postcoital contraception and increased education about this method for primary care physicians who treat adolescents are sorely needed. Prenatal care for adolescent women. Adolescents appear to have increased risks for certain potentially serious conditions during pregnancy, including pregnancy-induced hypertension, anemia, preterm labor, preterm delivery, and having low birth weight infants. Whether these increased risks are primarily a function of age or secondary to other variables, Scholl et al. 1994, is an ongoing research issue. The real challenge is to find ways that help pregnant adolescents achieve the best possible outcomes for themselves and their infants. When an adolescent woman becomes pregnant, her level of cognitive development and her level of psychosocial development will predict how she behaves with regard to herself and her pregnancy. Not only does she face the usual developmental tasks for her stage of adolescence, but she now has the added developmental tasks superimposed by the pregnancy. Drake 1996. The field of maternal, child nursing has had a long-standing appreciation for 108 psychological aspects of women's health care, 2nd edition these principles, and has contributed much of the information in this important area. A recent publication by Drake, 1996, provided an especially useful summation of these principles. Table 6:1 outlines the developmental tasks of adolescents as they are experienced by pregnant adolescent in the early, middle, and late stages of cognitive and psychosocial development. Table 6:2 outlines the developmental tasks of pregnancy as they are experienced by early, middle, and late adolescents. Special populations of pregnant adolescents. Substance abuse. Use of psychoactive substances during pregnancy has become an area of growing concern over the past 2 decades. This concern is fueled by statistics showing that new drug use occurs among women at a rate twice that among men. In one study from Maryland, baseline statistics showed that 16% of all newborns in 1986 were designated as high risk based on maternal drug use. 4 years later, the number had increased almost threefold, to 46%. Although it was unclear whether the apparent increase in drug-exposed infants was secondary to increased surveillance or higher rates of drug use, the authors felt certain that no reduction had occurred in the proportion of women using drugs during pregnancy. Marcus and McKnight 1991. A prominent finding in the Maryland study was that white pregnant teens were much more likely to fall into the two highest risk groups for drug abuse compared with only 12% of black pregnant teens. The authors contrasted their findings with another public health population in Florida in which black adolescents were 10 times more likely to be tested and thus appeared to have higher rates of substance abuse, Marcus and McKnight 1991. Similar findings were noted in another study that examined prenatal alcohol use in adolescents. Significantly more white adolescents were among the moderate/heavy drinkers than black adolescents. Drinking is common during adolescence, and adolescents have different patterns of drinking than adults. One national survey reported that more than 27% of female high school seniors reported at least one occasion in the 2 weeks prior to questioning when they had consumed 5 or more drinks. When compared with a cohort of pregnant adults, pregnant adolescents of both races had higher rates, table 6:1. Achievement of developmental tasks of adolescents by the pregnant adolescent. Developmental tasks of adolescents * middle pregnant adolescents. Late pregnant adolescents. Achievement of a stable identity. Weakly developed sense of self. Much difficulty in adapting to the demands of pregnancy. Too much turmoil and confusion for identity formation. Responsibilities of parenthood may be thrust on them. A developing sense of self. May still be developing ideas of what they want to do, how they want to behave. Pregnancy may have been desired to confirm feminine identity. A strong sense of self. Have developed feminine identities and are able to adapt to pregnant and parenting roles like adult mothers. Body image. Body in stage of rapid growth. Body reaching maturity. Usually awkward and self-conscious. React negatively to body image about being different. May conceal changes imposed by pregnancy. The pregnancy. Comfortable with mature body and maternal appearance. Sexuality. Prefer same-gender peers. Usually have only casual relationship with the father of the fetus. May have entered relationship with father of the fetus but relationship lacks depth and closeness. May have desired the pregnancy to strengthen the relationship with the father. Able to form close relationships with both genders. Have a stable relationship with the father of the fetus. Personal value system. Premoral or pre-conventional, Kohlberg 1964. Obey to avoid punishment. Conform to obtain rewards, have favors returned, Mercer 1990. Need concrete incentives to comply with recommendations for healthy prenatal behaviors. Role conformity or conventional, Kohlberg 1964. Maintain good relationships for others' approval. Conform to avoid censure by authorities and resultant guilt, Mercer 1990. Do what is suggested for prenatal care to avoid reproach by parents or health care providers. Self-accepted moral principles, Kohlberg 1964. Conform to maintain respect of impartial observer and to avoid self-condemnation, Mercer 1990. Self-motivated to do what is best for a healthy pregnancy. Adolescent pregnancy. Early pregnant adolescents. 109 Achievement of developmental tasks of adolescence by the pregnant adolescent, continued. Early pregnant adolescents. Middle pregnant adolescents. Late pregnant adolescents. Vocation/career in the 6th to 9th grade. Not able to be future-oriented or concerned about career choices. Also are not able to have motherhood as a role without support. In the 10th to 12th grade. If doing poorly in school and not encouraged to have educational and employment goals, motherhood may be primary role. May have completed high school. Are able to define career choices and goals. May combine choices and goals. May combine employment or education with motherhood. Independence from parents. Dependent on parents or other adults. Need much assistance with parenting responsibilities. Usually still dependent on parents or another adult. Share parenting responsibility with adult family members. May be independent if gainful employment is available for them or their partners. Can take primary responsibility for parenting with the father of the fetus. Asterisk as identified by Mercer, 1990. Source. Drake P. Addressing Developmental Needs of Pregnant Adolescents. J. Obstetgynekal Neonatalness 25:518, 524, 1996. Reprinted with permission of Association of Women's Health, Obstetric, and Neonatal Nurses, Wuhan. Psychological Aspects of Women's Healthcare, 2nd edition. Developmental Tasks of Adolescents * 110 Table 6-1. Table 6-2. Achievement of Developmental Tasks of Pregnancy by Adolescents. Developmental Tasks of Pregnancy * Early Adolescence, Middle Adolescence, Late Adolescence hampered by denial of pregnancy. May not be assertive in not able to clearly state questions expressing concerns. Late and concerns. Seek prenatal care. Prenatal care is common. Late or not at all. Actively seek information about pregnancy, birth, and infants. Usually start prenatal care in the middle trimester. Acceptance of the pregnancy by self and others. High levels of secrecy and denial of pregnancy may occur. Usually strong negative reaction by families. May have chosen the mothering role to gain mature status. Families' reaction usually negative, shock, anger, guilt, and sadness, Johnson 1995. Mixed reaction of adolescents, partners, and families. More acceptance if adolescents are financially independent. Acceptance of the reality of the unborn child. Have difficulty focusing on the fetus because they are present-oriented, self-centered, and concrete thinkers. May be willing to make the needs of the fetus first priority. Influenced by developing feminine identities and the significance of the mothering role. Able to focus on the fetus. Can understand the consequences of behavior on fetal growth and development. Acceptance of the reality of parenthood. Not emotionally ready to assume a parenting role. Require adult guidance and assistance to share responsibility for infant care. May be able to take on some. Can get prepared and assume the responsibility for parenting. To tasks of parenting competently. Continue own education. Assistance with child care from adults is necessary. Asterisk as identified by Rubin, 1984. Source. Drake P. Addressing Developmental Needs of Pregnant Adolescents. J. Obstetgynekal Neonatalness 25:518, 524, 1996. Reprinted with permission of Association of Women's Health, Obstetric, and Neonatal Nurses, Wuhan. Adolescent Pregnancy Seeking Safe Passage 111-112 Psychological Aspects of Women's Healthcare, 2nd edition of binge drinking during the first trimester, and adolescent binge drinking did not decrease until after the first trimester. Heavy drinking was a risk factor for later recognition of pregnancy in both adult and adolescent cohorts, which has important implications for prevention of fetal alcohol syndrome, Cornelius et al. 1994. In the same study, the use of marijuana and crack/cocaine decreased during pregnancy for both adolescents and adults. Tobacco use, on the other hand, decreased in the adult cohort but actually increased in the adolescent cohort. The proportion of tobacco smokers in the adolescent sample increased from 52% to 64% during pregnancy. Black adolescent women were less likely to use tobacco than white adolescent women, and by the third trimester, 92% of the white adolescents were smoking, Cornelius et al. 1994. Berenson et al. 1992, surveyed 342 pregnant adolescents from diverse ethnic origins to explore the relationship between violence and substance abuse. They reported that adolescent women with a history of combined physical and sexual assault were 7 times more likely to use psychoactive substances than were adolescents without a history of assault. Substance abuse was 5 times more likely for those who had been sexually victimized and 3 times more likely for those who had been physically assaulted. Drug use was most strongly associated with assault by a mate, whereas alcohol and tobacco were more commonly associated with assault by a member of the victim's family of origin. Scafidi et al., 1997, evaluated psychosocial stress in 104 adolescent mothers between the ages of 13 and 21 years. Drug-abusing adolescent mothers experienced more psychosocial stressors than did adolescent mothers who were not substance abusers. Drug-abusing adolescent mothers also reported poorer physical health, poorer mental health, lower vocational and educational status, more family and peer relations problems, less constructive use of leisure time, and poorer social skills than the comparable group. Overall, poor mental health was the most significant factor associated with drug abuse in this cohort of adolescent mothers. Mental Illness Kovacs et al., 1994, noted that the investigations prospectively examining mental illness in children as a predictor of adolescent pregnancy were limited. The authors used existing longitudinal data from a psychiatric clinic sample of 83 girls who were aged 8 to 13 years at study entry. They followed up with the girls over time and identified 25 girls who had had their first pregnancies, adolescent pregnancy 113 at age 18 or younger. The authors had postulated that girls with depressive disorders should be at greater risk for adolescent pregnancy, but the data did not support this theory. In the final multivariate analysis, only conduct disorders appeared to have a major role. Among girls with conduct disorders, 54.8% had teen pregnancies versus 12% of girls with other diagnoses. In a subsequent study by Zaccolillo et al., 1997, the role for conduct disorder as a predictor of greater risk for adolescent pregnancy was also acknowledged. 9 of 25 pregnant adolescent women studied had that diagnosis. In addition, conduct disorder was also a major risk factor for polysubstance use, with 67% of the subjects in the study also meeting diagnostic criterion for substance abuse or dependence. The authors suggested that screening for conduct disorder may be an efficient way to identify girls at especially high risk for early pregnancy. Screening is relatively easy, most adolescents will not meet the criterion, and intensive pregnancy prevention efforts could be directed toward those who do. A common explanation for poor contraception and unwanted pregnancy in past years has been an assumption that these behaviors were a reflection of poor self-esteem. Matsuhashi and Felice, 1991, found just the opposite in the first reported study assessing body perceptions in pregnant adolescents. They assessed 43 primiparous pregnant adolescents, aged 14 to 18 years, during the third trimester of pregnancy. In comparison with a never-pregnant control group matched for age, race, tenor stage of pubertal development, and socioeconomic status, the pregnant girls reported higher overall self-esteem, a more positive body image, a surer self-identity, and feelings of being more productive as family members. The authors suggested that some adolescent girls may actually be developing their own sexual identity through a pregnancy. That principle may apply to repeat pregnancy rates as well. Stephen Simon et al., 1996a, assessed attitudes toward childbearing in a racially diverse group of 200 consecutively enrolled, poor, pregnant adolescents aged 13 to 18 years in an adolescent-oriented maternity program. During the first postpartum year, the repeat pregnancy rate was 11.5%. Those adolescents who became pregnant again were more likely to have expressed positive attitudes toward childbearing during the index pregnancy, 60.9% versus 39.6%, p equals 0.05. Interestingly, they were also more likely to have reported a miscarriage prior to the index pregnancy, 30% versus 9%, p equals 0.04, and those with miscarriage prior to the index pregnancy conceived more quickly after the index pregnancy. Those who conceived again within 1 year were more likely to have dropped out of school before high school graduation, p equals 0.004. More 114 psychological aspects of women's health care, second edition often admitted to the use of illicit drugs, p equals 0.05, had more frequently moved away from their parental home, p equals 0.006, and were more likely to have rated their families as unsupportive during the index pregnancy, p equals 0.009. They were not significantly different with regard to age, race, Medicaid use, or depression scores, but they were less likely to have planned postpartum levonorgestrel, Norplant, used during the index pregnancy, 22% versus 49%, p equals 0.02. Planning for the future. As we look for conclusions about the complex issue of adolescent pregnancy, the only thing that is perfectly clear is that it is multifactorial and does not have any simple or easy solutions. It is imperative that we begin finding solutions, because our population is in a phase that will produce an accelerated number of middle and late adolescents during this decade. McElroy and Moore, 1997, estimated that between the years 1990 and 2000, the number of women ages 15 to 19 would increase by 1 million. Unless significant reductions are achieved in the adolescent birth rate, we can anticipate a substantial increase in the number of births in this group. References: Berenson of San Miguel v. Wilkinson G.S., Violence and its Relationship to Substance Abuse in Adolescent Pregnancy. J. Adolescent Health 13:470, 474, 1992. Bluestein D., Rutledge C.M., Determinants of Delayed Pregnancy Testing Among Adolescents. J. Pham Prac 35:406, 410, 1992. Boyer D., Fine D., Sexual Abuse as a Factor in Adolescent Pregnancy and Child Maltreatment. Pham Plan Perspect 24:4, 11, 19, 1992. Brown Jones L., or D.P., Health Care for the Adolescent Female. Compare their 19:291 299, 1993. Cornelius M.D., Richardson G.A., Day N.L., et al., A Comparison of Prenatal Drinking in Two Recent Samples of Adolescents and Adults. J. Stud Alcohol 55:412, 419, 1994. Custer M., Adoption as an Option for Unmarried Pregnant Teens. Adolescents 28:891 902, 1993. D'Angelo L.J., Brown R., English A., et al., HIV Infection and AIDS in Adolescents, a position paper of the Society for Adolescent Medicine. J. Adolescent Health 15:427 434, 1994. Adolescent Pregnancy 115. Donovan P., Confronting a Hidden Epidemic, The Institute of Medicine's Report on Sexually Transmitted Diseases. Pham Plan Perspect 29:87, 89, 1997. Drake P., Addressing Developmental Needs of Pregnant Adolescents. J. Obstetgynekal Neonatalness 25:518, 524, 1996. Farber N.B., The Process of Pregnancy Resolution Among Adolescent Mothers. Adolescents 26:697, 716, 1991. Gold J.H., Adolescence and Abortion, in Psychiatric Aspects of Abortion. Edited by Stotland N.L. American Psychiatric Press, Washington, D.C., 1991. Gold Ma, Shine A., Kupi S.M., Emergency Contraception, A National Survey of Adolescent Health Experts. Pham Plan Perspect 29:15, 19, 1997. Kohlberg L., Development of Moral Character and Moral Ideology, in Review of Child Development Research. Edited by Hoffman M.L., Hoffman W. New York, Russell Sage Foundation, 1964, pp. 383-431. Kovacs M., Kroll R.S.M., Vodi L., Early Onset Pathology and the Risk for Teenage Pregnancy Among Clinically Referred Girls. JAM Academic Child Adolescent Psychiatry 33:106, 113, 1994. Johnson P.A., Adolescent Sexuality, Pregnancy, and Parenthood, in Maternity Nursing. Edited by Bobak I.M., Lodermilk D.L., Jensen M.D. St. Louis, Missouri, Mosby, 1995, pp. 722-747. Lewis M., Folkmar Fr., Clinical Aspects of Child and Adolescent Development. Media P.A., Williams, and Wilkins, 1990, pp. 212-247. Mahler K., Physicians Often Omit Sexual Health Services from Adolescents' Care. Pham Plan Perspect 29:91, 92, 1997. Marcus Prairie McKnight A.J., Drug Abuse Risk Among Pregnant Adolescents Attending Public Health Clinics. AMJ Drug Alcohol Abuse 17:399, 413, 1991 Matson S.C., Pomeranz A.J., Camps Ka, Early Detection and Treatment of Sexually Transmitted Disease in Pregnant Adolescents of Low Socioeconomic Status. Clin Pediatra 32:609, 612, 1993 Matsuhashi Y., Felice, Adolescent Body Image During Pregnancy. J. Adolescent Health 12:313, 315, 1991 Maynard R.A., The Study, the Context, and the Findings in Brief, in Kids Having Kids, Economic Costs and Social Consequences of Teen Pregnancy. Edited by Maynard R.A. Washington, D.C., Urban Institute Press, 1997 McElroy, Moorcott, Trends Over Time in Teenage Pregnancy and Childbearing, The Critical Changes, in Kids Having Kids, Economic Costs and Social Consequences of Teen Pregnancy. Edited by Maynard R.A. Washington, D.C., Urban Institute Press, 1997 Mercer R., Parents at Risk. New York, Springer, 1990 Parker B., Abuse of Adolescents, What Can We Learn from Pregnant Teenagers? Hans Clin Issues Perinet Women's Healthness 4:363, 370, 1993 116 Psychological Aspects of Women's Health Care, 2nd edition Rainey D.Y., Stephen Simon C., Kaplan D.W., Are adolescents who report prior sexual abuse at higher risk for pregnancy? Child Abuse Nickel 19:1283, 1288, 1995 Rubin R., Maternal Identity and the Maternal Experience. New York, Springer, 1984 Scafidi Fa, Field T., Prodromides M., et al., Psychosocial Stressors of Drug-Abusing Disadvantaged Adolescent Mothers. Adolescents 32:93, 100, 1997 Scholl 2, Heidegger M.L., Belsky D.H., Prenatal Care and Maternal Health During Adolescent Pregnancy, A Review and Meta-Analysis. J. Adolescent Health 15:444, 456, 1994 Singer D.G., Revenson Ta, A Piaget Primer, How a Child Thinks. New York, New American Library, 1978 Stephen Simon C., Reichert S., Sexual Abuse, Adolescent Pregnancy, and Child Abuse. Archpediatra Adolesc Med 148:23, 27, 1994 Stephen Simon C., Kelly L., Singer D., Absence of Negative Attitudes Toward Childbearing Among Pregnant Teenagers. Archpediatra Adolesc Med 150:1037, 1043, 1996 of Stephen Simon C., Kelly L., Singer D., et al., Why Pregnant Adolescents Say They Did Not Use Contraceptives Prior to Conception. J. Adolesc Health 19:48, 53, 1996 B. Zobin L.S., Hayward S.C., Adolescent Sexual Behavior and Childbearing. Newbury Park C.A., Sage, 1993 Zakos G., Wilde S., Adolescent Abortion Option. SOC Work Healthcare 12:77, 91, 1987 Zaccolillo M., Myers J., Acid Hair S., Conduct Disorder, Substance Dependence, and Adolescent Motherhood. AMJ Orthopsychiatry 67:152, 157, 1997 7 Postpartum Disorders Gail Ehrlich Robinson, MD, D.Psych, FRCPC Donna E. Stewart, MD, D.Psych, FRCPC. Mental disturbance following childbirth was first mentioned by Hippocrates, but the first good clinical description of postpartum psychosis was written by a French psychiatrist, Louis Mars, in 1858. There was little interest in this disorder until Pfaffenberger, 1961, showed that admission to mental hospitals was enormously increased during the first month postpartum, and Hamilton, 1962, argued that puerperal psychosis was a distinct disorder. Psychologic disturbances can occur in the postpartum period in the form of maternity, baby blues, postnatal depression, or psychosis. Although any psychiatric disorder may present or recur in the postpartum period, it is clear that affective disorders are most common. Not uncommonly seen after delivery, however, are adjustment, attachment, obsessive-compulsive, and anxiety disorders as well as schizophrenia. Postpartum adaptation. The postpartum period involves numerous physiologic, psychologic, and sociocultural changes. All of the following have been investigated as possible etiologic factors in postpartum disorders. Biologic factors. Dramatic changes in hormone and electrolyte balance and fluid volume level occur during labor and the postpartum period. After birth, progesterone, and 118 psychological aspects of women's health care, second edition estriol rapidly fall, returning to pre-pregnancy levels by 3 days after delivery. When estrogen falls after birth, prolactin, which has risen during pregnancy, is no longer blocked and lactation is initiated. Suckling by the infant stimulates the secretion of oxytocin. The usual cyclic variation of androgens is absent during both pregnancy and lactation. Plasma corticosteroids reach a peak during labor and decrease significantly within 4 hours postpartum. Thyroid function returns to pre-pregnancy levels approximately 4 weeks after delivery. Beta endorphins rise during labor, reach a peak immediately before delivery, and decline after parturition. Plasma renin falls after childbirth. Sodium excretion rises and calcium excretion falls. Several days after birth, a rapid weight loss occurs. Testosterone is associated with greater reported mood disturbances after delivery, Buckwalter et al. 1999. Several methodologic problems have hampered studies on the biologic basis of postpartum disorders. Early researchers could not accurately assay hormones, particularly free, unbound plasma concentrations. Psychologic rating scales used in various studies differed. Some, confounded by the normal physical symptoms of the puerperium, were obviously inappropriate measures of maternal mental states. Blood sampling often took place at inappropriate times, ignoring activities such as breastfeeding that can alter hormone levels. Seasonal variations in hormones and circadian rhythmicity were often overlooked. Studies that examined one hormone in isolation were inadequate because of complex endocrine interrelationships. Psychosocial factors. Transition to parenthood has a significant impact on both men and women, their relationship as a couple, and their work and social activities. New conflicts may arise and old ones resurface. Problems in the relationship between the woman and her own mother may increase her difficulties in the development of her new maternal identity. She must also come to terms with her own femininity. A woman's postpartum adaptation is intimately linked to the quality of the relationship with her partner, Zelkowitz and Milet 1996. A supportive relationship with the child's father can help mitigate the stresses of being a new mother. In many cases, the family system must be reorganized, and many couples adopt more traditional roles. Couples with reasonably egalitarian relationships often have more difficulty adjusting to new parenthood because, regardless of previous philosophies, it is usually the mother who accepts the major share of parenting tasks. The parents must decide how their postpartum disorders' 119 new roles will affect their previous work patterns and implement the necessary changes. With the added burden of childcare, the relationship between the partners often suffers, and there is less time for socializing. Groups of other new parents can be very supportive in helping the couple work through these normal adjustments. Parity, culture, expectations, financial problems, and housing difficulties may all affect normal postpartum reactions and the developing relationship between the mother and her new baby. Infant feeding. It is generally agreed that breastfeeding is best for young infants, for both nutritional and other health reasons. It may also facilitate mother-child bonding. Although 65% of North American mothers begin breastfeeding, only 25% continue for 4 months. Although they are aware of the benefits of breastfeeding, many mothers prefer bottle feeding for various reasons. Wallet 1987, including modesty, discomfort, an unsupportive environment, difficulties in breastfeeding, a wish to share feeding responsibilities with others, or uncertainty about the amount of breast milk provided. The father's attitude toward breastfeeding often plays a vital role. Either partner's beliefs about the effect of breastfeeding on contraception or breast size and shape can also influence its acceptance. In addition, women who are returning to the workplace shortly after the birth may find it impossible to continue breastfeeding, whereas women on a demand schedule may feel overburdened by the responsibility of being available every few hours. Some women think their husbands will become more involved if they choose bottle feeding. A woman's attitude toward breastfeeding is greatly improved with support from her physician, hospital staff, and other healthcare providers. Information and support about breastfeeding is valuable in helping women weather the difficult first few weeks after birth. It is vital, however, that the woman not be made to feel guilty, whatever her informed choice. Maternity blues. Maternity blues is a common, benign, transitory condition occurring in the first 10 days postpartum. Its incidence ranges from 28%, 80%, Harris 1980, Langchick et al. 1992. 120 Psychological Aspects of Women's Healthcare, 2nd edition clinical presentation. Maternity blues typically begin 3 to 4 days after delivery, Stein 1982, and peak on days 4 to 5. The most frequently reported symptom is weeping. In the first few hours after delivery, crying may be accompanied by happy feelings. Handley et al. 1980, felt that depressed mood is characteristic of maternity blues, whereas Canorley and Gath, 1986, found that although women described themselves as low-spirited, they did not consider themselves to be depressed. Emotional lability seems to be a characteristic feature. Elation, postpartum pinks, may also occur and may be mild or predict more serious mood disturbance. Researchers have also described irritability, lack of affection for the baby, hostility toward the husband, sleep disturbance, headaches, feelings of unreality, depersonalization, exhaustion, and restlessness in women suffering from maternity blues. Although many mothers describe themselves as being absent-minded, distracted, and lacking in concentration, psychologic tests have produced no evidence that cognitive impairments are common, Canorley and Gath 1986. Etiology. Psychosocial factors. No clear correlations have been established between maternity blues and various psychosocial factors. Maternity blues have been reported in all social classes, Bollinger et al. 1979, Stein 1980, and in many different cultures, Davidson 1972, Harris 1980. The condition is unrelated to marital status, Davidson 1972, although associations have been reported with poor marital relationships, Bollinger et al. 1979, Catrona 1984. No positive association has been reported between the blues and other external stressors, Pakel et al. 1980, Pitt 1973. Hospital delivery does not appear to be a causal factor, because there is an equal incidence in home deliveries, Yalom et al. 1968. Contradictory findings have been reported for the association of maternity blues with personality factors, Knott et al. 1976, Pitt 1973, The Primipara State, Bollinger et al. 1979, Knott et al. 1976, Stein 1980, Ambivalent Attitudes Toward Pregnancy, Nilsson and Almgren 1970, Fear of Labor, Bollinger et al. 1979, Canorley and Gath 1986, and Anxiety and Depression During Pregnancy, Davidson 1972, Handley et al. 1980. O'Hara et al. 1991, reported a history of personal and family depression, more problems with social adjustment, and stressful life events in women who get postnatal blues compared with women who do not. Postpartum disorders. 121 biologic factors. The high incidence, typical onset at 3 days postpartum, fluctuating course, and lack of clear psychosocial causation of maternity blues have led many researchers to suspect a biologic cause. However, no consistent correlations have been found between maternity blues and prolactin, cortisol, thyroid hormones, beta endorphins, norepinephrine, 5-hydroxytryptamine, cyclic adenosine monophosphate, electrolytes, or pyridoxine, George and Sandler 1988. O'Hara et al., 1991, reported higher levels of free and total estriol before and after delivery in women who develop blues compared with those who do not. Harris et al., 1994, found a relationship between severity of the blues and the high levels and steep rate of rise of progesterone antenatally as well as a steep drop postnatally. Obstetric and gynecologic factors Yalom et al., 1968, noted a higher incidence of obstetric anomalies or subjective discomfort during pregnancy in women with maternity blues, whereas Pitt, 1973, and Bollinger et al., 1979, did not. No link was found among maternity blues and physiologic monitoring during pregnancy, Bloomberg 1980, cesarean section, Kendall et al. 1981, or breastfeeding compared with bot lifting, Bollinger et al. 1979, Cox et al. 1982. Researchers have reported that women who experience maternity blues were of a younger age at menarche, Yalom et al. 1968, have a shorter menstrual flow, Yalom et al. 1968, experience more menstrual irregularities, Handley et al. 1980, and have a history of premenstrual tension, Bollinger et al. 1979, compared with those who do not experience this condition. Davidson and Robertson, 1985, however, failed to find any association with previous menstrual difficulties. Treatment women with maternity blues benefit from reassurance that the symptoms are common and will disappear quickly. Emotional support and instruction on newborn care may also be helpful. Women should be advised to seek help if symptoms are severe or persist for more than 2 weeks. Prognosis: most women completely recover from maternity blues in a few days to 2 weeks. In a small number, however, the symptoms escalate into more serious 122 psychological aspects of women's health care, second edition psychiatric conditions. Many women experience maternity blues after each pregnancy. Disorders of the mother, infant relationship. Disorders of the mother, infant relationship range from delayed attachment to infanticide. Studies of these disorders are limited by problems in methodology, including the difficulty of measuring maternal, infant attachment. Incidence: delayed attachment is reported in approximately 10% of mothers. Absolute rejection of the infant and obsessive, hostile thoughts about the baby are seen in 1% of mothers. Estimates of child abuse vary greatly and depend on the criteria used and cultural norms. Infanticide occurs in 1/50,000 births in the United Kingdom, Brockington and Cox-Roper 1988. Clinical presentations: approximately 40% of primiparous women experience mild detachment or negative feelings toward their infants in the immediate postnatal period, with a gradual increase in the strength of maternal feelings over the ensuing few weeks, Robson and Powell 1982. In more severe, persistent disorders of attachment, the mother expresses disinterest, neglect, and failure to protect, nurture, or interact with the infant. Delayed attachment can be primary or can occur secondary to another psychiatric disorder, such as an adjustment disorder, depression, mania, psychosis, anxiety, obsessive-compulsive disorder, or personality disorders. Mark Eisen, 1982, has described infant rejection in which the mother shows persistent hostility, often wishes the child had never been born, and is determined to avoid the maternal role. Other women may feel normally loving toward their infants but may be afraid of contact because of obsessional, intrusive, and distressing thoughts about their babies, including impulses to harm them, Brockington and Cox-Roper 1988. Etiology: cultural factors and social class influence the way a woman first relates to her child, Robson and Powell 1982. The role of maternal personality factors in postpartum disorders 123 facilitating or interfering with attachment is still being studied. Women who have had disrupted or inadequate mothering themselves, Frommer and O'Shea 1973, and single teenage mothers without social supports should be considered at special risk for attachment disorder. Painful and difficult childbirth experiences have also been linked to early maternal detachment, Robson and Kumar 1980. Congenital defects or prematurity in the infant may result in a lack of attachment or rejection because of fear of subsequent loss. Problems with obsessional hostile feelings toward the newborn may be a manifestation of obsessive-compulsive illness or depression, Beck 1995. Socioeconomic or environmental stresses tend to exacerbate difficulties in attachment. Persistent rejection of the newborn is found most frequently in unwanted pregnancies, Resnick 1970. Management. Most delays in attachment resolve spontaneously within the first few days or weeks postpartum. Education about delayed attachment may alleviate the mother's guilt. Although it has not been clearly established that brief separation leads to attachment disorders, it is important to maintain close contact if either the mother or the baby requires hospitalization. Mothers who suffer from continued bonding problems may benefit from practical advice and support concerning infant care, psychotherapy to explore the determinants of the problem, behavioral approaches designed to decrease anxiety when coping with the baby, and occasionally joint admission to a mother-infant unit. Severe disturbances of attachment, in which the infant is at serious risk of abuse or neglect, may require protective custody, joint treatment, or enforced supervision where available. Obsessional thoughts of hostility toward the baby may respond to psychotherapy, often combined with pharmacotherapy with an antidepressant such as clomipramine or a selective serotonin reuptake inhibitor. Women with attachment difficulties secondary to other psychiatric disorders should be reassessed after the primary disorder has been treated. Effects on the neonate. Delayed attachment or early temporary separation from the mother has not been proven to have significant long-term effects on the baby, Robson and Powell 1982. Children who suffer from ongoing lack of bonding, however, may show failure to thrive, stunted emotional and cognitive development, and difficulty in developing peer relationships. These infants are also at more 124 psychological aspects of women's health care, second edition risk of being abused and rejected. A comprehensive review of infanticide, Resnick 1970, found that the victims of neonaticide, murder of the newborn within 24 hours of its birth, were most commonly unwanted babies of mothers who were young, unmarried, and without evidence of psychosis or depression. Many of the women were denied or failed to seek an abortion for an unwanted pregnancy they were afraid to reveal to their families. Postnatal depression. Postnatal depression is an affective disorder lasting more than 2 weeks, the severity of which meets criteria for DSM-4 affective disorder, American Psychiatric Association 1994. Carefully designed research has cast doubt on the existence of postnatal depression as a distinct entity, O'Hara and Zekowski 1988. In a group of pregnant women and matched, non-pregnant control women, rates of depression were 10.6% for postpartum women during the first 9 weeks after delivery and 10% for control subjects. O'Hara and Zekowski, 1988, concluded that there was no evidence that postpartum subjects were at greater risk for depression than control subjects. However, hospitalization rates to psychiatric hospitals are higher in the 30 days after delivery than at any other time in a woman's life, Pfaffenberger 1961. Regardless of whether postpartum depression is a distinct illness, the subsequent negative consequences to the mother, her marital relationship, and her child make postnatal depression an important condition to diagnose and treat. Prevalence and epidemiology. A meta-analysis of numerous studies found the average prevalence rate of postnatal depression to be 13%, O'Hara and Swain 1996. Lower occupational status of the mother and lower family income were found to be small but significant predictors of depression, whereas maternal age, marital status, education, parity, and length of relationship with partner all failed to significantly predict postnatal depression, O'Hara and Swain 1996, O'Hara and Zekowski 1988. Clinical presentation. Postnatal depression usually begins within 1 to 6 months after delivery. In some women, maternity blues simply continue and become more severe. In postpartum disorders 125 others, a period of well-being is followed by gradual onset of depression, characterized by tearfulness, despondency, emotional lability, guilty feelings, anorexia, and sleep disturbances, as well as feelings of being inadequate to cope with the infant, poor concentration and memory, fatigue, and irritability. Robinson and Stewart, 1986. Some women may worry excessively about the baby's health or feeding habits and see themselves as bad, inadequate, or unloving mothers. Etiology. Psychosocial factors. Studies of postnatal depression have been handicapped by methodologic errors and the inability to identify it as a distinct disorder. A relationship has been reported, however, between measurable anxiety during pregnancy and the level of postpartum depressive symptoms. Hayworth et al. 1980, Watson et al. 1984. Kumar and Robson, 1984, found no increase in previous psychiatric diagnoses in women with postpartum depression, in contrast with the findings of O'Hara, 1986, and O'Hara et al., 1983. O'Hara, 1986, also found that a higher percentage of depressed subjects, 66.7%, had a family history of depression than did non-depressed women, 20.7%. Several well-designed studies, Braverman and Rue 1978, Kumar and Robson 1984, have reported an increased risk of postpartum depression in women who experience marital problems during pregnancy. Hopkins et al., 1986, however, failed to confirm this finding. Women with postnatal depression perceived their husbands to be less supportive than did women who were not depressed, but these differences were apparent only postpartum, not during pregnancy. O'Hara 1986, O'Hara et al. 1983. Catrona, 1984, found that the availability of companionship and a feeling of belonging to a group were more important predictors of good adjustment than was intimacy with the husband. Only a few studies, Hopkins et al. 1986, found no association between measures of social support and the occurrence of postnatal depression. No relationship has been demonstrated between various obstetric variables and postnatal depression. Contradictory findings have been reported concerning the contribution of a poor relationship between the woman and her mother to postnatal depression. Kumar and Robson 1984, Nilsson and Almgren 1970, Pakel et al. 1980, Watson et al. 1984. Although O'Hara et al. 1984, and Catrona, 1984, found a relationship between external stressors and higher levels of postpartum depressive symptoms, Hopkins et al., 1986, found a relationship. 126 Psychological Aspects of Women's Healthcare, 2nd edition, only with having a baby who is difficult to care for or a baby with neonatal complications. Similarly, Kumar and Robson, 1984, found no association between stressful life events and postnatal depression. Biologic factors. Although it has been suggested that postnatal depression is caused by low levels of progesterone or estrogen or high levels of prolactin, no significant relationships have been found. Harris 1994, Hendrick et al. 1998. Some women may be especially vulnerable to normal hormonal changes that may trigger depression. Hendrick et al. 1998, Stewart and Boydell 1993. Alder and Cox, 1983, found that women who were breastfeeding their infants and taking oral contraceptives postpartum had a higher risk of depression at 3 to 5 months postnatally than did women who were breastfeeding exclusively but not taking oral contraceptives. No conclusive evidence relating the various neurotransmitter systems, free or total tryptophan levels, or cortisol levels and postnatal depressive symptoms has been demonstrated. Llewellyn et al. 1997. However, Harris, 1996, showed a minor association of postnatal depression and thyroid dysfunction in thyroid antibody positive women. Summary of etiologic factors. The most relevant etiologic factors for postnatal depression are those found in association with depression in general, personal or family psychiatric history of depression, lack of support, especially from the spouse, and occurrence of a number of negative life events around the time of delivery. O'Hara and Swain 1996, Stowe and Nemiroff 1995. Treatment. Postnatal depression is treated on both a psychosocial and a biologic basis. Identification and acknowledgement of the depression itself may be a helpful feature, dispelling the woman's fears of physical disease and personal inadequacy. Individual or group psychotherapy may help the woman resolve conflicts about mothering or her new role. Joint counseling is indicated if there are conflicts with or a lack of support from her partner. Information about newborn care, social assistance, and practical support such as homemaking may also be beneficial. Medication, such as nortriptyline, 75 to 100 mg/day, desipramine, 150 to 300 mg/day, fluoxetine, 20 to 60 mg/day, paroxetine, 20 to 60 mg/day, or sertraline, 50 to 150 mg/day, is helpful for many depression and postpartum disorders. 127 Anxiety disorders. The use of minor tranquilizers to reduce anxiety should be limited to brief or adjunctive therapy to reduce the risk of dependency. Estradiol has been reported as a useful treatment in 2 small studies and requires further investigation. Ahokas et al. 2000, Gregoire et al. 1996. Chapter 5 discusses the use of drugs in the breastfeeding mother. Prevention. Discussion of postpartum mood disorders during prenatal classes is likely to improve early detection and presentation for treatment. Gordon and Gordon, 1960, found that patients with a postnatal depression who received active social intervention as well as dynamic psychotherapy required shorter treatment and were less likely to require hospitalization. The women attending these groups, especially those accompanied by their husbands, experienced fewer emotional problems than did those in the control group. Hallinan and Passman, 1985, Shereshevsky and Lockman, 1973, and Broussard, 1976, found that either prenatal counseling or relaxation training could decrease the level of the woman's distress and improve the marital relationship postpartum. In a study of 15 women, Wisner and Wheeler, 1994, found that starting antidepressants within the first 24 hours after birth in women with a history of postnatal depression decreased the expected recurrence rate. Oral estrogen has been proposed as prophylaxis for women with histories of affective disorders occurring only in the puerperium, but studies remain limited. Sichel et al. 1995. Prognosis. Postnatal depression usually lasts several months if not treated. Kumar and Robson 1984, Watson et al. 1984. Women may have difficulties in bonding with their infants and may express feelings of rejection, dislike, or indifference. Margison 1982, Teddy et al. 1995. Women with postnatal depression are also more likely to experience future episodes of depression. Kaplan et al. 1989. Although the occurrence of a postnatal depression does not guarantee behavioral, cognitive, or social problems in the toddler or young child, exposure to maternal depression in the early postpartum months may have an enduring influence on the child's psychological adjustment. Murray et al. 1999. Subsequent depression in these women has been associated with poor adjustment of the child at 4 years of age. Kaplan et al. 1989, Phillips and O'Hara 1991. 128 Psychological Aspects of Women's Health Care, 2nd edition. Puerperal psychoses. Puerperal psychoses are psychotic disorders arising after childbirth. Controversy exists over the specificity and timing of these disorders because early research suffered from confounding variables such as differences in case definitions and the time period allowed for the occurrence of such disorders. Brockington et al. 1982. Consequently, some authors consider these disorders to be distinct entities with specific etiologies, clinical presentations, and prognosis. Brockington et al. 1982, Hamilton 1962, whereas most believe that they are simply episodes of psychotic illness triggered by the stresses of pregnancy and delivery. Kendall et al. 1987. Although women with schizophrenia frequently suffer from psychotic relapses within weeks after delivery, most authorities now agree that most postpartum psychoses are affective disorders. Kendall et al. 1987. Brockington et al. 1982, found that early postpartum psychosis could be blindly differentiated from nonpuerperal psychosis. McNeil, 1986, found that manic postpartum disturbances were characterized by more confusion and disorganized speech than were nonpuerperal episodes, and postpartum psychoses were generally characterized by more disorganized behavior. Other distinctive characteristics included a symptom-free phase between delivery and onset of psychosis, marked confusion, changeability, unpredictability in clinical features, and distinguishing psychologic characteristics related to concerns about motherhood. Hamilton, 1982. Clouding of consciousness, Prothero, 1969, and an excess of Schneiderian symptoms, Cadremas et al. 1979, are also characteristic features. Incidence and prevalence. The incidence of psychiatric admission for postpartum psychosis is 1 to 2 per 1,000 postpartum women. The relative risk of admission for psychosis within the first 30 days following childbirth is 21.7, decreasing to 12.7 in the first 90 days. Despite this decrease over time, the relative risk remains elevated for 2 years following delivery. Women with a history of bipolar affective disorder appear to be particularly vulnerable. Kendall et al. 1987. Epidemiology. Primiparous women appear to have a higher risk for postpartum psychosis. In Edinburgh, 62% of cases occurred in primiparous women versus 47% in postpartum disorders 129. The general population. Kendall et al. 1981. No significant relationship to maternal age. Kendall et al. 1987, class, or culture has been found. Although Kendall et al. 1987, found an increased number of admissions in single women, this finding may be related to a lack of spousal support. Pfaffenberger, 1964. Early versus late onset. McNeil, 1986, 1987, 1988a, 1988b, found a number of significant differences between women who had early onset, within 3 weeks of delivery, and those with late onset postpartum illness. Women with early onset psychoses tended to have affective illnesses, to be primiparous, younger, and to have suffered emotional disturbance during pregnancy. Women with late onset illnesses tended to have schizophreniform illnesses, were older, of lower socioeconomic class, and single, and had suffered premorbid mental problems and more emotional disturbances before pregnancy but fewer during pregnancy. Clinical presentation. Most postpartum psychoses begin within the first 3 weeks after delivery. There is nearly always an asymptomatic period of 2 to 3 days after delivery. Prodromal symptoms include sleep disturbances, fatigue, depression, irritability, and emotional lability. The mother often has difficulty caring for her infant. Characteristically, she feels confused, perplexed, bewildered, and dreamy and may complain of poor memory, although performance on formal mental tests is often normal. Brockington et al. 1982. Clinical presentation may be an atypical or brief reactive psychosis, major affective disorder, schizophreniform disorder, or an organic brain syndrome. The most common presentation of puerperal psychosis is an affective disorder. In psychotic depression, the woman is tearful, has psychomotor retardation, sleep, and appetite disturbances, and is preoccupied with feelings of guilt and worthlessness. She may have delusions about the infants being dead or defective. She may deny having given birth or have hallucinations commanding her to harm the baby. These typical depressive features are often accompanied by a sense of confusion. In postpartum mania, the woman is excited, euphoric, grandiose, irritable, and hyperactive. She requires little sleep, and her appetite may be markedly reduced or exaggerated. She may have grandiose delusions about her baby. Insight is usually lacking. 130 Psychological Aspects of Women's Health Care, 2nd edition. In a schizophreniform presentation, the woman demonstrates thought disorder, delusions, inappropriate affect, hallucinations, agitation, motor retardation, bizarre delusional ideas about herself or her child, and lack of insight. Women who present with an organic brain syndrome have prominent symptoms of confusion, bewilderment, and memory loss. This syndrome may be caused by medical conditions such as encephalitis, autoimmune disorders, endocrine disturbance, electrolyte imbalance, or sepsis, but can occur in the absence of any recognizable medical disorder. Robinson and Stewart 1986, Wellner 1982, and may be an atypical presentation of bipolar affective disorder. Etiology researchers have been unable to confirm a link between puerperal psychosis and levels of prolactin, thyroxine, estrogen, progesterone, adrenocorticoids, follicle-stimulating hormone, or beta-endorphins. Brockington et al. 1982, Steiner 1979, Stewart et al. 1988. A 2.5-fold increased incidence of puerperal psychosis is seen after cesarean compared with vaginal delivery, Kendall et al. 1981. Other obstetric variables have not been found to increase risk. Studies by Prothero, 1969, and Winokur et al. 1978, suggested that although an inherited predisposition to psychotic illness exists, a specific inherited predisposition to puerperal illness does not. However, a strong link has been found between bipolar disorder and puerperal psychosis with affective symptoms. Women with a history of bipolar affective disorder have a 50% chance of developing postpartum psychosis. McNeil 1987. Women with a history of manic episodes are especially at risk for developing postpartum psychosis. Brockington et al. 1982. Moreover, the severity of past psychiatric illness appears to be significantly related to the occurrence of postpartum psychosis. McNeil 1987. First-degree relatives of women with bipolar disorders also have an increased incidence, 20%, of postpartum psychosis. Uttenberg and Ingleson 1978. Women with a history of schizophrenia have a 24% chance of developing postpartum psychosis. McNeil 1986. Treatment of puerperal psychosis usually requires admission to a hospital, particularly if the mother is at risk of harming herself or her child through neglect, abuse, or acting on delusions or hallucinations. Mothers may be at postpartum disorders 131 MIT independently or, preferably, together with their infants, if feasible. The woman's partner should be involved in the treatment from the beginning. Puerperal psychosis requires both pharmacologic and psychosocial therapy. Specific drug treatments vary with the presentation. For depressive psychosis, an antidepressant such as nortriptyline, desipramine, or a serotonin reuptake inhibitor combined with a major tranquilizer such as haloperidol, 110 mg per day, or olanzapine, 5 to 15 mg/day, usually controls the psychotic symptoms as well as the depression. If the patient does not respond to these medications, electroconvulsive therapy is often effective, usually providing complete remission after 6 to 8 treatments. Hypomanic or manic presentations are treated with lithium carbonate in daily doses of 600 to 1,200 mg until a therapeutic serum level of 0.8 to 1.2 mg/L is reached. Patients who are unresponsive to lithium carbonate may be treated with other mood stabilizers such as carbamazepine or valproic acid. A major tranquilizer may be necessary to control acute symptoms until an adequate serum level of lithium or another mood stabilizer is obtained. Women who present with a schizophreniform disorder should be treated with a major tranquilizer such as haloperidol, 4 to 10 mg/day, or olanzapine, 5-15 mg per day. Those who do not respond adequately sometimes benefit from a trial of electroconvulsive therapy, particularly if affective or catatonic symptoms are present. Conflicts about mothering, career, marital problems, issues relating to the woman's own mother, and concerns about femininity may require attention after the psychotic symptoms remit. Idealistic expectations of parenthood often need to be explored. The woman requires both practical and emotional support from her spouse, family, and friends, sometimes including education about child care. Individual or marital therapy may be indicated. Community social services may be extremely helpful for the mother and infant after discharge. Prognosis prior to the development of psychotropic drugs. Untreated puerperal psychosis required an average of 5 to 8 months of hospitalization, with many women continuing to have symptoms for many years. Brockington et al. 1982. Current treatments have substantially shortened the psychotic episodes. 95% of adequately treated women improve within 2 to 3 months. Reviewing the results of several studies, Brockington et al. 1982, found 132 psychological aspects of women's health care. Second edition that 31% of women suffered a further puerperal episode and that psychosis complicated 21% of future pregnancies. They estimated the risk for each succeeding pregnancy to be 20% and postulated that the risk was higher in women with more severe psychosis and multiple risk factors. Prophylactic lithium given immediately after delivery to women with a history of postpartum affective psychosis appears to reduce the recurrence risk to 10%. Stewart et al. 1991. Careful follow-up is indicated after subsequent deliveries, both for support and early case identification and treatment. Scove et al. 1984, found that 65% of women studied had at least one nonpuerperal relapse and only 25% remained free of later psychopathology. Of those who had nonpuerperal relapses, 43% had been diagnosed as suffering from affective psychosis, 38% from schizoaffective psychosis, and only 19% from schizophrenia. They found that nonpuerperal relapses were strongly related to a family history of psychosis and the occurrence of a psychotic episode before the index episode. Davidson and Robertson, 1985, looked specifically at women in whom the puerperal illness was the first onset of illness. Overall, 56% had at least one recurrent illness during follow-up. Of those women diagnosed as having unipolar depression, 40% had a nonpuerperal illness, whereas 30% had another puerperal disorder. Those diagnosed as having bipolar affective disorders had a 66% recurrence of nonpuerperal disorders and a 50% occurrence of subsequent puerperal psychosis. All of the women who had schizophrenia developed a chronic illness with frequent exacerbations. Effect on the mother-child relationship. Evidence on the long-term effects on children of mothers with puerperal psychosis is conflicting. The psychiatric history, premorbid personality, nature, and timing of the puerperal psychosis, current marital and environmental circumstances, degree of life stress, access to support, and health and temperament of the baby may all play a role. In the United Kingdom, many women are admitted to hospitals with their babies, either to a specialized mother-infant unit or to a general psychiatric ward. Although it is difficult to do randomized, controlled studies of the effectiveness of mother-infant admissions, a beneficial effect on the parent-child relationship and on parenting competence is apparent when measured 2 years later. Stewart 1989. It is difficult to predict which infants may be at risk of harm from their mothers. Most women who commit neonaticide are not psychotic at the time. Resnick 1970. Filicide, the murder of a child by its parent more than 24 postpartum disorders 133 hours after birth, however, is most often associated with mental illness as part of a suicide attempt, as a response to hallucinations or delusions, as a delusional attempt to prevent the child from suffering, or as an accidental result of a violent outburst. Women with manic, depressed, or schizophrenic illnesses may also place their children at risk through neglect and lack of judgment, and careful supervision is required while the mother is ill and recovering. Postpartum anxiety disorders. Anxiety disorder with or without panic attacks may develop de novo in the postpartum period. Metz et al. 1988, or a previous anxiety disorder may be exacerbated at this time. Cowley and Royburn 1989. Panic attacks are typical in nature and respond to the usual pharmacologic treatments. The extent to which pregravid anxiety disorder predicts the occurrence of postpartum anxiety is unknown. Cohen et al. 1994. Postpartum worsening of panic attacks is hypothesized to be caused by the rapidly changing concentrations of reproductive hormones on monoaminergic binding sites, Charney et al. 1990, or to the relationship between falling progesterone levels during the postpartum period and resulting rises in blood PCO2, Villepinto et al. 1992. The presence of even mild symptoms of panic disorder during pregnancy may indicate the possibility of a postpartum anxiety disorder and the need for treatment with antidepressant medication, such as imipramine 150-300 mg per day, fluoxetine 10 to 40 mg/day, or sertraline 25 to 100 mg/day, with or without cognitive behavior therapy, Cohen et al. 1994. Postpartum obsessive-compulsive disorders. Development of obsessive-compulsive disorders and obsessive-compulsive symptoms is not uncommon in the early postpartum period. Women with these disorders usually experience unwanted intrusive thoughts about harming their babies and may avoid situations in which they feel they are at risk of acting on their thoughts, example bathing or sleeping with the infants, preparing food with sharp knives. Not infrequently, women with postpartum depression may also develop obsessive-compulsive symptoms. These women usually recover promptly when treated with serotonin reuptake inhibitor antidepressants or clomipramine combined with supportive psychotherapy. However, some postpartum women appear to have a pure obsessive-compulsive disorder without effective changes, Williams and Coron 1997. These 134 psychological aspects of women's health care, second edition. Women are often more treatment resistant, although success has been experienced using higher doses of serotonin reuptake inhibitor antidepressants, example fluoxetine 80 mg per day, with cognitive behavioral therapy over a period of several months. Conclusions: postpartum psychiatric disorders have a major impact on women, their children, and their families. It is important for physicians to be aware of the possibility that a woman will develop an emotional disorder in the postpartum. Frequently, women are discharged home within 24 hours of birth, isolated, and do not see a health care provider again until their 6-week postpartum follow-up visit, when it may be discovered that they have been ill for many weeks. Women may hesitate to admit feeling depressed or unattached to the baby. Healthcare providers may dismiss their signs and symptoms as normal reactions to new motherhood. Women who may be particularly vulnerable to developing a postpartum disorder include those who have a history of psychiatric disorders, especially a bipolar affective disorder, are anxious or depressed during pregnancy, are younger mothers, lack a support network, have had difficult deliveries, or are under other current stresses. All women, however, should be considered to be at increased risk, and a strong case can be made for screening for psychosocial risk factors during prenatal and postpartum care, Evans et al. 2000, Reed et al. 1998. There is a great need for physicians and community-based groups to provide information, support, and reassurance to new mothers and to participate in detecting and treating postpartum illness at an early stage. References: Ahokas A. Ato M. Ryman R. Positive treatment effect of estradiol in postpartum psychosis, a pilot study. J. Clin Psychiatry 61:166, 169, 2000. Alder M. Cox J. L. Breastfeeding and Postnatal Depression. J. Psychosome Rest 27:139, 144, 1983. American Psychiatric Association, Diagnostic and Statistical Manual of Mental Disorders, 4th edition. Washington, D.C., American Psychiatric Association, 1994. Postpartum Disorders 135. Bollinger C.B., Buckley D., Naylor G.J., et al., Emotional Disturbance Following Childbirth, Clinical Findings and Urinary Excretion of Cyclic Amp Cycol Med 9:293 300, 1979. Beckcourt, The Effects of Postpartum Depression on Maternal, Infant Interaction, a Meta-Analysis. NIS-RES 44, 298-304, 1995. Bloomberg N. Effects of Neonatal Risk, Maternal Attitude and Cognitive Style on Early Postpartum Adjustment. J. Abnorm Cycol 89:139, 150, 1980 Braverman J., Rue J.F., Screening for the Patient at Risk for Postpartum Depression. Obstetgynecol 52:731, 736, 1978 Brockington Iv., Cox Roper A., The Nosology of Puerperal Mental Illness in Motherhood and Mental Illness, Vol. 2, Causes and Consequences. Edited by Kumar R., Brockington Iv. London, Wright, 1988, pp 1-16 Brockington Iv., Winokur G., Dean C., Puerperal Psychosis in Motherhood and Mental Illness, Vol. 1. Edited by Kumar R., Brockington Iv. London, Academic Press, 1982, pp 37-70 Broussard E.R., Evaluation of Televised Anticipatory Guidance to Primipary. Community Ment Health J12:203, 210, 1976 Buckwalter J.G., Stanchik F.Z., McCleary C.A., et al., Pregnancy, the Postpartum, and Steroid Hormones, Effects on Cognition and Mood. Psychoneuroendocrinology 24:69, 84, 1999 Kaplan Hill Coghill S.R., Alexandra H., et al., Maternal Depression and the Emotional Development of the Child. BRJ Psychiatry 154:818, 822, 1989 Charney D.S., Woods S.W., Nagy L.M., et al., Noradrenergic Functions in Panic Disorder. J. Clin Psychiatry 51:5, 11, 1990 Cohen L.S., Sichelda, Dimmock J.A., et al., Postpartum Course in Women with Pre-Existing Panic Disorder. J. Clin Psychiatry 55:289, 292, 1994 Cowley D.S., Royburn P.P., Panic Disorders During Pregnancy. J. Psychosome Obstetgynecol 10:193, 210, 1989 Cox J.L., Connor Y., Kendall Ree, Prospective Study of the Psychiatric Disorders of Childbirth. BRJ Psychiatry 140:111, 117, 1982 Catrona C.E., Causal Attributions and Perinatal Depression. J. Abnorm Psychol 92:161, 172, 1983 Catrona C.E., Social Support and Stress in the Transition of Parenthood. J. Abnorm Psychol 93:378, 390, 1984 Davidson J.R., Postpartum Change in Jamaican Women, A Description and Discussion on Its Significance. BRJ Psychiatry 121:659, 663, 1972 Davidson J., Robertson E., A Follow-Up Study of Postpartum Illness 1946-1978. Acta Psychiatriscan 71:451, 459, 1985 Evans G.G., Theophrastus J.P., Galvin S.L., Postpartum Depression, A Comparison of Screening and Routine Clinical Examination. AMJ Obstetgynecol 182:1080, 1082, 2136 Psychological Aspects of Women's Healthcare, 2nd edition Fromer E.A., O'Shea G., Antenatal Identification of Women Liable to Have Problems in Managing Their Infants. BRJ Psychiatry 123:149, 156, 1973 George A., Sandler M., Endocrine and Biochemical Studies in Puerperal Mental Disorders, in Motherhood and Mental Illness, Vol. 2, Causes and Consequences. Edited by Kumar R., Brockington Iv., London, Wright, 1988, pp 78-112 Gordon Ree, Gordon K.K., Social Factors in the Prevention of Postpartum Emotional Problems. Obstetgynecol 15:433, 438, 1960 Gregoire A. J.P., Kumar R., Everett B. et al., Transdermal Oestrogen for Treatment of Severe Postnatal Depression. Lancet 347:930, 933, 1996 Hallinan J.S., Passman R.H., Relaxation Training and Expectation in the Treatment of Postpartum Distress. J. Consult Clin Psychol 53:839, 845, 1985 Hamilton J.A., Postpartum Psychiatric Problems. St. Louis, Missouri, C.V. Mosby, 1962. Hamilton, J.A., The Identity of Postpartum Psychosis in Motherhood and Mental Illness, Vol. 1. Edited by Brockington Iv, Kumar R. London, Academic Press, 1982, pp. 1-20. Handley S.L., Dunn T.L., Waldron G., et al., Tryptophan, Cortisol, and Puerperal Mood. BRJ Psychiatry 136:498, 508, 1980. Harris B., Maternity Blues. BRJ Psychiatry 136:520, 521, 1980. Harris B., Biological and Hormonal Aspects of Postpartum Depressed Mood. BRJ Psychiatry 164:288, 292, 1994. Harris B., Hormonal Aspects of Postnatal Depression. International Review of Psychiatry 8:27, 36, 1996. Harris B., Lovett L., Newcomb R. L., et al., Cardiff Puerperal Mood and Hormone Study Paper 2, Maternity Blues and Major Endocrine Changes, The Progesterone Factor. BMJ 308:949, 953, 1994. Hayworth J., Little B.C., Carter S.B., et al., A Predictive Study of Postpartum Depression, Some Predisposing Characteristics. BRJ MedPsychol 53:161, 167, 1980. Hendrick v. Altschuler LL, Suri R., Hormonal Changes in the Postpartum and Implications for Postpartum Depression. Psychosomatics 39:93, 101, 1998. Hopkins J., Campbell S.B., Marcus M., The Role of Infant-Related Stressors in Postpartum Depression. J. Abnorm Psychol 96:237, 241, 1986. Kadramas A., Winokur G., Crow R., Postpartum Mania. BRJ Psychiatry 135:551, 554, 1979. Kendall Reeve, Rennie D., Clark J.A., et al., The Social and Obstetrics Correlates of Psychiatric Admission in the Puerperium. Psychol Med 11:341, 350, 1981. Kendall Ree, Chalmers J.C., Platt C., Epidemiology of Puerperal Psychoses. BRJ Psychiatry 150:662, 673, 1987. Canorally H., Gath D., Maternity Blues Reassessed. Psychiatry Dev 1:1, 17, 1986. Kumar R., Robson K.M., A Prospective Study of Emotional Disorders in Childbearing Women. BRJ Psychiatry 144:35, 47, 1984. Postpartum Disorders 137. Langchick M., Spengler H., Heydrich A. et al., Postpartum Blues, Depressive Disease or Pseudoneurasthenic Syndrome. J. Affect Disorder 25:47, 52, 1992. Llewellyn A. M., Stosy N., Nemiroff C.B., Depression During Pregnancy and Puerperium. J. Clin Psychiatry 58:26, 32, 1997. Mars L.V., Trait de la folie de femme enceinte, de nouvelles accouches et de nourrices. Paris, France, Bellier, 1858. Margison F., The Pathology of the Mother-Child Relationship in Motherhood and Mental Illness, Vol. 1. Edited by Brockington Iv, Kumar R. London, Academic Press, 1982, pp. 191-232. McNeil T.F., A Prospective Study of Postpartum Psychoses in a High-Risk Group, I. Clinical Characteristics of the Current Postpartum Episodes. Acta Psychiatriscan 74:205, 216, 1986. McNeil T.F., A Prospective Study of Postpartum Psychoses in a High-Risk Group, 2, Relationships to Demographic and Psychiatric History Characteristics. Acta Psychiatriscan 7535, 43, 1987. McNeil T.F., A Prospective Study of Postpartum Psychoses in a High-Risk Group, 3, Relationship to Mental Health Characteristics During Pregnancy. Acta Psychiatriscan 77:604, 610, 1988. A McNeil T.F., a prospective study of postpartum psychoses in a high-risk group. 4. Relationship to life situation and experience of pregnancy. Acta Psychiatriscan 77:645, 653, 1988. B. Metze, Sicilda, Goff D.C., Postpartum Panic Disorder. J. Clin Psychiatry 49:278, 279, 1988. Murray L., Sinclair D., Cooper P., et al., The Socio-Emotional Development of 5-Year-Old Children of Postnatally Depressed Mothers. J. Child Psychol Psychiatry 40:1259, 1271, 1999. Nilsson A., Almgren P., Perinatal Emotional Adjustment, a prospective investigation of 165 women. Acta Psychiatriscan Sup 220:65, 141, 1970. Not, P.N., Franklin M., Armitage C., et al., Hormonal Changes and Mood in the Puerperium. B.R.J. Psychiatry 128:379, 383, 1976. O'Hara M.W., Social Support, Life Events, and Depression During Pregnancy and the Puerperium. ArchGen Psychiatry 43:569, 573, 1986. O'Hara M.W., Swain A.M., Rates and Risk of Postpartum Depression, a Meta-Analysis. International Review of Psychiatry 837, 54, 1996. O'Hara M.W., Zekowski M., Postpartum Depression, a Comprehensive Review in Motherhood and Mental Illness, Vol. 2, Causes and Consequences. Edited by Kumar R., Brockington Iv. London, Wright, 1988, pp 17-63. O'Hara M.W., Rem L.P., Campbell S.P., Postpartum Depression, a Role for Social Network and Life Stress Variables. J. Nerve Mentis 171:336, 341, 1983. 138 Psychological Aspects of Women's Healthcare, 2nd edition. O'Hara M.W., Noon Aber D.J., Zekowski M., a Prospective Study of Postpartum Depression, Prevalence, Course, and Predictive Factors. J. Abnorm Psychol 93:158, 171, 1984. O'Hara M.W., Schleck J.A., Lewista, et al., Prospective Study of Postpartum Blues, Biologic and Psychosocial Factors. ArchGen Psychiatry 48:801, 806, 1991. Pfaffenberger Ars, The Picture Puzzle of Postpartum Psychosis. J. Chronic Dis 13:161, 173, 1961. Pfaffenberger Ars, Epidemiological Aspects of Postpartum Mental Illness. B.R.J. Prevent SOC Med 18:189, 195, 1964. Pakel E.S., Ems M., Fletcher J., et al., Life Events and Social Support in Puerperal Depression. B.R.J. Psychiatry 136:339, 346, 1980. Phillips L.H.C., O'Hara M.W., Prospective Study of Postpartum Depression, for 1/2-year follow-up of women and children. J. Abnorm Psychol 2, 151-155, 1991. Pitby, Maternity Blues. B.R.J. Psychiatry 122:431, 435, 1973. Protherosi, Puerperal Psychoses, a Long-Term Study 1927-1961. B.R.J. Psychiatry 115:930, 1969. Reed A.J., Beringer A., Carol J.D., et al., Using the Alpha Form in Practice to Assess Antenatal Psychosocial Health. Kin-Med Association J. 159:677, 684, 1998. Resnick P.J., Murder of the Newborn, A Psychiatric Review of Neonaticide. AMJ Psychiatry 126:1414, 1420, 1970. Robinson G.E., Stewart D., Postpartum Psychiatric Disorders. CMAJ 13431, 37, 1986. Robson K.M., Kumar R., delayed onset of maternal affection after childbirth. BRJ Psychiatry 136:347, 353, 1980 Robson K.M., Powell E., Early Maternal Attachment in Motherhood and Mental Illness, Vol. 1. Edited by Brockington Iv, Kumar R. London, Academic Press, 1982, pp 155-190 Scope J, Briois C., Jonquière M., et al., on the Nosology of Severe Psychiatric Postpartum Disorders. Urarch Psychiatry Neurol Psy 234:54, 63, 1984 Sharashevsky P.M., Lockman R.F., Comparison of Counseled and Non-Counseled Groups, in Psychological Aspects of a First Pregnancy. Edited by Sharashevsky P.M., Yarrow L.J. New York, Raven, 1973, pp 151-163 Sichelda, Cohen L.S., Robertson L.M., et al., Prophylactic Estrogen in Recurrent Postpartum Affective Disorder. Bile Psychiatry 38:814, 818, 1995 Stein G.S., The Pattern of Mental Change and Body Weight Change in the First Postpartum Week. J. Psychosome Res 24:165, 171, 1980 Stein G.S., The Maternity Blues, in Motherhood and Mental Illness, Vol. 1. Edited by Brockington Iv, Kumar R. London, Academic Press, 1982, pp 119-154 Steiner M., Psychobiology of Mental Disorders Associated with Childbearing, an Overview. Acta Psychiatriscan 60:449, 464, 1979 Stewart D., Psychiatric Admission of Mentally Ill Mothers with Their Infants. Ken J. Psychiatry 3434, 38, 1989 Postpartum Disorders 139 Stewart D., Boydell K.M., Psychologic Distress During Menopause, Associations Across the Reproductive Life Cycle. Int J. Psychiatry Med 23:157, 162, 1993 Stewart D., Addison A.M., Robinson G.E., et al., Thyroid Function in Psychosis Following Childbirth. AMJ Psychiatry 145:1579, 1581, 1988 Stewart D., Klompenhower J.L., Kendall Rhee, et al., Prophylactic Lithium in Postpartum Affective Psychosis, 3 Centers Experience. BRJ Psychiatry 158:393, 397, 1991 Stosy N., Nemiroff C.B., Women at Risk for Postpartum Onset Major Depression. AMJ Obstetgynekal 173:639, 645, 1995 Teddy D.M., Messenger D.S., Gelfand D.M., et al., Maternal Depression and the Quality of Early Attachment, an Examination of Infants, Preschoolers, and Their Mothers. Dev Psychol 31:364, 376, 1995 Uddenberg N., Ingleson I., Prognosis of Postpartum Disturbance. Acta Psychiatriscan 58:201, 212, 1978 Villeponto V.A., Lydiard R.B., Laraya M.T., et al., The Effects of Pregnancy on Pre-Existing Panic Disorder. J. Clin Psychiatry 53:201, 203, 1992 Watson J.P., Elliott S.A., Rugg A.J., et al., Psychiatric Disorder in Pregnancy and the First Postnatal Year. BRJ Psychiatry 144:453, 462, 1984 Wellner A., Childbirth-Related Psychiatric Illness. Compare Psychiatry 23:143, 154, 1982 Williams K., Coron L.M., Obsessive-Compulsive Disorder in Pregnancy, the Puerperium and the Premenstruum. J. Clin Psychiatry 58:330, 334, 1997 Winokur G., Beer D., Van Valkenburg C., et al., Is a Familial Definition of Depression Both Feasible and Valid? J. Nerve Mentis 166:764, 768, 1978 Wisner K.L., Wheeler R.N., Prevention of recurrent postpartum major depression. Hospital and Community Psychiatry 45:1191, 1196, 1994 Wallet A, Who Breastfeeds? The Family and Cultural Context. J. Reprod Infant Psychol 5:127, 131, 1987 Yalom I, Lund DT, Moose RH, et al., Postpartum Blues Syndrome, A Description and Related Variables. ArchGen Psychiatry 18:16, 27, 1968 Zelkowitz P., Mila Th, Postpartum Psychiatric Disorders, Their Relationship to Psychological Adjustment and Marital Satisfaction in the Spouses. J. Abnormal Psychol 105, 281-285, 1996 This page intentionally left blank. 8 Perinatal loss Irving G. Leon, Ph.D. G. Reef Following perinatal loss has been discovered relatively recently by the medical profession. 30 years ago perinatal death was considered a non-event by medical caregivers, born 1968, perhaps a disappointment, but certainly not a significant loss. Medical practice, accordingly, was oriented toward suppressing emotional reactions to the loss. Parental contact with the dead baby was virtually unthinkable. Tranquilizers were dispensed to dull parental, especially maternal, distress. Parents were advised to forget what had happened and women were advised to try to become pregnant again as soon as they physically recovered. Today, the standard of care by medical caregivers is exactly the opposite. Parents are now encouraged to see, touch, hold, name, and bury their stillborn or dead infant to make that child's life and death more real. Tranquilizers are avoided. Instead, parents are encouraged to grieve together. They are usually urged to wait until this loss has been sufficiently grieved before embarking on another pregnancy. Recent longitudinal, prospective studies indicate that at 6 months after pregnancy loss, women report significantly greater distress, anxiety, physical complaints, and especially depression than do their counterparts delivering healthy babies. These differences tend to wane by 1 year. Butel et al. 1995, Janssen et al. 1996, Neugebauer et al. 1997, Vance et al. 1995. This finding confirms the consensus held by most researchers and clinicians that over the course of the year following perinatal loss most women are able to resume pre-loss functioning, accompanied by a lingering, transient shadow grief. Peppers and Knapp 1980, often triggered by important anniversaries and reminders of the loss. However, about 25% of women experiencing pregnancy loss may be expected to have more serious and often enduring psychiatric difficulties following this loss. Ziana 1989. This chapter explores why Preg 141-142 Psychological Aspects of Women's Healthcare, 2nd edition Nancy and Newborn Demise is such a difficult loss to endure, identifies the many ways this loss affects family members, and suggests medical and psychiatric approaches that may deter the development of psychiatric difficulty and effectively address those problems when they arise. Epidemiology and etiology. Perinatal loss is typically defined as fetal demise beyond 20 weeks gestation through infant death 1 month postpartum and occurs in approximately 1.2% of all pregnancies in the United States, Cunningham et al. 1997. Although this rate is less than half the perinatal mortality rate in the United States in 1950, it is still significantly higher than other industrialized countries with wide differences among different groups in our country. There are half as many perinatal deaths in Japan than in the United States, and the perinatal mortality rate for blacks in America is almost twice that of whites, Hearst 1993. In short, we can do better. About 15%, 25% of all recognized pregnancies result in miscarriage. The actual rate of spontaneous abortions may be twice as high, because a subclinical early pregnancy loss is more likely to be viewed as a late period than a miscarriage, DeLuca and Leslie 1996. Ectopic pregnancies, increasing more than threefold between 1970 and 1986, now occur in almost 2% of all pregnancies, Stone 1995. It is beyond the scope of this chapter to review medical aspects of pregnancy loss, but a few basic points are worth noting. Although most miscarriages are caused by major genetic abnormalities in the embryo or fetus that are not likely to recur, perinatal loss is usually the result of maternal factors leading to preterm delivery of a non-viable fetus. Many maternal factors, such as cervical incompetence, hypertension, and diabetes, are now successfully treated. The increasing incidence of ectopic pregnancies is due to the higher incidence of pelvic inflammatory disease and complications resulting from the use of intrauterine devices and from surgeries leading to tubal damage. Stone 1995. Most of the psychologic investigation and the resulting changes in medical practice have focused on the relatively infrequent late-term perinatal loss, especially stillbirth. Furthermore, although with wider application of existing medical technology it is possible to reduce the rate of perinatal loss even further, the greater frequency of pregnancy among older women will increase their rate of miscarriages. Although there was a greater appreciation, and perinatal loss 143 study, of the impact of miscarriages through the 1990s, there continues to be virtually no investigation of the specific psychologic repercussions of ectopic pregnancy losses. This chapter more broadly considers miscarriages and ectopic pregnancies as well as perinatal death, noting the relevant differences among these losses. Related losses such as infertility, see Chapter 10, and pregnancy termination for fetal anomaly, see Chapter 3, will not be discussed in detail, although both are usually profound losses that complicate and magnify subsequent pregnancy losses. Because sudden infant death syndrome, SIDS, or crib death does not entail the unique aspects of a loss around pregnancy and also involves the death of an older infant, its repercussions are usually different and are not discussed here. Finally, elective abortion, when chosen without pressure from others during an unwanted pregnancy, usually does not result in the extended grief reaction of other pregnancy losses, Blumenthal 1991, Dag 1991, and therefore is not discussed. Historical and cross-cultural considerations. Historical review. Before the 1970s, the lack of awareness among medical and psychologic caregivers that perinatal loss generally evokes intense grief mirrored society's minimization or ignorance of this loss. As a logical outgrowth of their pioneering work on the development of parental attachment to the newborn, consolidated in bonding, Kennel et al., 1970, were among the first to recognize the pattern of grieving following the death of a baby. Mounting appreciation during the 1970s of the usually profound grief following perinatal loss culminated in the first major study of this death by Peppers and Knapp in 1980, Motherhood and Mourning, Perinatal Death, followed by more than a dozen handbooks over the next 15 years directed toward bereaved parents. In seeking to describe the normative pattern of grieving perinatal loss, clinical investigators during the 1970s demonstrated, ironically, how individualized the reactions to this loss were, thus providing richly textured and highly personal accounts. Grubb 1976, E. Lewis 1976. Throughout the 1980s, quantitative investigations reported that perinatal loss in the Western industrialized world was a major loss of a family member. See reviews by Leon 1990, 1992b and Ziana 1989 for more detail. However, methodologic flaws such as failing to develop measures specific to 144 psychological aspects of women's health care, second edition perinatal loss, or to track the course of this grief made it difficult to appreciate what is unique about this death at the inception of life as well as to identify early risk factors leading to later psychologic difficulties. Hospital practice, however, dramatically improved during the 1980s. This decade marked the increasingly routine use of protocols embedded in perinatal bereavement programs helping parents to grieve. Kellner et al., 1981, pioneered perhaps the earliest multidisciplinary, hospital-based perinatal mortality counseling program, integrating effective delivery of services with data collection for research. RTS Bereavement Services, formerly resolved through sharing, offered specialized training to hundreds of hospitals, especially obstetric nurses confronting perinatal losses in their patients, throughout the country. Limbo and Wheeler 1986. Finally, pastoral and lay caregivers, many of whom were dismayed by their own perinatal losses being ignored by medical professionals, played a crucial role in developing self-help groups and materials emphasizing the vital importance of social support and increasing recognition of this previously overlooked loss. Under the leadership of Sister Jane Marie Lamb 1986, for over a decade, SHARE, founded in 1977, provided a model for over 400 community-based self-help groups oriented to pregnancy loss throughout the world. ILSA's 1990 work, Empty Arms, is perhaps the brochure most frequently distributed to parents following a perinatal loss to help them normalize powerful reactions and encourage them to construct memories to facilitate grieving. During the late 1980s and early 1990s, more sophisticated self-report measures of perinatal loss were developed and increasingly used, thus helping to track longitudinally the course of perinatal bereavement as well as to understand better the different dimensions of this loss. Using their perinatal bereavement scale, therapeutic et al., 1989-1990, reported that recovery from pregnancy loss was often facilitated by a successful subsequent pregnancy. Using the perinatal grief scale, a 33-item questionnaire increasingly becoming the standard in the field, Toter et al., 1988, distinguished three distinct factors, i.e., active grieving, difficulty coping, and despair, that make up perinatal loss. They reported that it was not the intensity of initial grief but rather pre-pregnancy mental health that appeared to have the greatest impact on difficulties in coping and depression for couples 2 years post-loss, Lasker and Toter 1991. These important studies challenged some of the prevailing clinical wisdom and results of earlier, poorer research. For example, it had been believed, and recommended, that the bereaved couple should complete grieving before beginning the next pregnancy and that a more intense, early grief reaction predicted prolonged difficulties. Perinatal loss: 145 cross-cultural reactions to pregnancy loss. Because societal beliefs in part structure the boundaries of life and death in which perinatal loss is experienced, cultural attribution is a crucial ingredient in understanding the impact of pregnancy losses. Aside from a few general, Lawson 1990, Lane 1990, and anecdotal, T.H. Lewis 1975, Mammon 1995, accounts, culture has been largely ignored. Although quantitative studies have usually found socio-demographic variables to be poor predictors of psychologic and behavioral responses to perinatal loss, Kellner et al. 1984, Lasker and Toter 1991, Nicole et al. 1986, qualitative examination of how different subgroups within our culture respond to perinatal loss continues to be lacking. A recent volume edited by Cecil, 1996a, The Anthropology of Pregnancy Loss, begins to correct the omission of cross-cultural investigation by providing ethnographic descriptions of pregnancy loss in rural India, Jamaica, New Guinea, Tanzania, and Cameroon, as well as historical accounts of pregnancy loss in 18th century England and early 20th century Ireland. The experience of pregnancy and its demise becomes part of the very fabric of a culture's beliefs and identity. In particular, pregnancy loss is commonly attributed to the woman being estranged from her spiritual and social world. Whether viewed as a target of evil spirits in India, Jeffrey and Jeffrey 1996, and Cameroon, Savage 1996, or as a victim of sorcery in Jamaica, Sobo 1996, and New Guinea, Winkvist 1996, the woman is still commonly viewed as ultimately responsible for reproductive outcome. In many of these cultures, pregnancy loss is considered a punishment for actual misdeeds, Wembarashid 1996, for negative emotions such as anger, envy, or jealousy, Savage 1996, or for breaking societal taboos, Winkvist 1996. Physical explanations coexist with social/spiritual perspectives, allowing for the possibility of less condemning and more sympathetic responses, Chalmers 1996, Wembarashid 1996, Winkvist 1996. Notably absent in virtually all of these cultural accounts is the grief reaction now almost ubiquitously reported in Western studies. Because many of these unborn children were regarded as not fully human, Savage 1996, Wembarashid 1996, Winkvist 1996, or as the product of some transgression, mourning was often actively discouraged. Pregnancy loss simply did not signify the death of a valued, potential member of society. Importantly, many of these cultures believe pregnancy begins during the second trimester, often at quickening. Jeffrey and Jeffrey 1996, Sobo 1996, Wembarashid 1996, thereby making the most common pregnancy loss, early miscarriage, a true non-event. 146 Psychological Aspects of Women's Healthcare, second edition. Depending on the societal definition of pregnancy and the causal explanations for these losses, grieving is not an inevitable or even appropriate response for all or most members of a community. We also need to respect the non-medical, seemingly irrational ideas of many women who experience these losses. Many Western women describe feelings of being punished for misdeeds, "What did I do to deserve this?" or attribution of pseudo-medical explanations, example eating certain foods, having intercourse during pregnancy, exercising, suggesting that we in the West share a need with non-Western cultures to create more social, personal, and spiritual understandings of these losses beyond what science can tell us. Indeed, not only medically sound explanations, Dunn et al. 1991, but even inaccurate, self-blaming beliefs may provide some reason for these losses, some sense of control and efficacy against their recurrence. Affleck et al. 1985, Tenen et al. 1986. Although data are limited, it may be surmised that grief reactions to pregnancy loss were significantly less intense and common in the early 20th century in the West. Several investigators have suggested that the more common occurrence of perinatal and infant loss in undeveloped countries today, Shepard Hughes 1991, and in the West many years ago, Cecil 1996c, may have led to the view that such a loss was just one of those things. Cecil 1996c, p. 190, an almost expected disappointment but not a tragedy. Again, when infant mortality was high, babies were often not recognized as fully human and not worthy of much grief. The development of maternal attachment during pregnancy may have only gradually become a cultural norm, consolidating as the odds for survival increased. Cecil 1996b, Shepard Hughes 1991. Today, a woman who becomes pregnant again after a perinatal loss may take a task-oriented, unenthusiastic approach to the pregnancy, thus avoiding the usual attachment to the unborn child until a healthy baby is born. Phipps 1985. Finally, historical accounts indicate that not much more than a century ago in the United States, children were still viewed as economic assets rather than as solely objects of love and caregiving. Mason 1994, Zelizer 1985. The medical discovery of perinatal grief in the past quarter century perhaps naturally followed how increasingly normative that grief became in the preceding 50 years. Impact of perinatal loss on the mother. There are many aspects to the psychologic repercussions of pregnancy loss. The unique nature of this loss is critically important and often missed by studies that compare or evaluate this loss with other family losses, such as death. Perinatal loss 147 of a spouse or older child. The following areas can be used as a clinical guide for assessing maternal responses and risk factors. This discussion includes clinical issues faced by mental health workers, whether as part of a multidisciplinary team in the hospital at the time of loss, Kellner et al. 1981, or as a therapist working with the clients sometime after the loss. Mourning the death of a baby by the last trimester of pregnancy. Both of the expectant parents, but especially the mother, develop an intense attachment to their unborn child as a unique, separate person. Condon 1985, Lumley 1982, Stainton 1990. Parental images of the unborn child are so powerfully consolidated by this time that a statistically significant degree of continuity exists in parental perception of the baby's temperament, example activity, rhythmicity, adaptability, mood, in utero and postpartum. Ziana et al. 1985. Based on this attachment, Parents grieve the death of their unborn child, already a beloved family member before birth. The usual pattern of grieving has been recognized for over 50 years, Lindemann 1944. After the initial shock and numbness on learning of the death, especially if it was unexpected, a period of intense confusion usually follows, with lapses in memory, anxiety, restlessness, irritability, and somatic distress. As the reality of the death gradually sinks in, the bereaved parents yearn for the return of the deceased. Inconsolable sadness, preoccupation with memories of the deceased, and intensely painful periods of loneliness, guilt, anger, and hopelessness wash over the bereaved. Over the next year, the parents gradually become reconciled to this permanent loss, everyday activities are resumed, vigor in other relationships and the world in general is renewed, and capacity to feel pleasure is restored. It usually takes more work to make perinatal loss feel real. Because so much of the image of the unborn child is imbued with fantasies during pregnancy, Deutsch 1945, Pines 1972, it comes as no surprise that couples after perinatal loss often struggle with whether a pregnancy actually occurred, Helmrath and Steinitz 1978, Lovell 1983. The raw material of memories fueling the grieving process is scarce or absent following perinatal loss. For this reason, virtually all researchers and clinicians working in this area recommend giving parents as many opportunities as possible to get to know their baby, seeing and holding their child, and going home with mementos and pictures testifying to their baby's existence. Much of perinatal loss involves grieving the loss of the future, relinquishing the wishes, hopes, and fantasies. 148 Psychological Aspects of Women's Health Care, 2nd edition, about one who could have been. It may be accurate to say that most grieving involves retrospective mourning, i.e., detaching oneself from the relationship that once was, whereas perinatal loss demands prospective mourning, i.e., detaching oneself from the relationship that was to be, Leon 1990. Recent studies of bereavement in general, Class ETAL 1996, and of the death of a child, Knapp 1986, Rubin 1985, or that of a child's parent, Alchel 1988, Harris 1995, in particular suggest that it is normal for an intermittent, usually attenuated, grief to recur throughout one's life following major losses. This may occur after perinatal loss, when the lost child-to-be would have reached the age at which cherished wishes for him or her would have occurred. A critical determinant of the magnitude and quality of grief following perinatal loss is how much and in what way the child was wanted and loved. The common research finding of more profound grief following a later-term pregnancy loss, CUISE near ETAL 1993, Goldbach ETAL 1991, Janssen ETAL 1997, Kirkley Best and Kellner 1982, Theod ETAL 1989, Toter ETAL 1988, is logical based on the deepening attachment usually formed toward the child-to-be as the pregnancy progresses. Similarly, the generally muted, limited, or even absent grief following uncooked decisions to surrender unwanted pregnancies or children, such as by elective abortion, Blumenthal 1991, Dag 1991, relinquishing a child for adoption, Cushman ETAL 1993, McLaughlin ETAL 1988, or surrogacy, Fisher and Gilman 1991, Hanifin 1987, Schmolker and Egan 1989, provides powerful testimony that the woman's attachment to her baby is a variable, psychologic process rather than a biological, instinctive inevitability. These same losses usually provoke much more intense grief when the babies are in fact wanted, such as when the pregnancy is terminated because of fetal anomaly, Leon 1995, Ziana ETAL 1993, or when the loss is an essentially involuntary decision, example studies of extended birth mother grief when adoption was only feasible choice available, prior to the legal availability of abortions or societal acceptability of unmarried parenthood, Dickon ETAL 1984, Rynerson 1982. To understand grief following pregnancy loss, clinicians should remember that along with the commonly felt loss of a very real baby may be the just as powerful evocation of a prior loss. Images of the child-to-be are a conglomeration of current and earlier object ties, Bibring 1959, a kind of projective screen of salient relationships among which incompletely mourned people may figure quite prominently. Not infrequently, an intractable, more chronic grief following perinatal loss may involve the unconscious resurfacing of an earlier loss, especially the death of a parent while the woman was still in childhood, Leon 1987, 1990. Perinatal loss. 149 clinicians must recognize that grieving is a highly individual and variable process, Parks 1985, Zizek and Duvall 1985, not one that can be readily put on a schedule or compartmentalized into stages. Studies of grief in general, Wordman and Silver 1989, and perinatal loss in particular, Lin and Lasker 1996, indicate that most people do not, in fact, follow the stepwise pattern and diminution of grief so frequently assumed. Repairing narcissistic losses. Reproduction fulfills many cherished wishes and ambitions that have little to do with parenting a child and everything to do with enhancing self-esteem. Pregnancy promotes self-worth and enriches feminine identity by fostering a sense of omnipotence, both in the act of creation and in becoming a parent, who is imbued with so much power in the mind of the young child, affirming gender identity through reproduction, and diffusing death anxiety by ensuring a biologic continuity in projecting oneself into the next generation, Leon 1990, 1992b. Pregnancy loss, therefore, causes multiple blows to self-worth and self-image. The growing intimation of omnipotence is shattered by this loss. The woman is unable to experience even the usual sense of control over her body. She faces the harsh finality of death when she least expects it, in the very act of creating life. Her own mortality is awakened, as she sometimes fears she will die as well. Pride in her femininity is transformed into shame and humiliation. Ultimately, she feels she has failed. Many of the usual reactions to pregnancy loss: persisting worthlessness, intense guilt, rage at the unfairness of it all, feelings of emptiness and fragmentation, and psychosomatic symptoms, Furman 1978, Kohut 1971, Lasker and Toter 1991, Peppers and Knapp 1980, may be better understood as resulting from the profound deprivation of normal narcissistic motives of pregnancy rather than the usual pattern of grieving the death of one's baby, i.e., object loss, Leon 1990, 1992b. Such profound narcissistic damage helps explain why many women experience a significant improvement in well-being when they are able to achieve a successful pregnancy following pregnancy loss, Hunfeld et al. 1997, Murray and Callan 1988, Theod et al. 1990. This enables them not only to parent but to repair a damaged self. Narcissistic rage directed at medical caregivers may originate in the intense disappointment and hurt of the loss but is invariably compounded when caregivers are unable to appreciate the magnitude of this loss. Empathic communication that enables the woman to feel understood is vital in reducing 150 psychological aspects of women's health care, 2nd edition. Narcissistic damage and healing self-esteem, Leon 1990. Quantitative studies indicate that after pregnancy loss, parents express significantly higher self-esteem when they were satisfied with the support they received from hospital caregivers, Murray and Callan 1988. The degree of parent satisfaction with care was directly related to the attentiveness and sensitivity of healthcare professionals rather than the total number of interventions they received, Lasker and Toter 1994, Raidstad et al. 1996b. In the words of Furman, 1978, for the professional person to tell the parents just to bear it is not enough, to be with them and to extend oneself in bearing it can do much more, p. 216. Women who suffer miscarriage or ectopic pregnancy may experience additional narcissistic damage because of its occurrence in the early part of pregnancy when there is usually much less separation between fetus and self, and also because of the bodily damage to the fallopian tubes often accompanying ectopics. Furthermore, because most psychologic interventions are designed to grieve the loss of a baby, these early losses are often minimized, neglected, or ignored, resulting in patients reporting greater dissatisfaction in their care than those suffering later perinatal losses. CUISC near ETAL 1993, Lasker and Toter 1994, Raidstad ETAL 1996a. Surmounting developmental interference. Pregnancy ushers in a new stage of development. Parenthood, Leifer 1977, Sheckman 1980, that profoundly changes self-perception, perception of the meaning and purpose of life, and the value of family and relationships. As with any other developmental advance, turmoil in one's inner world is heightened, often leading to confusion, anxiety, and insecurity. This process of inner disorganization facilitates reintegration and further development of the personality, optimally increasing adaptation. Benedict 1959, Bibring 1959. Pregnancy loss is a crisis within a crisis. Instead of progression to the next developmental stage, developmental interference occurs. Studies demonstrate that having had children previously reduces the depressive consequences of pregnancy loss. Graham et al. 1987, Janssen et al. 1997, Neugebauer et al. 1992b, 1997, Toter et al. 1988. Women who have lost a pregnancy often talk of not getting on with their life goals, plans, and dreams. They feel stuck, off track, as if running in place. Interpersonal isolation compounds the sense of internal stagnation. The woman may feel profoundly estranged and lonely, cut off from family and perinatal loss. 151 friends who are moving on with their lives and having families of their own. Soon after a pregnancy loss, it is often too painful to go to places frequented by young families. Many of the usual responses to perinatal loss, such as visualizing or hearing a baby, wishing to have another baby as soon as possible, and feeling intense pain and envy when exposed to other babies, may come from the frustration of not being able to parent. Pregnancy losses near the beginning and end of a woman's reproductive life may also complicate developmental issues. For the teenager, pregnancy may be less a wish to parent than to feel like an adult or, regressively, seek to feel loved by, i.e., be taken care of by, a baby. Mischny 1986, Rosenthal 1993. When such a pregnancy is lost, the young woman must contend with the thwarted needs both to grow up and to satisfy early childhood longings, often quickly prompting another pregnancy. For women who have delayed parenthood into their 30s or later, the perceived danger of never becoming a biologic parent looms over this loss. Reviving Psychologic conflicts. In their extensive review of the perinatal loss literature, Bourne and Lewis, 1992, note a relative absence of psychoanalytic work in the area of revived psychologic conflicts. This absence may be the result of an unspoken allegiance to some traditional but now outdated psychoanalytic belief that unconscious psychologic conflicts cause perinatal loss. Leon 1996b. Earlier conflicts and relationship paradigms may be activated by and interwoven with a perinatal loss. Clinical accounts, Condon 1986, Leon 1987, 1990, 1996a, and quantitative studies, Hunfeld et al. 1997, Lasker and Toter 1991, Toter et al. 1988, indicate that earlier psychologic problems, especially prior depression, Butel et al. 1995, Janssen et al. 1997, Neugebauer et al. 1997, can interfere with the successful resolution of perinatal loss. Although complicated grief following perinatal loss can often be treated with short-term psychotherapy, Leon 1987, 1990, 1996a, serious, ongoing character problems may require more extended therapy to prevent further regression and to address aspects of grief, especially rage and guilt, intensified by the personality disorder. Mastering exacerbating circumstances of the loss. The circumstances and causes of a loss typically are crucial factors influencing the course and outcome of bereavement. Bowlby 1980, Raphael 1983. 152 Psychological Aspects of Women's Healthcare, 2nd edition Clinical, Parks 1980, Fulkin 1970, and Quantitative, London 1984, Pridgerson et al. 1997, studies indicate that a sudden, unexpected loss trauma complicating grief significantly interferes with adaptive resolution of grief, often resulting in higher psychiatric and physical morbidity. The ability to gradually digest and process a major loss before the actual death, anticipatory mourning, usually facilitates grief resolution, clearly documented in the significantly greater likelihood of parents to adaptively mourn the loss of an older child from a terminal illness as opposed to a sudden death. Knapp 1986, Leon 1990, Rando 1983. Pregnancy loss is typically an unexpected death, often resulting in some traumatic aftermath. Flashbacks of the hospital experience, intense anxiety on returning to the hospital, and initial numbness soon after the loss are all telltale signs that the trauma needs to be processed before and while the death is grieved. Other circumstances complicating the loss also need to be considered. Loss of a baby who survived some time after birth, thus leading to increased maternal attachment, often results in more extended grief. Medical threats to the mother's life concurrent with pregnancy loss, such as ectopic pregnancy and preeclampsia/eclampsia, may provoke an additional degree of trauma. When mothers engage in behavior contributing to fetal death, example substance abuse, or demonstrably substandard medical care is provided, the intensity of guilt or rage may complicate coping with the loss. Skillful clinical acumen and tact will be necessary to determine and communicate how much the understandable preoccupation with this aspect of the loss is an adaptive catharsis of trauma or a barrier to dealing with other critical issues, example grieving the baby's death. Only by encouraging a detailed telling of the story will it be possible to assess the degree of trauma as well as to begin to resolve that trauma. Other important factors: infertility compounding perinatal loss, clinical experience, Leon 1990, 1996a, indicates that infertility profoundly complicates pregnancy loss. Infertility usually heightens the developmental interference with realizing parenthood. The grief over a pregnancy loss following infertility may be exacerbated by how precious and long overdue this pregnancy has been, a psychic gestation measured often in years rather than months. Infertility may interfere with grief resolution by denying the opportunity for closure and reparation during the subsequent pregnancy and birth. Perinatal loss 153 of a healthy child, Kirkley Best and Kellner 1982, Peppers and Knapp 1980, Theod et al. 1989. The stigma associated with infertility, Greel 1991, Menning 1988, and the ensuing feelings of shame, failure, and worthlessness create additional obstacles to obtaining psychologic help, Leon 1990, 1996a, thus demanding clinical sensitivity in normalizing the psychologic repercussions. That some members of the psychiatric, especially psychoanalytic, community continue to believe that unconscious conflicts cause perinatal loss, example Pines 1990, and infertility, example Bidlowski and Diane Linzer 1988, provides a haunting reminder of how much women, in one way or another, are held responsible for reproductive outcome in our culture, and many others, and how much psychiatric thinking has served that social ideology. Social support mediating aftermath. Perhaps more than any other single variable, the availability or absence of social support may influence both the process and outcome of pregnancy loss. When couples are able to mutually understand and support each other, Forrest et al. 1982, Jansen et al. 1997, LaRoche et al. 1984, Nicole et al. 1986, Toter et al. 1988, Tude Hope et al. 1986, and medical caregivers are felt to be sensitively responsive to the loss, Harmon et al. 1984, Murray and Callan 1988, Smith and Borgers 1988, grief is reportedly more tolerable and the outcome more benign. Social support essentially means providing empathy, engendering a feeling of being understood, appreciated, and respected. One's pain is taken seriously and compassionately. It is defined less by what is said and how many things are done than by how these things are said and done. Furman 1978, Leon 1992a, Swanson-Kaufman 1986. Job stress or relief. Often overlooked factors influencing the aftermath of pregnancy loss are the demands and satisfactions of work. Most women will still be grieving on returning to work. A fulfilling job can be extremely therapeutic in reducing narcissistic injury by promoting a feeling of competence again and by offering a welcome distraction from the continuous pain of grief. Other aspects of the work environment may make grieving more difficult or even intolerable. Total indifference by co-workers may be especially disorienting and painful. Some corporate or professional work climates may not tolerate even a muted grief. For healthcare workers, a macho medical ethos may permit compassion for one's patients while expecting immediate recovery for oneself. Medical, especially obstetric, caregivers need to be reminded that returning to a 154 psychological aspects of women's healthcare, second edition jobs so closely related to their loss may require that re-entry be gradual and that their anxiety, sadness, and numbing while on the job is valid and normal. Putting religious faith to the test. Almost universally, the meanings and causality of pregnancy loss are sought beyond the answers of science. Not how, but why did this happen to me? Religious beliefs may ease or intensify distress. Believing in the child's continued existence in heaven and an eventual reunion there following one's own death may be comforting and may relieve some of the pain of separation. Even if one does not claim to know God's purpose, believing that a God or gods exists, in whatever form one's religion describes, and that such a death is not without meaning can be reassuring. For others, religious beliefs become a source of increased guilt, a feeling of being punished. For those whose belief in God is based on a sense of fairness and justice, this loss may severely challenge their faith, leading to a bitter or cynical retreat from God or an eventual modification and reaffirmation of that faith. Clerical counselors may be most prepared to discuss religious matters, but all clinicians should inquire about and be ready to address these concerns. One need not, maybe cannot, have the answers in order to be enormously helpful by facilitating the processes of searching, questioning, challenging, abandoning, changing, and finding religious faith. Family reactions. Mothers and fathers, grieving apart and together. Although fathers clearly grieve for their unborn, stillborn, and newborn children who die, their grief tends to be significantly less intense and shorter than that of their mates. Benfield et al. 1978, Helmrath and Steinitz 1978, Smith and Borgers 1988, Theod et al. 1989, Vance et al. 1991, 1995, Ziana et al. 1995. Peppers and Knapp, 1980, attributed this pattern of incongruent grieving to the significantly earlier and more intense attachment by the expectant mother to the unborn child within her body compared with that of the prospective father. Although attempting to be supportive, husbands often betray impatience and irritation over their wives' seemingly endless grieving. Husbands fear their wives will never get over it, and often want to get back to normal before their wives are ready. Perinatal loss 155. The texture of grief often differs between mothers and fathers. Because the child-to-be is more a part of the woman's physical and psychologic self and felt to be more under her control, maternal guilt and diminished self-esteem tend to be more important ingredients of grief among women than among men. Leon 1990. For a man, relief over his wife's physical recovery may also eclipse grief over what has been lost. Cultural gender roles that discourage masculine expression of intense feelings in general and of sadness in particular often magnify the different expressions of perinatal loss by fathers and mothers. Gilbert and Smart 1992. Men believe that they should be strong. Social norms reinforce these role expectations. Husbands are often asked how their wives are doing, with little concern about how they themselves are faring. They may feel ashamed and fear losing control of their intense emotions. They may grieve alone, crying in the car on the way to work, or their frustration and disappointment may be channeled into a more acceptably masculine emotion, anger. Men are often assigned and assume the responsibility of taking care of their wives and managing concrete tasks, such as funeral arrangements, thus reinforcing the masculine preference to act rather than to feel. The sense of helplessness may propel them to work overtime to combat depressed feelings, to avoid being with a depressed wife, and to find some sense of accomplishment on the job. They may seek out distractions in sports or, more problematically, retreat into substance abuse. A husband may feel it is his duty to cheer his wife up rather than share his grief with her, increasing his wife's isolation and estrangement from him. Although his wife may crave physical affection and cuddling in order to feel loved, he is more likely to press for sexual intercourse as a way of feeling close to her, leading each to feel disappointed by the other. These are general patterns. Some men experience a deeper loss of their child than do their wives following pregnancy loss. Notwithstanding these normative differences, most couples successfully weather the storm, eventually reporting increased closeness and a stronger marital bond. Gilbert and Smart 1992, Harmon et al. 1984, Helmrath and Steinitz 1978, Peppers and Knapp 1980. No evidence of increased incidence of divorce following perinatal loss has been found. Couples work can be an especially timely and appropriate intervention after pregnancy loss. It may provide a bridge to appreciate and empathize with the partner's experience modeled by the clinician when appropriate, that is enriched by exploration of salient individual issues. 156 Psychological Aspects of Women's Healthcare, 2nd edition. Effects on Siblings. The invisible loss. Perinatal sibling loss has been called the invisible loss because the dead baby usually is not seen, little is heard about the loss, and often the siblings' many questions, confusions, and feelings go unacknowledged. Leon 1986b. This has significantly improved over the past 15 years. Siblings are increasingly allowed or encouraged to see the baby as they participate in opportunities for the whole family to grieve. However, the professional blind spot in this area continues, with virtually no quantitative research on the impact of perinatal loss on siblings and the most effective ways of helping them cope with this loss. As early as age 2 or 3 years, a child can begin to grasp the essential concept of death as the permanent cessation of all functioning. Bowlby 1980, Furman 1974. Preschoolers, however, dramatically distort causality. Magical thinking and egocentrism dominate their interpretation of events. Thus, a child's jealousy toward the new baby during pregnancy may, after perinatal loss, become a conviction that he or she caused the death. At the same time, sibling rivalry should not be the only lens through which perinatal sibling loss is viewed. If permitted, young children, especially beyond toddlerhood, often powerfully and poignantly grieve their sibling's death. Ultimately, the child's developmental level, individual dynamics, including reactions to this pregnancy, and family style of grieving will decisively influence the child's reactions to this loss. Clinicians can play a valuable role in helping parents understand and cope with their children's reactions to perinatal loss. The range of normal reactions should be reviewed with parents. Anxiety is common. Will someone else die too? Depressed feelings may be based on many factors, including guilt, was I to blame, lowered self-worth due to neglect, nobody pays attention to me anymore, and grief over the loss. These feelings may take the form of tired, bored, or angry behavior or of somatic complaints. It is normal for children to become preoccupied with death for a while, staging mock funerals or asking many questions about what happens to the body. A child's reluctance to show any interest may be based on the family's overt or unspoken rules about avoiding that topic. Children may also respond nurturantly toward their parents' grief. What can I do to make the pain go away, Mommy? Perinatal sibling loss may foster a child's empathy. Attending the funeral usually helps even young children by making the death concrete and providing social support. The child needs to be prepared for what he will see and hear and have a trusted adult nearby to answer any perinatal loss 157 questions that arise. It is crucial that parents explain what happened and how the baby died in clear, simple, concrete terms using words the child can understand. This should be done when pregnancy loss occurs early, example miscarriage or ectopic, as well as late, Parents often deny a child's knowledge about the pregnancy or believe such a discussion creates an unnecessary burden, overlooking how the sometimes devastating impact of miscarriage, Butel et al. 1995, Hearst 1984, Neugebauer et al. 1992a, 1997, will be more confusing and troubling to children if not put into some understandable context. Drawing pictures can be a useful aid. Having the child repeat the explanation in his or her own words may tell the parent what has been understood or confused. It may be necessary to clarify for a younger child that the death was not caused by anything he or she felt or did but rather by a baby disease that cannot happen to anyone older in the family. Children may also need to hear that the parent's sadness over the death of the baby does not mean that they love their living children any less, although it may be hard for them to be as attentive when they are so sad. It helps parents to talk about the death, sad as they may be, and helps them feel better about themselves as parents when they are able to help their children cope with the loss and answer any questions. A mental health consultation with a clinician familiar with childhood grief may be warranted when sibling distress becomes chronic. As with adult responses, unresolved perinatal sibling loss is often associated with earlier problems predating the loss. Clinical studies, Leon 1986a, 1986b, 1990, strongly suggest that children's disturbed reactions to perinatal sibling loss were strongly linked to a failure by parents to provide accurate and clear information about the loss and to support their child's feelings, to parental unresolved grief usually leading to an extended disruption in parenting, or to parents engaging the child in destructive patterns of family interaction, including scapegoating, extreme overprotectiveness, or using a subsequent child as a replacement for the dead baby. Caregiver and community responses. How caregivers respond. Early work exploring the reactions of caregivers to perinatal loss focused on their tendency to resort to psychologic defenses to protect themselves against the intense feelings aroused by these losses. Born 1968, Klaus and Janelle 1982, Peppers and Knapp 1980, Stack 1982. This temporary relief of their 158 psychological aspects of women's health care, second edition own distress was bought, however, at the high price of failing to engage with their bereaved patients as well as blocking more effective coping. Among obstetricians, widespread knowledge of parental grief following perinatal loss, Kirkley Best et al. 1985, has enabled them to be more helpful to their patients. Medical training that dictates that it is unprofessional to have strong feelings because of the danger of becoming emotionally involved with one's patients must be challenged. Such thinking is bad for patients and caregivers. It is natural for medical caregivers who have participated in a pregnancy to feel loss, sometimes profound, at its demise. It is just as natural for caregivers to feel sad when they are with people who are grieving, helping them feel they are not alone and that their pain is shared by others. Bereaved parents need to see that their caregivers care. Medical caregivers frequently feel guilty, inadequate, and helpless after a pregnancy loss, even when they know they did nothing wrong. They may fail to recognize the enormous importance of their emotional response to their vulnerable patients. What medical caregivers say and do at the critical time of this loss is not forgotten. Heartfelt, comforting words or touches can become lifelong sustaining memories that promote healing, just as seeming indifference can leave painful scars, irreparably damaging the patient-doctor relationship. Overwhelming helplessness in the wake of pregnancy loss may cause trauma among medical caregivers, unforgettable memories returning as flashbacks or dissociative detachment masking as indifference. The cumulative strains on caregivers who regularly deal with these losses can be debilitating. Measures for resolving the occupational grief and trauma that affect medical caregivers need to be devised at individual, group, and institutional levels. Gilliland and James 1993. How friends and extended family react. Until recently, there was little communal recognition of and compassion for perinatal loss. Talk about the baby was often replaced with a deafening silence that seemed to say, contrary to parents' grief, that nothing had happened and no one had died. Helmrath and Steinitz 1978, Peppers and Knapp 1980. Well-meaning advice intended to comfort and distract the bereaved was more likely to impede grieving by encouraging suppression. Just try not to think about it and you'll feel better, reinforcing maternal guilt, it was meant to be, and denying the loss, you can always have another child. Perinatal loss 159. Many people still recoil from the tragedy of pregnancy loss. Fearing they will say the wrong thing, they will often say nothing. It is also common to expect bereaved parents to return to normal and become their old selves within weeks or a few months at most. It may be especially difficult for grandparents to tolerate their children's grieving. Grandparents often avoid talking about the baby for fear they will upset their children, which in turn leads bereaved parents to feel more isolated and misunderstood. Although adult siblings can be an important source of support, if siblings are pregnant or have young children, envy felt by the bereaved parents may be intolerable, increasing estrangement from extended family. The most beneficial source of community support and understanding for perinatal loss has been self-help groups in which bereaved parents reaffirm for one another the normalcy of grieving by providing a place where those feelings may be freely expressed. Klaus and Janelle 1982, Peppers and Knapp 1980, Wilson and Soul 1981. For those whose grief has abated, these groups may provide a valuable channel for supporting others, transforming self-preoccupation into altruism. Videka Sherman 1982. However, only a small percentage of the bereaved ever attend a self-help group. This resource is rarely used by minorities or the most socially isolated. Recommending a support group should never substitute for a caregiver's listening and responding to perinatal grief. Psychologic Management of Pregnancy Loss Hospital Practice. Klaus and Janelle, 1982, provided the basic model of preventive intervention following perinatal loss. Doctors empathically but honestly keep parents fully informed of the baby's condition when problems emerge. Immediately after the death, the doctor meets with parents to give the tragic news, offer comfort and support, and answer any medical questions they may have. Parents are encouraged to validate their loss by having contact with their baby as well as taking home pictures and mementos of the baby, example footprints, baby bracelet, receiving blanket, and lock of hair. Dulling grief with sedation is avoided. Instead, the normalcy of the intense grief that can be anticipated, including rage, irrational guilt, and somatic symptoms, is explained. Because the parents are often in a state of shock at the time of death, a second meeting is 160 Psychological Aspects of Women's Healthcare, second edition scheduled for a few days later to discuss many of the same concerns, continuing to provide support and empathy for their feelings. The importance of sharing their grief is emphasized, as is the fact that no one is to blame. Parents are usually encouraged not to attempt another pregnancy until they have grieved this loss, at least 6 months. At 3 to 6 months after the loss, a third meeting is scheduled to review the autopsy findings, address any new issues, and determine whether additional follow-up meetings or mental health referral is needed. With minor variations, this basic approach has become the standard of care for all pregnancy losses, including outpatient obstetric practice, Leppert and Paca 1984. Many hospitals have created their own multidisciplinary grief support teams, Brown 1992, Kellner et al. 1981, Lake et al. 1983. An alternative approach is training all obstetric caregivers, often with the aid of protocols in the hospital management of perinatal loss, Carr and Knupp 1985, Hutty 1988. A danger exists that sole reliance on grief specialists, let them do it, will devalue the importance of all medical caregivers developing skills in responding to these losses. However caregiving is delivered, it needs to be individualized. Leon 1992a. Too great a reliance on specific instructions will deplete the genuine interaction with bereaved parents that is the essence of good care. As important as contact with the dead baby is for most parents in order to make the loss real and to help them grieve their loss, such contact is not equivalent to mourning. Quantitative studies have not yet conclusively demonstrated that such contact facilitates grieving or is indispensable. Caregivers need to guard against exercising undue pressure on parents to view their baby. Caregivers will never go wrong when they allow themselves to empathize with their patients. By listening carefully, caregivers may be able to sense to what extent the loss is experienced as the death of a child, a profound blow to self-worth, the revival of an earlier loss or trauma, or an obstacle to becoming a parent. Finally, because these losses so often leave parents traumatized in the wake of feeling profoundly helpless, empowering them by offering options rather than dictating care is usually therapeutic. For example, instructing parents to wait at least 6 months before attempting another pregnancy is less effective than discussing the pros and cons about timing future pregnancies, allowing the parents to decide what is best for them. Davis et al. 1989. Although models of follow-up care are available, Eoton 1993, Ilse and Fur 1988, McGuire and Skolikis 1988, insufficient follow-up after the family leaves the hospital is a serious deficiency in the management of pregnancy loss. In addition to facilitating continued grieving, follow-up care may perinatal loss 161 provide the needed support for the next emotionally difficult pregnancy, fraught with anniversary revivals of anxiety and grief, Bourne and Lewis 1984, Phipps 1985. Research has repeatedly emphasized both the value of follow-up contact and how often it is overlooked. A single 15 to 40-minute phone call within 10 days of a neonatal death significantly reduced loneliness, depression, and guilt 2 to 6 months post-loss, Schreiner et al. 1979. Even research interviews at 6 weeks and 6 months after a miscarriage appeared to have unintended therapeutic effects, Neugebauer et al. 1992b. Other investigations, Kleiman et al. 1979, Hellstrom and Victor 1987, Kellner et al. 1984, have indicated that up to 75% of parents who experienced a pregnancy loss wanted to discuss the details of the death or come in for a follow-up appointment 2 to 4 months after the loss. A recent National Maternal Health Survey reported that over 50% of the sample experiencing perinatal loss wanted more information, Covington and Theot 1993. Mental health considerations. Mental health professionals play a crucial role in the continuum of caregiving for pregnancy loss. They can make diagnostic differentiations, such as distinguishing intense, immediate grief reactions from frankly psychotic episodes or appreciating the impact of earlier characterologic disturbance, such as borderline personality. They may serve valuable educational and supervisory roles. Accustomed to equating care with overt procedures, medical caregivers often need to learn that empathic listening and responding to a parent's intense grief is not doing nothing, but is in fact beneficial. Outside the hospital as therapists, mental health professionals may mitigate the potentially destructive and chronic consequences of unresolved grief. Thanatologists typically distinguish more or less normal grief from the range of pathologic or complicated grief reactions, including chronic, delayed, inhibited, or distorted mourning. Bowlby 1980, Horowitz et al. 1997, Jacobs 1993, Worden 1982. Treatment recommendations are similarly divided between supportive counseling oriented toward facilitating resolution of normal grief and interpretive psychotherapy directed toward diffusing pathologic reactions. Worden 1982. Although distinguishing self-remitting grief reactions from disturbed responses requiring psychologic intervention certainly has both heuristic and practical value, my clinical experience suggests these distinctions are best viewed as two poles on a continuum. That is, many if not most bereavements possess aspects of normal and disturbed grief. Treatments, similarly, blend as 162 psychological aspects of women's health care, second edition PECs of counseling and psychotherapy. Many responses viewed as symptomatic of distorted grief, example furious hostility, depersonalization, loss of patterns of social interaction, and agitated depression, Lindemann 1944, are not unusual reactions in the months following perinatal loss. It has been notoriously difficult to predict accurately the individuals at risk for later psychologic problems. Kellner et al. 1984, Laroche et al. 1984, Leon 1990, Ziana 1989. Too many quantitative studies continue to view marked distress and depressive symptoms in the weeks and first months following pregnancy loss as psychiatric disturbance, example Friedman and Gath 1989, Neugebauer et al. 1997, rather than intense grief. Patterns of grieving in general, Class et al. 1996, Wordman and Silver 1989, and perinatal loss in particular, Brown 1993, Lin and Lasker 1996, do not fit the dichotomy of normal versus pathologic grieving. Those labeled as having uncomplicated grief may be discouraged from seeking the help they could use, whereas those burdened with the idea of being sick may be too frightened to obtain the help they need. Many women who seek psychotherapy after perinatal loss describe significant unresolved childhood loss, disappointment, or emotional deprivation, especially with their own mothers, that has indirectly been awakened by this loss. Leon 1990. During the year following pregnancy loss, psychologic help may prevent the development of further disturbance by facilitating grief and addressing maladaptive reactions based on prior emotional difficulties and/or inadequate social support, especially between the partners. Two of the factors most convincingly associated with later emotional problems in quantitative studies, Lasker and Toter 1991, Ziana 1989. Substance abuse, the development of severe psychosomatic problems, suicidal behavior, or serious intent, not solely the thoughts or wishes of dying that are common, require immediate attention. When grief, depression, impaired job performance and interpersonal functioning, or any other emotional or behavioral difficulties do not begin to subside over the second half of the first year, treatment may be indicated. In subsequent years, psychotherapy may effectively address emotional difficulties based on earlier unresolved pregnancy loss that have become entwined with a prior unresolved loss or other latent conflicts and/or deficits. Condon 1986, Leon 1987, 1990, Turco 1981. If the bereaved parent is able to form an effective therapeutic alliance, antidepressants usually are not necessary, because considerable symptomatic relief is generally achieved with short-term psychotherapy. In the presence of immobilizing depression or suicidal risk, antidepressants may be needed. With the increased use of selective serotonin reuptake inhibitors, example Fluox perinatal loss 163 etin, sertraline, and paroxetine, causing fewer side effects, antidepressants are increasingly being prescribed for depressive reactions associated with bereavement. Antidepressants without regular psychotherapy are not the appropriate treatment for maladaptive grief reactions. Treating pregnancy loss. Whatever the setting, a consultation sets the stage for treating pregnancy loss. Flexibility is crucial both in the number of sessions needed, usually 3 to 6, and whether the partner is included, which is initially based on a client's wish. Consultation balances the tasks of crisis intervention, counseling, and assessment. The first session usually involves the patient telling the story of what happened, not, I would emphasize, a psychiatric interview with history-taking designed to obtain a DSM diagnosis. This approach fosters the therapeutic alliance, facilitates grieving and processing trauma by making the events real for the client and clinician, and highlights what is unique about this loss. The therapist counsels by providing direction as needed, example the importance of sharing feelings with one's partner and explaining the appropriate details to one's children, and almost always by offering reassurance about the normalcy of intense grief, i.e., you're not going crazy. Psychological evaluation clarifies the multiple factors that make this loss so difficult, provides a history, and develops a diagnosis as the consultation progresses. Flexibly structured short-term psychotherapy is usually the optimal intervention for recent perinatal loss. Leon 1987, 1990, 1996a. Even if long-term intensive psychotherapy appears warranted based on significant prior disturbance, clients rarely are prepared to accept that recommendation. They are not seeking characterologic change at this time, are inclined to experience such a recommendation as another narcissistic blow, and need the prospect of short-term relief. Clients are empowered by deciding when they are ready to stop rather than having to submit, helplessly, to a prescribed number of sessions, whether by theoretical design, MAN 1973, or according to the limits of managed care. Usually, one can be optimistic about significant improvement within 3 to 4 months following the consultation. By the end of the consultation, it can be valuable to distinguish to the degree they can be heard the longer-term issues that will not be the focus of these sessions, thereby setting realistic expectations for the treatment. A cardinal principle in treating pregnancy loss is flexibility. All modalities should be considered and a multimodal approach used when appropriate. Although individual work may focus on complicated intrapsychic dynamics, 164 psychological aspects of women's health care, second edition marital work may be crucial in clarifying the different responses to this loss, and family work may promote a safe family atmosphere to grieve. Therapists need to be careful not to usurp the parental role in addressing this loss with children. Having a preferred orientation does not prevent using other approaches when warranted. Cognitive behavioral techniques may be quite effective with specific symptoms, example encouraging systematic desensitization with phobic reactions related to avoiding grief-evoking stimuli. A flexible approach to the frequency of meetings is also helpful. Weekly meetings are the norm, although more frequent sessions on short notice during more emotionally intense times, example anniversaries, are effective, as are less frequent meetings, especially in tracking the extended stresses of infertility treatments or a future pregnancy. The positive therapeutic relationship is not the means but the essence of this work. If a solid alliance cannot be established, the prospects for effective short-term therapy are poor. Grieving is understood not solely as an intrapsychic process but also as an interpersonal transaction. In a sense, this is an adaptive form of projective identification, Hinchelwood 1991, in which the bereaved, overwhelmed by the sadness of her loss, is assisted in expressing and getting through the pain of her grief by its being shared and felt by another. This process demands stable object relatedness in the bereaved, i.e., having basic trust in others, and a willingness by the therapist to participate in a subdued fashion in the grieving. Maintaining an empathic connection is more important than getting it right, i.e., interpretation of unconscious conflicts. Past dynamics are explored only as they influence current loss issues. Transference expression is not encouraged and interpreted only when necessary, i.e., when threatening the alliance. Taking account of subcultural attitudes and religious beliefs, not as stereotypes but as normative contexts from which individual differences emerge, is another important facet of what the loss means to the parent. Challenging the stigmatization associated with some of these losses, example infertility, pregnancy termination for fetal anomaly, adoption counseling, promotes a recognition of the social forces that help shape their impact. Depending on the situation and timing, the therapist may gently encourage or advise against certain actions. Example, it usually does couples no good to exacerbate intense grief by attending baby showers before they are ready or by celebrating major holidays when they feel they have nothing to celebrate. This is not telling them what to do but rather giving them permission to do what they already know is right for them. Terminations vary. Even when the help has been deeply appreciated, perinatal loss 165 endings tend to be more brief and less intense in this work than in more traditional therapies. The therapist will usually have an intuitive sense of a premature, unexpected, avoidant bolting as opposed to a readiness to end soon because the work is drawing to a close. Ironically, although the essence of this work is grieving multiple losses, the loss of the therapist is usually not grieved by the patient but is instead relinquished without much fanfare, as a transitional object loses its significance for the young child once indispensable to her sense of security and well-being, but now expendable. Winnicott 1953. Conclusions: although major advances have been made in the understanding and management of pregnancy loss, more work is needed, especially in appreciating the individual experience of this loss. More case clinical studies are needed to design intervention studies that involve families, fathers, and children as well as mothers. Quantitative measures assessing the multiple dimensions of this loss, such as the Perinatal Grief Scale Toter et al. 1988, are vital in tracking the course and outcome of reactions beyond a uniform model of grieving, Lin and Lasker 1996. Non-clinical studies must go into greater depth than the self-reports found in anecdotal handbooks. All of these approaches broaden our understanding of normal and maladaptive reactions to pregnancy loss, enabling a more individualized approach in hospital and psychologic practice than currently exists. Finally, integrating the impact of subcultural, ethnic, and religious influences on the individual phenomenology of these losses will provide a much-needed anchor in the social realm. References: Affleck G., McGrade B., Allen B., et al., Mothers' Beliefs About Behavioral Causes for Their Developmentally Disabled Infant's Condition, What Do They Signify? J. Pediatric Psychol 10:293, 303, 1985 Alchel S., ed. Childhood Bereavement and Its Aftermath. Madison Court, International Universities Press, 1988 Benedict T., Parenthood as a Developmental Phase. JAM Psychoanal Association 7:389, 417, 1959 166 Psychological Aspects of Women's Healthcare, 2nd edition Benfield D.G., Live Essay, Volman J., Grief Response of Parents to Neonatal Death and Parent Participation in Deciding Care. Pediatrics 62:171, 177, 1978 Butel M., Deckard R., Von Rath M., et al., Grief and Depression After Miscarriage, Their Separation, Antecedents, and Course. Psychosome Med 57:517, 526, 1995 Bibring G., Some Consideration of the Psychological Processes in Pregnancy. Psychoanal Study Child 14:113, 121, 1959 Blumenthal S.J., Psychiatric Consequences of Abortion, Overview of Research Findings, in Psychiatric Aspects of Abortion. Edited by Stotland N.L. Washington, D.C., American Psychiatric Press, 1991, pp. 17-37 Bourne S., The Psychological Effects of Stillbirths on Women and Their Doctors. J.R. Colgen Prac 16:103, 112, 1968 Bourne S., Lewis E., Delayed Psychological Effects of Perinatal Deaths, The Next Pregnancy and the Next Generation. BMJ 289:209, 210, 1984 Bourne S., Lewis E., Psychological Aspects of Stillbirth and Neonatal Death, An Annotated Bibliography. London, England, Tavistock Clinic, 1992 Bowlby J., Attachment and Loss, Vol. 3, Loss. New York, Basic Books, 1980 Brown Y., The Crisis of Pregnancy Loss, A Team Approach to Support. Birth 19:82, 89, 1992 Brown Y., Perinatal Loss, A Framework for Practice. Healthcare Women in 14:469 479, 1993 Bydlowski M., Diane Linzer M., A Psychomedical Approach to Infertility, Suffering from Sterility. J. Psychosome Obstet Gynecol 9:139, 151, 1988 Cardi, Nup S., Grief and Perinatal Loss, A Community Hospital Approach to Support. J. Obstet Gynecol Neonatalness 14:130, 139, 1985 Cecil R., ed. The Anthropology of Pregnancy Loss. Oxford, England, Berg, 1996 A Cecil R., Introduction, An Insignificant Event? Literary and Anthropological Perspectives on Pregnancy Loss, in the Anthropology of Pregnancy Loss. Edited by Cecil R. Oxford, England, Berg, 1996 b, pp 1-14 Cecil R., Memories of Pregnancy Loss, Recollections of Elderly Women in Northern Ireland, in the Anthropology of Pregnancy Loss. Edited by Cecil R. Oxford, England, Berg, 1996 c, pp 179-196 Chalmers B., Cultural Variations in South African Women's Experiences of Miscarriage, Implications for Clinical Care, in the Anthropology of Pregnancy Loss. Edited by Cecil R. Oxford, England, Berg, 1996, pp. 153 to 177. Kleiman R., Green C., Mickelson C., et al. Do parents utilize physician follow-up after the death of their newborn? Pediatrics 64:665, 667, 1979. Condon J.T., The Parental Fetal Relationship, A Comparison of Male and Female Expectant Parents. J. Psychosome Obstet Gynecol 4:271, 284, 1985. Condon J.T., Management of Established Pathological Grief Reaction After Stillbirth. AMJ Psychiatry 143:987, 992, 1986. Perinatal Loss 167. Covington S.N., Theod S.K., Reactions to Perinatal Loss, A Qualitative Analysis of the National Maternal and Infant Health Survey. AMJ Orthopsychiatry 63:215, 222, 1993. CUISC near MCJ, Kuijpers J.C., Hoogdwin Cal, et al., Miscarriage and Stillbirth, Time since the loss, Grief intensity and satisfaction with care. URJ Obstet Gynecol Reprod Bile 52:163, 168, 1993. Cunningham F.G., McDonald P.C., Grant N.F., et al., Williams Obstetrics, 20th edition. Stamford Court, Appleton and Lang, 1997. Cushman Loaf Calmus K., Namero P.B., Placing an Infant for Adoption, The Experience of Young Birth Mothers. SOC Work 38:264, 272, 1993. Dag PKB, The Psychological Sequelae of Therapeutic Abortion, Denied and Completed. AMJ Psychiatry 148:578, 585, 1991. Davis D.L., Stewart M., Harmon R.J., Postponing Pregnancy After Perinatal Death, Perspectives on Doctor Advice. JAM Academic Child Adolescent Psychiatry 28:481, 487, 1989. DeLuca Ma, Leslie P.W., Variation in Risk of Pregnancy Loss, in the Anthropology of Pregnancy Loss. Edited by Cecil R. Oxford, England, Berg, 1996, pp. 113 to 130. Deutsch H., The Psychology of Women, Vol. 2, Motherhood. New York, Gruen and Stratton, 1945. Dickon E., Campbell L., Patty P., The Post-Adoptive Experience of Surrendering Parents. AMJ Orthopsychiatry 54:271, 280, 1984. Dunn D.S., Goldbach K.R., Lasker J.N., et al., Explaining Pregnancy Loss, Parents and Physicians' Attributions. Omega 23:13, 23, 1991. Eoten D.S., A Perinatal Loss Follow-Up Guide for Primary Care. Nurse Pract 18:30, 36, 1993. Fisher S., Gilman I., Surrogate Motherhood, Attachment, Attitudes, and Social Support. Psychiatry 54:13, 20, 1991. Forrest G., Standish E., Baum J., Support After Perinatal Death, A Study of Support and Counseling After Perinatal Bereavement. BMJ 285:1475, 1479, 1982. Friedman T., Gath D., The Psychiatric Consequences of Spontaneous Abortion. BRJ Psychiatry 155:810, 813, 1989. Furman E., A Child's Parent Dies. New Haven Court, Yale University Press, 1974. Furman E., The Death of the Newborn, Care of the Parents. Birth and Family Journal 5:214, 218, 1978. Gilbert K.R., Smart L.S., Coping with Infant or Fetal Loss, The Couple's Healing Process. New York, Brunner/Mosel, 1992. Gilliland V., James R.K., Crisis Intervention Strategies, 2nd edition. Pacific Grove C.A., Brooks/Cole Publishing, 1993. Goldbach K.R., Dunn D.S., Toter L.S., et al., The Effects of Gestational Age and Gender on Grief After Pregnancy Loss. AMJ Orthopsychiatry 61:461, 467, 1991 Graham-Mott, Thompson S.C., Estrada M., et al., Factors Affecting Psychological Adjustment to Fetal Death. AMJ Obstetgynekal 157:254, 257, 1987 168 Psychological Aspects of Women's Healthcare, 2nd edition Greel A.L., Not Yet Pregnant, Infertile Couples in Contemporary America. New Brunswick, New Jersey, Rutgers University Press, 1991 Grub C., Body Image Concerns of a Multipara in the Situation of Intrauterine Fetal Death. Mattern Childness J5:93, 116, 1976 Hannafin H., Surrogate Parenting, Reassessing Human Bonding. Presented at the annual meeting of the American Psychological Association, New York, August 28, 1987 Harmon R., Glicken A., Siegel R., Neonatal Loss in the Intensive Care Nursery, Effects of Maternal Grieving and a Program for Intervention. JAM Academic Child Psychiatry 23:68, 71, 1984 Harris M., The Loss That Is Forever, The Lifelong Impact of the Early Death of a Mother or Father. New York, Dutton, 1995 Helmrath T., Steinitz E., Death of an Infant, Parental Grieving and the Failure of Social Support. JFAM Prac 6:785, 790, 1978 Hellstrom L., Victor A., Information and Emotional Support for Women After Miscarriage. J. Psychosome Obstetgynekal 7:93, 98, 1987 Hersey, Psychological Repercussions of Pregnancy Loss. Psychiatra and 14:454, 457, 1984 Hersey, Perinatal Loss, in Psychological Aspects of Women's Health Care. Edited by Stuart De, Scotland N.L. Washington, D.C., American Psychiatric Press, 1993, pp 139-161 Hinchelwood R.D., A Dictionary of Kleinian Thought, 2nd edition. Northvale, New Jersey, Jason Aronson, 1991 Horowitz, M.J., Siegel B., Holen A., et al., Diagnostic Criteria for Complicated Grief Disorder. AMJ Psychiatry 154:904, 910, 1997 Hunfeld Jam, Volodymyrov J.W., Pasteur J., Prediction and Course of Grief 4 years after perinatal loss due to congenital anomalies, a follow-up study. BRJ Med Psychol 70:85, 91, 1997 Huddy M.H., A Quick Reference Table of Interventions to Assist Families to Cope with Pregnancy Loss or Neonatal Death. Birth 1533, 35, 1988 Ils S., Empty Arms, Coping After Miscarriage, Stillborn, and Infant Death, 2nd edition. Maple Plains, Minnesota, Wintergreen Press, 1990 Ils S., for CB, Development of a Comprehensive Follow-Up Care Program After Perinatal and Neonatal Loss. J. Perinat Neonatalness 2:23, 33, 1988 Jacobs S., Pathologic Grief, Maladaptation to Loss. Washington, D.C., American Psychiatric Press, 1993 Jansen H.J.E.M., CUISC MCJ, Hugdwin K.A.L., et al., Controlled Prospective Study on the Mental Health of Women Following Pregnancy Loss. AMJ Psychiatry 153:226, 230, 1996 Jansen H.J.E.M., CUISC MCJ, DeGraw Ph.M., et al., A Prospective Study of Risk Factors Predicting Grief Intensity Following Pregnancy Loss. ArchGen Psychiatry 54:56, 61, 1997 Perinatal Loss 169 Jeffrey P., Jeffrey R., Delayed Periods and Falling Babies, The Ethnophysiology and Politics of Pregnancy Loss in Rural North India, in the Anthropology of Pregnancy Loss. Edited by Cecil R. Oxford, England, Berg, 1996, pp 17-37 Kellner K., Kirkley Best E., Ches Burrow S., et al., Perinatal Mortality Counseling Program for Families Who Experience a Stillbirth. Death Education 5:29, 35, 1981 Kellner K., Donnelly W., Gould S., Parental Behavior After Perinatal Death, Lack of Predictive Demographic and Obstetric Variables. Obstet-Gynecol 63:809, 814, 1984 Kennel J., Slider, H., Klaus M., The Mourning Response of Parents to the Death of a Newborn Infant. An English J. Med 283:344, 349, 1970 Kirkley Best E., Kellner K., The Forgotten Grief, A Review of the Psychology of Stillbirth. AMJ Orthopsychiatry 52:420, 429, 1982 Kirkley Best E., Kellner K., Laduti, Attitudes Towards Stillbirth and Death Threat Level in a Sample of Obstetricians. Omega 15:317, 327, 1985 Class D, Silverman PR, Nickman SL, eds Continuing Bond/New Understandings of Grief. Bristol PA, Taylor, and Francis, 1996 Klaus M., Jane L. J., Parent-Infant Bonding, 2nd edition, St. Louis, Missouri, C.V. Mosby, 1982 Knapp R., Beyond Endurance, When a Child Dies. New York, Schocken Books, 1986 Kohut H., The Analysis of the Self. New York, International Universities Press, 1971 Lake M., Knuppel R.A., Murphy J., et al., The Role of a Grief Support Team Following Stillbirth. AMJ Obstet-Gynecol 146:877, 881, 1983 Lamb J. M., Share, In Parental Loss of a Child. Edited by Rando T. Sampain, I.L., Research Press, 1986, pp 499-507 Laroche C., Lalinik Michaud M., Engelsman F., et al., Grief Reactions to Perinatal Death, A Follow-Up Study. J. Psychiatry 29:14, 19, 1984 Lasker J. N., Toter L. J., Acute versus Chronic Grief, The Case of Pregnancy Loss. AMJ Orthopsychiatry 61:510, 522, 1991 Lasker J. N., Toter L. J., Satisfaction with Hospital Care and Interventions After Pregnancy Loss. Death Studies 18:41, 64, 1994 Lawson L.V., Culturally Sensitive Support for Grieving Parents. AMJ Mattern Childness 15:76, 79, 1990 Lane L.L., Motherhood Lost, Cultural Dimensions of Miscarriage and Stillbirth in America. Women Health 16:69, 98, 1990 Leifer M., Psychological Changes Accompanying Pregnancy and Motherhood. Janet Psychol Monogram 95:55, 96, 1977 Leon I.G., Intrapsychic and Family Dynamics in Perinatal Sibling Loss. Infant Mental Health Journal 7:200, 213, 1986 Leon I.G., The Invisible Loss, The Impact of Perinatal Loss on Siblings. J. Psychosome Obstet-Gynecol 5:1, 14, 1986 B. Leon I.G., Short-Term Psychotherapy for Perinatal Loss. Psychotherapy 24:186, 195, 1987 170 Psychological Aspects of Women's Health Care, 2nd edition Leon I.G., When a Baby Dies, Psychotherapy for Pregnancy and Newborn Loss. New Haven Court, Yale University Press, 1990 Leon I.G., Perinatal Loss, A Critique of Current Practices. Clin Pediatra 31:366, 374, 1992 Leon I.G., The Psychoanalytic Conceptualization of Perinatal Loss, A Multidimensional Model. AMJ Psychiatry 149:1464, 1472, 1992 B. Leon I.G., Pregnancy Termination After Fetal Anomaly, Clinical Considerations. Infant Mental Health J 16:112, 126, 1995 Leon I.G., Reproductive Loss, Barriers to Psychoanalytic Treatment. JAM Academic Psychoanal 24:341, 352, 1996. A Leon IG, Revising Psychoanalytic Understandings of Perinatal Loss. Psychoanal Psychol 13:161, 176, 1996. B. Leopard PC, PACA BS, Grieving Characteristics After Spontaneous Abortion, A Management Approach. Obstetgynecol 64:119, 122, 1984. Lewis E., The Management of Stillbirth, Coping with an Unreality. Lancet 2:619, 620, 1976. Lewis Th., A Culturally Patterned Depression in a Mother After Loss of a Child. Psychiatry 38:92, 95, 1975. Limbo R.K., Wheeler S.R., When a Baby Dies, A Handbook for Healing and Helping. La Crosse, Wisconsin, Resolved Through Sharing, 1986. Lynn S.X., Lasker J.N., Patterns of Grief Reaction After Pregnancy Loss. AMJ Orthopsychiatry 66:262, 271, 1996. Lindemann E., Symptomatology and Management of Acute Grief. AMJ Psychiatry 101:141, 148, 1944. Laval, Some Questions of Identity, Late Miscarriage, Stillbirth, and Perinatal Loss. SOC Psy-Med 17:755, 761, 1983. Lumley J., Attitudes to the Fetus Among Primigravidi. AUS Pediatric J 18:106, 109, 1982. London T., Morbidity Following Sudden and Unexpected Bereavement. BRJ Psychiatry 144:84, 88, 1984. McGuire D., Skoulikas S., Developing a Bereavement Follow-Up Program. J. Perinat Neonatalness 2:67, 77, 1988. Mamen OK, Women's Reaction to Perinatal Loss in India, An Exploratory, Descriptive Study. Infant Mental Health J 16:96, 101, 1995. Mann J., Time-Limited Psychotherapy. Cambridge, Mott, Harvard University Press, 1973. Mason Mott, From Father's Property to Children's Rights, The History of Child Custody in the United States. New York, Columbia University Press, 1994. McLaughlin S.D., Pierce S.D., Mannanen D.L., et al., To Parent or Relinquish, Consequences for Adolescent Mothers. SOC Work 33:320, 324, 1988. Menning B., Infertility, A Guide for the Childless Couple, 2nd edition. New York, Prentice Hall, 1988. Perinatal Loss 171. Mishny J.M., Clinical Work with Adolescents. New York, Free Press, 1986. Murray J., Callan V.J., Predicting Adjustment to Perinatal Death. BRJ Med Psychol 61:237, 244, 1988. Neugebauer R., Klein J., O'Connor P., et al., Depressive Symptoms in Women in the 6 Months After Miscarriage. AMJ Obstetgynecol 166:104, 109, 1992. Neugebauer R., Klein J., O'Connor P., et al., Determinants of Depressive Symptoms in the Early Weeks After Miscarriage. AMJ Public Health 82:1332, 1339, 1992. B. Neugebauer R., Klein J., Shroud P., et al., Major Depressive Disorder in the 6 Months After Miscarriage. JAMA 277:383, 388, 1997. Nicole Mount Tompkins Jr., Campbell N.A., et al., Maternal Grieving Response After Perinatal Death. Med J. Ost 144:287, 295, 1986. Park C.M., Bereavement Counseling, Does It Work? BMJ 281:3, 6, 1980. Park C.M., Bereavement. BRJ Psychiatry 146:11, 17, 1985. Peppers L., Knapp R., Motherhood and Mourning, Perinatal Death. New York, Praeger, 1980. Phipps S., The Subsequent Pregnancy After Stillbirth, Anticipatory Parenthood in the Face of Uncertainty. Int J Psychiatry Med 15:243, 264, 1985 Pines D, Pregnancy and Motherhood, Interaction Between Fantasy and Reality. BRJ Med Psychol 45:333, 343, 1972 Pines D, Pregnancy, Miscarriage, and Abortion, A Psychoanalytic Perspective. Int J Psychoanal 71:301, 307, 1990 Pragerson H.G., Beerhals A.J., Castle S.V., et al., Traumatic Grief as a Risk Factor for Mental and Physical Morbidity. AMJ Psychiatry 154:616, 623, 1997 Raidstad I, Norden C., Steeneck G., et al., Stillbirth is no longer managed as a non-event, a nationwide study in Sweden. Birth 23:209, 215, 1996 Raidstad I, Steeneck G., Norden C., et al., Psychic and Social Consequences of Women in Relation to Memories of a Stillborn Child, a Pilot Study. Gynekologstedt Invest 41:194, 198, 1996 B. Rando T., An Investigation of Grief and Adaptation in Parents Whose Children Have Died of Cancer. J. Pediatric Psychol 8:3, 20, 1983 Raphael B., The Anatomy of Bereavement. New York, Basic Books, 1983 Rosenthal M., Adolescent Pregnancy, in Psychological Aspects of Women's Health Care. Edited by Stuart De, Scotland NL. Washington, D.C., American Psychiatric Press, 1993, pp 97-114 Rubin S., Maternal Attachment and Child Death, on Adjustment, Relationship, and Resolution. Omega 15:347, 352, 1985 Rynearson E., Relinquishment and Its Maternal Complications, a Preliminary Study. AMJ Psychiatry 139:338, 340, 1982 Savage OMN, Children of the Rope and Other Aspects of Pregnancy Loss in Cameroon, in the Anthropology of Pregnancy Loss. Edited by Cecil R. Oxford, England, Berg, 1996, pp 95-109 172 Psychological Aspects of Women's Health Care, 2nd edition Shepper Hughes N., Social Indifference to Child Death. Lancet 337:1144, 1147, 1991 Schmulker I., Agan B.P., The Terror of Surrogate Motherhood, Fantasies, Realities, and Viable Legislation, in Gender in Transition, A New Frontier. Edited by Offerman Zuckerberg J. New York, Plenum, 1989, pp 235-248 Schreiner R., Gresham E., Green M., Physician's Responsibility to Parents After Death of an Infant. AMJ Dischild 133:723, 726, 1979 Sheckman K.W., Motherhood as an Adult Developmental Phase. AMJ Psychoanal 40:273, 281, 1980 Smith A., Borgers S., Parental Grief Response to Perinatal Death. Omega 19:203, 214, 1988 Sobo E.J., Cultural Explanations for Pregnancy Loss in Rural Jamaica, in the Anthropology of Pregnancy Loss. Edited by Cecil R. Oxford, England, Berg, 1996, pp 39-58 Stack J., Reproductive Casualties. Perinatal Press 631, 36, 1982 Stainton M.C., Parents' Awareness of Their Unborn Infant in the Third Trimester. Birth 17:92, 96, 1990 Stone L.R., Pregnancy Losses, in Primary Care of Women. Edited by Lemke D., Pattison J., Marshall L. Norwalk Court, Appleton and Lang, 1995, pp 531-539 Swanson Kaufman K., Caring in the Instance of Unexpected Early Pregnancy Losses. Top Clinics 837, 46, 1986 10 NH, Affleck G., Gershman K., Self-Blame Among Parents of Infants with Perinatal Complications, the role of self-protective motives. J. Pers. SOC Psychol 50:690, 696, 1986 Theod S.K., Peterson Fott, Zaslow M.J., et al., Perinatal Loss and Parental Bereavement. AMJ Psychiatry 146:635, 639, 1989 Theod S.K., Zaslow M.J., Rabinovich B., et al., Resolution of Parental Bereavement After a Perinatal Loss. JAM Academic Child Adolescent Psychiatry 29:521, 525, 1990 Tozer, L.J., Lasker J.N., Al-Hadef J.M., The Perinatal Grief Scale, Development and Initial Validation. AMJ Orthopsychiatry 58:435, 449, 1988 Tude Hope D., Iredell J., Rogers D., et al., Neonatal Death, Grieving Families. Met J. Ost 144:290, 292, 1986 Turco R., The Treatment of Unresolved Grief Following Loss of an Infant. AMJ Obstetgynekal 141:503, 507, 1981 Vance J.C., Foster W.J., Nauman J.M., et al., Early Parental Responses to Sudden Infant Death, Stillbirth or Neonatal Death. Met J. Ost 155:292, 297, 1991 Vance J.C., Nauman J.M., Thirl M.J., et al., Psychological Changes in Parents 8 months after the loss of an infant from stillbirth, neonatal death, or sudden infant death syndrome, a longitudinal study. Pediatrics 96:933, 938, 1995 Videka Sherman L., Coping with the Death of a Child. AMJ Orthopsychiatry 52:688, 698, 1982 Folken v. Typical Findings in Pathological Grief. Psychiatric Q44:231, 250, 1970 Perinatal Loss 173 Wembarashi Jar, Explaining Pregnancy Loss in Matrilineal Southeast Tanzania, in the Anthropology of Pregnancy Loss. Edited by Cecil R. Oxford, England, Berg, 1996, pp 75-93 Wilson A., Sol D., The Role of a Self-Help Group in Working with Parents of a Stillborn Baby. Death Education 5:175, 186, 1981 Winkvist A., Water Spirits, Medicine Men, and Witches, Avenues to Successful Reproduction Among the Abalam, Papua New Guinea, in the Anthropology of Pregnancy Loss. Edited by Cecil R. Oxford, England, Berg, 1996, pp 59-74 Winnicott D.W., Transitional Objects and Transitional Phenomena. Int J. Psychoanal 34:89, 97, 1953 Worden J.W., Grief Counseling and Grief Therapy, A Handbook for the Mental Health Practitioner. New York, Springer, 1982 Wordman C., Silver R., The Myths of Coping with Loss. J. Consult Clin Psychol 57:349, 357, 1989 Ziana C.H., Adaptation Following Perinatal Loss, A Critical Review. JAM Academic Child Adolescent Psychiatry 28:467, 480, 1989 Ziana C.H., Keener M., Stewart L., et al., Prenatal Perception of Infant Personality, A Preliminary Investigation. JAM Academic Child Psychiatry 24:204, 210, 1985 Ziana C.H., Daly J., Rosenblatt M., et al., Do Women Grieve After Terminating Pregnancies Because of Fetal Anomalies? A Controlled Investigation. Obstetgynekal 82:270, 275, 1993 Ziana C.H., Danis B., Hirschberg L., et al., Initial Adaptation in Mothers and Fathers Following Perinatal Loss. Infant Mental Health J. 16:80, 93, 1995 Zelizer V.A., Pricing the Priceless Child, The Changing Social Value of Children. New York, Basic Books, 1985 Zizuk S., Duvall R., Unresolved Grief. AMJ Psychoanal 45:370, 379, 1985.